Hello. Hello.
चालू तू ज्वाइन थियो बटे असिराज 2020
डॉक्टर निर्मल गर्ग
When he went and became a monk, and he came back, and then he again applied to the same.
बेटा मैं क्लास में चलाऊं।
के दूसरे ब्लॉक नहीं लाओ।
गुड मॉर्निंग।
गुड मॉर्निंग सर।
हाँ क्या हाल है
सर बढ़िया।
और थोड़ी जुड़े कोई?
हाँ नहीं सर, हैं काफी लोग बाग हैं।
अच्छा फिर ठीक है, एक मिनट।
हाँ मैडम है, ये जो पार्टिसिपेंट है इनमें भी अमृत कौर है, अरविंद मोहन है।
ठीक 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 है।
ये एसीराज के नाम से तो मैं
मैम गुड मॉर्निंग।
गुड
परवा मैम
मॉर्निंग।
गुड मॉर्निंग।
गुड मॉर्निंग। गुड मॉर्निंग।
मॉर्निंग मैम।
हाँ गुड मॉर्निंग।
मैम अभी जो अपन स्टार्ट करेंगे ना,
इंट्रोड्यूस कर दो।
हाँ तो वही तो मैं, हाँ जैसे टाइम हो, अभी मैम टाइम है उस टाइम इंट्रोड्यूस कर देते, जैसे टाइम हो के तुरंत 1 मिनट में इंट्रोड्यूस करके स्टार्ट करवा देते।
हाँ हाँ हाँ
जी
बिल्कुल
मैम।
वही करना है। ओके
राजेंद्र,
हाँ मैम, हाँ सर।
हाँ, इसमें एक काम करना है कि जैसे
हाँ।
जो आपके पास सीक्वेंस है ना, उससे बुलाते जाना।
ठीक है सर।
और टाइम का हिंट रुपेश जी आपको दे देंगे जैसे ही कंप्लीट होने लगेगा, मान लो ज्यादा भी चले तो।
5+1 दे रखा ना सर,
हाँ,
खत्म
ठीक
होने
है
वाला
सर,
था।
ठीक।
5+1 को बोल देंगे जैसे खत्म होने वाला होगा।
हाँ, और उनसे फिर लास्ट में एक दो क्वेश्चन और कर लेना। आपको एक तो इनवाइट करना है उनको, 1 बाय 1
ठीक है।
कर लेना जैसे, और लास्ट में थैंक्स।
ठीक
और
है।
बाय द वे कोई स्टूडेंट नहीं हो तो उससे नेक्स्ट को कॉल कर लेना।
हाँ ठीक है सर।
और लास्ट में यदि वो तब तक इससे वो जुड़ जाता है तो वो
उसको कर लेंगे
तुम्हारे
ना
ऊपर
सर,
है,
ऐड
तुम
कर
चाहो
लेंगे।
तो उसका प्रेजेंट करा सकते हो, चाहो तो नहीं करा।
हाँ सर, अगर ऐड हो जाता है टाइमली तो
ये
उसको
है।
ऐड कर देंगे। हाँ
हाँ, टाइम रहे तो सही है बस।
ठीक है। हाँ
तो अभी जैसे ही रुपेश जी, टाइम क्या हुआ, कितना टाइम है ये बताओ।
सर,
सर
अभी
अभी
टाइम हुआ
9:50 हुआ है।
2:50, 10 मिनट और।
हाँ तो ठीक है, 10 मिनट अपन अभी 10 मिनट के अंदर, उस टाइम जैसे ही टाइम होगा उससे 2 मिनट पहले बता देना, तो अपन
ठीक है।
फॉर्मल इंट्रोड्यूस करके और फिर स्टार्ट कर लेंगे।
अच्छा,
ओके सर,
इंट्रोडक्शन
ओके।
क्या आप रहोगे सर, आप कराओगे मैडम
मैं
वगैरह
बोल दूंगा, फिर तेरे को टेक ओवर करना पड़ेगा, फिर आप बुलाते रहना।
मैं इनवाइट कर लूंगा फिर पार्टिसिपेंट को।
हाँ, पार्टिसिपेंट्स वो सारा इनवाइट आपको ही करना है, मेरे को तो केवल कि भाई
मैं
अपन जस्ट ओवरव्यू कि अपन कॉन्फ्रेंस कर रहे हैं, ये है आज पेपर प्रेजेंटेशन है, कल बस वो एक जस्ट फॉर्मल 1 और 2 मिनट।
ठीक है सर।
ठीक है, ओके।
ओके।
Dr. Jagdish, good morning. Good morning. Good morning, Dr. Manor. Please check your audio. Just unmute yourself and just check your audio. Rupesh ji,
यस मैम।
check everyone's audio.
मैम, एक डॉक्टर जेपी चौधरी सर, एक डॉक्टर मनोहर धवन, दोनों
हाँ,
के ऑडियो में
check,
प्रॉब्लम है।
check their audio. Check the audio.
नो डॉक्टर मनोहर ऑडियो इज अवेलेबल।
Hello, sir.
Good morning.
Good
Dr.
morning.
Prabha this side.
Good morning.
Good morning. It's the new beginning for the new festive season today. Yeah. Thank you.
One of the candidate is showing name ASIRAJ. May I know the name, please?
रुपेश जी, मैं हूं प्रदीप।
सर नाम मैं आपका ही कर रहा हूँ, प्लीज।
रुपेश जी,
ओके सर, ओके।
इसको तो मैं चालू करूँ, चालू हो जाएगा यहाँ से।
मेरा तो मेरे को बोलना पड़ेगा ना.
Dr. Bhavar, start.
Ma'am, start now.
Yes. Start.
हेलो.
हेलो.
हाँ दवा साहब, क्या हाल है?
बस ठीक है सर. गुड मॉर्निंग.
गुड मॉर्निंग, गुड मॉर्निंग. तो स्टार्ट करते हैं, चलो.
ठीक है सर. लेट्स स्टार्ट.
Good morning, respected chairpersons, delegate, dear students. Today we start our web, our state chapter conference on web platform first time, and we are holding our conference in the adverse time when the corona pandemic is on its peak, but we are trying our best to do best in this adverse time. So today the only session for the paper presentations, which are only for the residents, which may include non-competitive as well as competitive papers. So I welcome all the chairpersons and the participants, including our and hope you will benefited by this conference, and also you will get your certificate of participations with presenting paper from your own residence or from your home without going to the as in the offline conferences. So we are trying our best. So, and today is also the Saradiya Navratra, day first of the Navratra. So I also bow my head to Ma Durga to help us and to give strength to fight this corona pandemic. So now over to the chairpersons. Please invite the one by one students for presenting paper and proceed further. Now over to chairperson.
Thank you very much. I welcome all delegates and all participants, and thank you very much for making us a judge in this event and in the starting of this event. I invite on behalf of organizer, first participant, whoever is online, please begin your session.
Yes, Dr. Akash Patel.
Good morning, sir.
Good morning.
Sir, shall I start?
Yes.
Okay. Good morning, everyone. I am presenting this paper based on my study of patients having chronic limb wounds, chronic as well as traumatic, post-traumatic, and post-debridement wounds, in which I attempted VAC therapy, vacuum dressing. I am third year resident from BJ Medical College, Ahmedabad. Wound healing is a complex dynamic process, and delayed wound healing or conversion to non-healing wound leads to increased morbidity in terms of increased length of hospital stay and overall treatment cost. Amongst the various treatments available for wound healing, vacuum assisted closure has proven efficacy in enhancing wound healing and for the treatment for chronic non healing wounds, diabetic foot wounds, and venous ulcers and pressure sores. It is also known as negative pressure wound therapy. The aim of the study is to evaluate the functional outcome of vacuum assisted closure dressing therapy for management of raw areas, and the objective was to apply such negative pressure wound dressing in traumatic as well as non-traumatic upper limb and lower limb raw areas. So in this study, total of 30 patients, this was a prospective study, and 30 patients were selected with large upper limb, lower limb raw areas. The definition of large, I would consider here having more than 10 centimeter area length in greatest dimension, length or breadth in any dimension. In our hospital, a civil hospital, from over a period of 8 months, ranging from May 2019 to December 2019, and the age range was 18 to 70 years. 21 patients were male, 9 patients were female. KCI system, KCI VEC system dressings were applied to the raw areas after debridement or amputation, or in those with the chronic non-healing ulcers. We kept maximum of 5 dressings, 5 VEC dressings to be applied, so that the cost does not increase too much. Patients having diabetic foot and chronic venous ulcers were also included in the study. There were no patients less than 80 years of age included from in the study. Abdominal trunk as well as perineal wounds were excluded. So VEC dressing was applied after removing the previous dressing, after thorough saline wash, standard foam, then over standard foam dressing, and between 2 layers of foam, negative suction for negative suction, Ryle's tube was kept, and it was connected to KCI vacuum device. It was our criteria was 1 hour of suction, 1 hour of vacuum, and then 1 hour of rest. And we kept the dressing for 48 hours. We changed every 48 hours. So the results were outcome of the patient. In terms of outcome, 12 patients underwent split thickness grafting, 5 patients underwent flap closure, so by tertiary intention. 7 patients had healing by secondary intention. 6 patients had to undergo redebridement or amputation. And number of VEC dressings I have described. 2 patients required only 1 VEC dressing. They were post-traumatic wounds. 5 patients required 2 VEC dressings. 14 patients required 3 VEC dressings before split thickness grafting or closure, and 8 patients required 4 dressings. Only 1 patient required 5 VEC dressings. So average number of dressings we required in the patients were 3 dressings. This is one of the patients with BK amputation stump. After second VEC dressing, after second VEC dressing, we took this patient for STJ. So the optimum level of negative pressure that is proven that is to be used in case of VEC therapy is minus 125 negative pressure, and the range is usually minus 75 to minus 125. The mechanism of action that is thought to act here is it promotes granulation tissue formation, it stimulates localized blood flow, it prevents colonization of bacteria, it provides moist environment for healing, it reduces localized edema, it enhances epithelial migration, applies uniform negative pressure so that wound contraction is promoted. So I conclude that VEC dressing, it enhances wound healing by increasing vascularity and decreasing time to development of granulation tissue. It reduces length of hospital stay. It enables early recovery and reduces overall treatment cost of the patient. So VEC dressing prepares the wounds for closure through split skin grafting or secondary closure in short time, leading to less overall morbidity with decreased hospital stay.
Nice presentation, doctor.
Thank you, sir.
Your sample size is very less. I think 30 is not adequate. Have you ever tried on bad sore ulcers?
No, sir, I have not tried this on bed sore also.
Okay. And
I
what are
think
the
this
complications of
therapy is
what
best
therapy?
for the bad sore.
Sorry, sir, I could not get. Sir,
Yes, Dr. Bugalia.
Yes, sir. What are the complications of VEC therapy?
Complication of VEC therapy is that in heavily exudative wounds, it may increase bacterial contamination. Heavily exudative wounds.
And in which cases we don't apply VEC therapy?
In patients patients already having contaminated wounds or having slough.
Okay. Yes, sir.
Dr. JP, you may ask anything. Okay, nice presentation. The next one.
Dr. Amrit Kumar.
Yes, sir. Yes, sir.
Please. Share your screen, please.
Yeah. 1 second, sir. लॉक कर दिया तुम लॉक किया स्क्रीन
Slide view.
Yeah, 1 second, sir. It's so myself, Dr. Amrit Kumar, and I'm going to present a paper on diagnosis of H. pylori using the rapid urease test in patient with dyspepsia. The aim of the study is to study the prevalence of H. pylori in patient with dyspepsia undergoing upper GI scopy with rapid urease test. H. pylori is an important human pathogen involved in the pathogenesis of atrophic gastritis, gastroduodenal ulcer, gastric cancer, mild lymphoma, idiopathic thrombocytopenic purpura, iron deficiency anemia, and vitamin B12 deficiency. H. pylori is not a commensal in that the infection always causes gastric mucosal inflammation and damage. The basic lesion is a progressive mucosal inflammation which may result in a pre-neoplastic atrophic changes. A number of methods of H. pylori infection have been developed, and there are generally grouped as being invasive, meaning that they require gastric tissue or mucus, or non-invasive, requiring only blood, breath, or stool for analysis. Here we discuss the rapid urease test, which is an invasive test in that it requires sampling of gastric mucosa. The test provides an indirect evidence of infection by identifying the presence of non-mammalian enzymes such as urease in the gastric mucosa. I have taken 25 cases of dyspepsia studied clinically over the period of 6 months from May 2019 to October 2019. They were subjected for upper GI endoscopy under the topical anesthesia, during which 2 biopsy from each from the pathological area was taken. Biopsy specimen were immediately inoculated on RUT test kit. Positive test for H. pylori was indicated by change in color of the medium from yellow to pink or red. The urease test has a sensitivity of 90 to 95% with the specificity 80 to 90%. The histological diagnosis of H. pylori have a sensitivity of 88 to 95 with the specificity of 95 till 95%. Out of 25 patients, 22 patients were diagnosed to have a H. pylori. The rapid urease test is a popular diagnostic test in that it is a rapid, cheap, and simple test that detect the presence of urease in or on the gastric mucosa. The sensitivity and specificity are generally high, and the many versions have been approved for use in human. Best results are obtained if the biopsy were obtained from both antrum and the corsum of the stomach. False positive results are rare if the RUT contains an antibacterial agent to prevent the growth of urease containing contaminant, and the tests are discarded at 24 hours. The use of antimicrobial drugs and proton pump inhibitor as well as the presence of intestinal metaplasia may result in the false negative result. The RUT is an indirect test for the presence of H. pylori based on the presence of urease. It has an advantage over serology in that it detects only the presence of active infection. The test requires the sample of gastric mucosa or mucus that is added to a tube, gel, or other device, which brings the sample into contact with the urea, a method to detect the products of urea hydrolysis such as ammonia and carbon dioxide. Different tests have been developed to assess the presence of gastric urease activity and have been based on the probably every possible component of the reaction, including those that assess the changes in the label CO2 in serum or breath ammonia, and the pH change induced by the ammonia, either as a color change or directly using a pH meter. A positive rapid urease test require approximately 10 to power 5 H. pylori in the biopsy sample to change the color using an agar-based test. The first requirement is that the biopsy sample must come from a site where the organism is present. Two sample, one from the antrum, avoiding the areas of ulceration and the obvious intestinal metaplasia, and one from the normal appearing corpus are sufficient, provide the highest yield. Commercially available RUT kits suggest that the decision be made within 24 hours. The time the test turn positive depend on the concentration of bacteria and the temperature. Most will turn positive within a 120 to 180 minutes, but it is best to hold those tests to appear negative for 24 hours. After 24 hours, the test may turn positive from the presence of non-H. pylori urease containing organism such as Proteus, Klebsiella, and Bora. Positive result after 24 hours are most often false positive and should not be used as a treatment decision. It is a RUT test kit. It contain a media which is yellow in color. If organism is present, yeah, H. pylori enzyme urease is present, it changes color to pink or red. Clinical interpretation of RUT result. The
10 seconds left.
Hello. The RUT, like any diagnostic tag, depends in the part of pre-test probability of an infection. Thus, in a patient with a duodenal ulcer, a single positive RUT will be considered confirmatory of the diagnosis, whereas a negative test would need to be confirmed by the result of the another test, such as histology. It has also been recommended that RUT should not be used as a sole arbiter of the result of H. pylori eradication therapy, because sensitivity of RUT is not 100%, and thus a negative test does not fully exclude the presence of an active infection. On conclusion, in this study, we found that H. pylori was consistently associated with gastritis and diagnosed early by rapid urease. So RUT test with endoscopy can be used as a primary diagnostic test for dyspepsia, and treatment can be started accordingly, but it is not a gold standard test.
Hello.
Yes, sir.
Is there any relevancy of a H. pylori test in India where 70% population is lower economic status and they will get infected reinfected again? What is the relevancy?
Sir, since there is 70% in the prevalence in India, but sir, H. pylori regimen contain multiple drug regime, which include two of the antibiotic and PPI.
I'm agreed. I'm agreed with ampicillin and chlorpromazine or metronidazole with PPI 2 times. I'm agreed with your regime. But what is the relevancy? What is the while the chance of reinfections are lots of there, and we are from the lower economic status, we don't get the distilled water or sterile food every time because our pupils are illiterate, and 70% of people are coming from lower economic status. So what is relevancy of in Indian context? What is the relevance?
Sir, relevance is so H. pylori. If we do a H. pylori eradication therapy, there will be less over-the-counter abuse of the antacid, which is presently, sir, going on, sir. Each and every patient, sir, with the presenting with gastritis, they take antacid preparation such as PPI or H2 blocker for continuous time, such as 6 months or 1 year. There is no time period for that, sir. If we eradicate a therapy, the symptomatic relief will be for longer time period. So we can prevent the antacid abuse from sir using H. pylori kit and diagnosis.
PPI use or antacid?
Sir, both, sir. The antacid abuse and PPI abuse
So your
over the counter use.
aim of your study is to decrease the burden of PPI's cost on
Yes, sir.
society.
The over counter abuse can be decreased if we diagnose HP H. pylori early, and we can start the therapy as soon as possible, sir.
Okay,
Dr.
maybe
Amrit, what is cost of this RUT kit and what is cost of anti-H. pylori kit?
Sir, and sir, I actually don't know the anti-H. pylori kit price, sir, but sir, the HP RUT kits, sir, RUT kit actually came in the package of 25. A single slide cost nearly about 100 to 200 rupees, sir.
When you did the study, you didn't ask anybody to say the cost of this kit?
Sir, actually, these kits are, sir, available in our institute by medical pharmaceutical free of cost, sir.
So how can you calculate the cost, overall cost burden on the patient?
So patient for this study, sir, patient has to go under endoscopy. So that procedure is going to cost him if it is in going in a private institute near about 1,500 to 2,000 rupees, sir. So if
3,000 to 2,000 to 3,000.
yes, sir. So, if the single RUT kit
Thank
will
you,
run
Dr.
in,
Amrit. Thank you,
yes, sir.
Dr. Amrit. It was a good presentation and a good study.
Okay, sir. Thank you, ma'am.
Next presenter.
Dr. Arvind Mohan Verma.
To the chairpersons, please stick to the time. Try to stick.
Yes, yes, ma'am.
Dr. Arvind Mohan Verma.
Hello. Good morning, sir. Hello.
Good morning. Please share your screen.
Sir,
Okay, can I? Okay.
hello. Good morning,
Yes,
sir.
please.
Carry on.
Sir, good morning, my teachers. Today, I am presenting a study of the validation of the Boyce score in post-operative morbidity and mortality among the patient with perforated peptic ulcer. Aims and background. Perforated peptic ulcer is one of the most common indication for emergency gastrointestinal surgery. Delayed treatment, older age, presence of shock on admission, and comorbidity disease risk factor for prediction of complication and mortality. A delay of the more than 24 hours increase the lethal status 7 to 8-fold with the complication rate by 3-fold. The evolution of the accuracy of Boyce scoring system to predicting post-operative morbidity and mortality in perforated peptic ulcer in correlation with duration of perforation, comorbidity, and preoperative shock. Method. A study was undertaken with 100 diagnosed patients of the peptic ulcer disease to predict the morbidity and mortality using risk stratified Boyce score, risk factor and score. The first factor duration of perforation. The duration of perforation was determined by the time interval between the onset of the symptom to the arrive time in the hospital. If they are less than 24 hours, then score is 0. If more than 24, then score 1. Second risk factor is comorbid disease, including heart disease, lung disease, liver disease, diabetes, renal failure, or any immunocompromised patient. The score is if you are absent, then score 0. If a comorbid condition present, score 1. Third risk factor is a shock.
How much comorbid?
Sir.
No, keep continuing.
Third risk factor is shock. At the time of patient is a hypotensive at time of admission. The shock is determining by systolic BP is 90 mmHg, mean arterial pressure is 60 mmHg. Reduction of the systolic BP more than 40 mmHg of the baseline. If the shock is present, that score is 0. If the shock is the shock is absent, score is 0. If shock is present, is score 1. All the three risk factor criteria we make a score, Boyce score. Boyce score we make a 4 groups. And if you are one risk factor is present, then is group first. If you are if you are no risk factor present, that is group 1 risk factor group 2 risk factor group 3, and 4 risk factor is group 4. Then after all patients with peptic ulcer perforation were treated with exploratory laparotomy through peritoneal lavage and modified gram page repair and placement of drain under general anesthesia. All patient was follow-up SS fortnightly, 14 days, and later 3 monthly. Morbidity was assessed in the term of length of the hospital stay. Post-operative complications such as a breast abdomen, surgical site infection, leak at the repair site, and pulmonary complication, pneumonia, atelectasis, and pleural effusion. After the study, the results were overcome. In your study, 100%, 58% were admitted within the 24 hours on the symptom of the severe abdomen pain, and other 42% admit after 24 hours on the symptom. Comorbid condition in pulmonary complication is COPD 18%, diabetes mellitus is 4%, COPD with diabetes mellitus is 2%, with rest of 75% without any comorbidities. There were 36% patient present with the sign and symptom of shock at the time of the admission, rest of 64% patient without any sign and symptom of shock. In our study, 100% perforated peptic ulcer was more common in male, 92% were male, and younger age group between the 31 to 14 years, and risk significantly increased with the increase of the Boyce score. In chart, the distribution of the patient using Boyce score. All three, in Boyce score, 40% in the Boyce score 0, group first, and 28% are in group second and scored first, and 22% are group score third, score second, or 10% in score third. According to cytopeptic ulcer perforation, intraoperatively finding of the peptic ulcer perforation, 62% patient were pre-pyloric perforation, and then pyloric perforation 26%, and 12% in duodenal of the first part. And after morbidity is compared to in complications. Most common complication is a pulmonary complication like COPD, atelectasis, and 30%. Second most common is a surgical site infection, 28%. And third is a breast abdomen, 20%. And last is leak of the repair site, 6% complete. Morbidity of each age group of the Boyce score. In a Boyce score 0, 4%, 4% population, and score 1 is 12%, score 2 is 14%, score 3 is 8%. Patient are morbidity. And
Arvind?
Yes, ma'am.
Arvind, Dr. Arvind?
Yes, ma'am.
Please show the screen sharing.
Ma'am, time is also over, please.
And time is also over. So conclude.
Conclude your results.
Just a minute. Screen share.
Okay, conclude your results. Don't worry.
Just a minute.
Conclude. Dr. Arvind, conclude your results. Don't worry.
Okay, I understand. And conclusion of my result is the practical performance compromise. One of the most common surgical emergency in poison country, and mortality incidence ranging is 6 to 40%. We imperatively identify the high risk group of the patient, subject them of the risk analysis, planning of the treatment as per need of basic intensive care unit. The prospective study design and 100% of Boyce score. The Boyce score is increased, that complications are also increased. Statistical analysis of post-operative complication, morbidity, mortality of the Boyce score. On your study, found a peptic ulcer percentage is common in male, then female, and pre-pyloric region is most common for the peptic ulcer, and pulmonary complication is the most common or of the complication. Boyce score is a predictive morbidity and mortality is 88% and 84%. as near perfect prediction. And mortality rate was 40%, mortality was 38%.
Thank you, Dr. Arvind.
Thank you, ma'am.
Hello.
Yes, sir.
Respected.
Yes, sir.
What I am asking three things: age, gender, and socioeconomic status. Three things are really important in peptic perforation, especially socioeconomic status. Age and gender are also important. So I think so that this study is biased. It will be better that you should evaluate it by including some more criteria. So it will, otherwise it will be not accepted at all.
Sir, actually, sir, इसमें age का include किया गया age, younger
gender सोशियो-इकोनॉमिक स्टेटस, क्योंकि मोर्टिलिटी पे जेंडर का, सोशियो-इकोनॉमिक स्टेटस का, एज का, इन सब का पड़ रहा है. आपके जो 4 पॉइंट्स आए थे ना, कोमोर्बिडिटी, ये सेप्सिस, शोक और कोमोर्बिडिटी भी उसमें, मतलब आपने सिंगल और मल्टीपल, तो ये थोड़ा सा ऐसे लग रहा है जैसे थोड़ी और रिफाइंड होती तो बेटर होता. ठीक है डॉक्टर अरविंद?
सर एक्चुअली क्या इसमें एज और सेक्स का भी इंक्लूड किया गया है, क्योंकि मेल सेक्स जेंडर को किया गया है. जेंडर मेल इज 92% मेल इज affected of the peptic pulse perforation.
Affected, that is your observation, that is not the scoring included in scoring system. Whatever may be, respected judges, kindly comment. Hello.
Nice presentation, but it was technically poor, and the inclusion criteria were not included, as Dr. Chaudhary has mentioned already. I think we should proceed considering time.
Next,
Thank
Dr.
you.
Ashna. Dr. Ashna.
Yes, sir.
Yeah, please.
प्रेजेंटेशन तो नहीं होता है, मैं करे शो नहीं हो रहा, पता नहीं यार, मेरी वीडियो शो नहीं होती है. प्रेजेंटेशन तो हो रहा था ना, अपना तो हो रहा था, ऊपर लिख तो रहा था. आया था क्या? बीच में मैडम का कुछ हो गया था.
Dr. Ashna.
Unmute.
Good morning, everyone. I am Dr. Ashna Jaggi, first year resident from Mahatma Gandhi Medical College. I am going to present abdominal cocoon as a lump in hypogastrium, a
We
rare
are not able
presentation
to
that
see
is
your
seen.
slides, please.
One second.
Share your screen, Ashna. Share your screen.
Yes, ma'am.
To all other presenters, please keep your PPT open on your screen. Please keep your PPT open.
Taking time.
Or this will be included in your time.
Ma'am, is it visible?
No.
No.
No, the PPT is not here. Another next presenter can present whose PPT is open.
Now
You
Dr. Ashna has started.
Yes,
Please.
okay. Good. Dr. Ashna, you are there.
Yes. I am going to present abdominal cocoon as a lump in hypogastrium, a rare presentation seen. Abdominal cocoon syndrome is total or partial encapsulation of small bowel by fibrocollagenous membrane with local inflammatory forming a lump. Recurrent acute or chronic small obstruction secondary to kinking or compression is a major presenting feature that is seen. A 17-year-old female presented with pain abdomen from past 2 months, vomiting from past 2 months, and a lump that was seen in lower abdomen from past 2 months. Constipation was on and off for a period of 2 months. She presented with a lump that was initially lemon-sized, which gradually progressed to a cricket ball. It was intermittent and regressed when she vomited. We inquired about the past history. in her family, as well as she has taken any LTD before, there was no significant past history. On examination, a lump of 5 into 5 centimeter in the hypogastric region was palpated. It was smooth in surface, soft in consistency. Only upper and lateral margins were palpable. On deep palpation, gurgling sound was heard. We advised the CECT whole abdomen. Dilated bowel loops were seen with fixation of loops and localized fluid collection suggestive of cocoon. We managed the patient by exploratory rhabdotomy for abdominal cocoon with idiolysis and excision of the peritoneal sac. Biopsy was sent. Mesenteric lymph node biopsy was suggestive of tuberculosis. Central necrosis was seen. Patient was discharged on ATT for 9 months. This is a CCT, whole abdomen. We have an axial view as well as a conclusion. Abdominal cocoon causes intestinal obstruction and diagnosis require high index of suspicion because of a non-specific clinical feature. CCT whole abdomen aids in preoperative diagnosis. Peritoneal sac excision and idiolysis is the treatment of choice with satisfactory outcomes. Thank you.
What is the pathophysiology? Pathophysiology of cocoon formation of gut. Am I audible?
Yes, sir.
What is pathophysiology of cocoon formation in small?
So there is enormous thickening of the parietal peritoneum with multiple tiny tubercles seen. Dense adhesions in the peritoneum. Sorry, sir.
Is it always tubercular? Is it right to say that every cocoon is tubercular, or?
So most commonly it is.
Your case was due to tuberculosis. You are saying, right?
Yes, sir. Yes, sir.
Okay. Proceed.
So there is an enormous thickening of the parietal peritoneum with multiple tiny nodules. Dense adhesions can be seen in peritoneum and omentum with content inside as a small bowl, which causes intestinal obstruction most likely. Multiple dense adhesions.
How you diagnosed that it was due to tuberculosis? Was there any COX positive or CB-net positive or anything else, or any non-invasive test before surgery you have done to rule out tuberculosis?
Sorry, sir.
How you confirmed that it was due to tuberculosis, after or before surgery? How you came to know that?
Sir, a cytic fluid tap, we sent for investigation.
What investigation? That's what I am asking. क्या इन्वेस्टिगेशन आपने करवाए तो आपने इसको टीबी बताया मैडम? डॉक्टर साहब,
ADA
एसाइटिक में कितनी वैल्यू एडीए की होती है ट्यूबरकुलोसिस बताने के लिए?
54, sir.
Your 54 or reference range is 54?
Reference line, sir.
Reference range is 35 probably in SIT fluid, 25 in the CSF, and more than 45 in chest pleural tape. I think so that earlier data, new data may be there. But is there any more relevant test is available? More relevant than this? ADA is a supportive. ADA, CRP, ESR, all are supportive, not the definitive. What are the definitive?
So gene expert CB-NAT.
CB-NAT. Why you have not gone for CB-NAT? Why not for CB-NAT? Is it not available at your center? You are from Mahatma Gandhi Medical College. Is
available,
it
sir?
Available? Then why
yes,
you have not gone? Why you have not gone for that? Okay, improve it.
Okay, sir.
Comment from my seniors, please.
Nice presentation, but some improvement. So next,
Dr.
Thank
Ashok Yadav. Dr. Ashok Yadav. Dr. Ashok Yadav.
Hello. Good morning, sir. Am I audible, sir?
Yeah, please share your screen.
Yes, sir.
Dr. Ashok Yadav.
anyone available?
Dr. Asmita Solanki, please.
Sir, I am not able to share my.
Dr. Asmita Solanki,
Yes, sir.
you please share your.
Yes, sir. Is it visible, sir?
Yes, please. Make it slide view.
Oh, good morning, sir.
Morning, proceed now.
Yes. I am Dr. Asmita Solanki from BJ Medical College, Ahmedabad. I am presenting a study of analysis of factor affecting the outcome in cases of head injury. Introduction: outcome prediction after severe head injury is of great clinical importance, especially for the countries like India. Study was undertaken to evaluate the various factors as predictor of outcome in severe head injury. The management of severe head injury patients demand the dedication of the expensive but limited intensive care resources for considerable length of time. And despite of this effort, mortality and morbidity remains the same. In all reported series of significant number of patients, a mortality rate of 30 to 40% was seen. Outcome prediction after severe head injury continues to be an area of interest. My aim is study is to measure the prevalence of various outcome in cases of head injury, to identify the clinical factors affecting the outcome in the patient having head injuries, to find out the CT brain findings affecting the outcome in the patients having the head injuries. In my methodology, this study is based on the prospective analysis of the 100 patient with the traumatic brain injury hospitalized in the emergency department of the general surgery, VJ Medical College, Ahmedabad. After initial resuscitation, they were evaluated and investigated. CT scan was done in all patients, and if any significant operable lesion was found, they were transferred to Department of Neurosurgery and operated upon immediately. Other patients were managed conservatively using ventilatory support, anticonvulsant, and anti-edema drugs. Clinical outcome was evaluated at the time of discharge and at 1 month according to the Glasgow outcome score. Glasgow outcome score: grade 1 suggestive of death of the patient, grade 2 is a vegetative state, grade 3 is mostly dependent patients, grade 4 is minimally dependent, and grade 5 is the good recovery. Glasgow outcome score of 1 to 3 was considered as an unfavorable outcome, and Glasgow outcome score 4 to 5 was considered as the favorable outcome. My subject selection includes inclusion criteria of the patients of head injury came to the emergency surgical department of the hospital, age more than 12 years, patient having solitary head injury and no other organ system involved. The exclusion criteria includes patient with associated severe chest trauma and blunt abdominal trauma. Patients having multiple long bone fractures and severe orthopedic trauma were excluded. Age less than 12 years. Patient leave against medical advice, which prevents the follow-up of them. Patients who were treated on OPD basis and pregnant women. My results is during this study period of 100 consecutive patients of head injury were enrolled, and different factors have been observed and analysis, which includes the epidemiological prognostic factors, various clinical factors, and influence of various CT brain finding. My epidemiological prognostic factors includes the age of the patient and sex, mode of injury, history of alcohol intake, and the time of presentation. The chart showing the 45 patients out of 100 have good recovery after head injury after 1 month. 24 patients having moderate disability. So that means the 69 patients having the favorable outcome, and 19 patients become dead, and 4 to 8 patients fall into Glasgow outcome score 2 and 3 respectively. So 31 patients have unfavorable outcome. Then unfavorable outcome had a statistically significant relation with the age of the patient, in which 60% of the patient with age above 60 years had adverse outcome, which was much higher than 15% in the 12 to 20 year of age group. And then unfavorable outcome have statistically no significant relationship with the gender of the patient as well as the mode of injury. Then distribution of the patient according to the influence of various clinical factors on the neurological outcome, which factors includes history of loss of consciousness, history of vomiting, history of convulsion, history of ear, nose, throat bleeding, Glasgow coma scale, and treatment of the patient. In history of loss of consciousness, 27 patients having no history of LOC. Among them, only 17% having unfavorable outcome compared to the 31% and 48% in the patient having less than 15 and more than 15 minutes of history of LOC respectively. Then distribution according to the Glasgow coma scoring. 30 patients who had GCS 14 or 15 at the presentation, only 16% have unfavorable outcome compared to the 48% which has unfavorable outcome in 26 patients who had GCS 3 to 8 at presentation, and 31% having unfavorable outcome in GCS 9 to 13. Then distribution of the patient according to history of vomiting and the convulsion, which includes among 40 patients who had history of vomiting present, 37% have unfavorable outcome compared to the 27% in whom the history of vomiting was absent, and 50% of the patient had unfavorable outcome in which the history of convulsion was present compared to 24% in which there is no history of the convulsion is present. And then distribution of the patients according to the various CT brain finding and its outcome. The factors includes the midline shift, extradural hemorrhage, subdural hemorrhage, depressed fracture, and diffuse axonal injury, in which the diffuse axonal injury has statistically very high relationship with the outcome. 95 patients who have no diffuse axonal injury have only 26%, 28% favorable outcome compared to the 67% unfavorable outcome, in which remaining 5 patients who have change of diffuse axonal injury in CT or MRI brain. Then depressed fracture of the skull had a statistically significant relationship as outcome, as out of 15 patients who have depressed fracture, 56% have an unfavorable outcome compared to 32% in patient not having the depressed fracture. Then extradural hemorrhage and subdural hemorrhage, unfavorable outcome in 28% patient who have no extradural hemorrhage in CT brain compared to the 55% unfavorable outcome having more than 10 mm EDH. Same way, 22% of the patient having unfavorable outcome in with no subdural hemorrhage, and 57% having unfavorable outcome with more than 10 mm of subdural hemorrhage. So the extradural hemorrhage and subdural hemorrhage have a significant outcome after head injury. My conclusion is majority of the patients were a young male with a road traffic accident. So it can be concluded from this study that strict enforcement of the traffic rules in young generation can help us to save the life by reducing the incidence of head injury. As early patients present to the emergency surgical services, outcomes go more toward the favorable. This study helps us to allocate the areas where emergency medical transportation and referral services are poor, and recommends it bringing at the optimal level. Advanced age, history of loss of consciousness, conversion, and low Glasgow coma score are the clinical factors which affect the outcome in cases of the head injuries. Midline shift, extradural hemorrhage, subdural hemorrhage, depressed fracture of skull are the CT brain finding which affect the outcome of the head injury. This study increase our ability to accurately predict the outcome in cases of head injury and thus to identify the right candidate to utilize the limited resources in our institution. Thank you, sir.
Dr. Smita,
Yes, sir.
what is exclusion criteria of your study?
Sir, my exclusion criteria first is a pregnant female, then age of the child less than 12 years, and patient associated with other major injury, orthopedic injuries, and uh, orthopedic injuries.
Have you mentioned though?
Yes, sir. I have.
In your
Yes, sir. I have mentioned.
Is there any relevancy of pre-hospital care in traumatic brain injury? What is pre-hospital care? In ATLS, advanced trauma life support, in mainly the traumatic brain injuries are very important in those days in road traffic accident.
Yes.
I want to, what is the pre-hospital care? And is there any relevancy to give public some training about the pre-hospital care, because a accident occurs in India and people take water and give sips of water, that you patient is unconscious and they are giving sips of water.
Yes, sir.
What is the relation of pre-hospital care in traumatic brain injury?
Sir,
Okay, no issue.
pre-hospital.
It's nothing. One tricky question, last but not least. What is the GCS3? But how will you define, is it GCS3? There is nothing about Glasgow coma scale differentiate between the death and only 3 criteria. GCS3. What will be the GCS for a dead patient?
Sir, GCS means the patient has no eye opening.
Yeah. In dead patient is same. So what will be GCS? A brain dead is coming to you.
Sir, verbal command is.
Okay, no verbal command is brain dead.
And no motor movements are present, sir.
No motor movement also present in brain dead, but the organs can be used. So how GCS helps to define? Okay, no issue. This is the tricky question for all of us. Thank you. Very nice presentation.
Okay. Thank you, sir. Thank you, sir.
Hello. Hello, Bhamar sir. Hello.
Dr. Ashok Yadav. Dr. Yashok Yadav, are you ready with your presentation?
Ma'am, but I am not able to share my screen, ma'am. Browser is preventing access to my screen.
Access already
Hello,
given.
good morning, ma'am.
Next is Dr. Bansal.
Before we proceed,
Yes, sir.
who's NICSI, please change your name, use your original name. And a request to all the participants, please switch on your cameras while presenting.
Dr. Bansal.
Yes, sir.
Yes.
Yes, sir. Okay. My paper is on role of negative suction drain in subcutaneous plane in exploratory laparotomy, in emergency exploratory laparotomy. Myself, third year general surgery resident at Civil Hospital, Ahmedabad. Surgical site infections, they are classified into incisional and organ space infections, and 4 more are further subclassified into superficial and deep. Superficial, that is limited to skin and subcutaneous tissue. The development of surgical site infection is related to three factors: A, degree of microbial contamination of the wound during surgery; B, the duration of the procedure; and C, host factors such as diabetes, malnutrition, obesity, immunosuppression. Surgical site infection is one of the most common post-operative complications occurring in at least 5% of all the patients undergoing surgery and 30 to 40% patient undergoing abdominal surgery, depending on the level of contamination. Infection complications, they are the main cause of post-operative morbidity in abdominal surgery. Wound infection, the most common form is superficial wound infection occurring within the first week of surgery. Negative pressure provides a moist and protected environment, reducing peripheral edema around the wound, stimulating circulation to the wound bed, decreasing bacterial colonization, increasing the rate of granulation tissue formation, and epithelialization. Study was conducted from January 2019 to January 2020, and patients were randomly selected and divided into two groups. In group A, in which the negative suction drain was placed, and in group B, in which the negative suction drain was not placed. All the patients received the same preparation, that is, surgical field was disinfected by use of povidone iodine, injection cefotaxime 1 gram IV just before the skin incision made with scalpel, and subcutaneous fat dissected with electrocautery, surgical instruments to be exchanged just before the muscle closure, wound irrigated with saline just before the skin closure, and closure of all the abdominal wound with the same technique in all the cases: rectus sheath closed with ethylone loop number 1, subcutaneous closed with Vicryl 20, and skin closed with ethylone 30. Subcutaneous drain was placed along the entire length of the subcutaneous tissue. Use of appropriate Romovec negative suction drain in group A patient. Exit of the drain should be separated from the main wound. Daily observation of the surgical site and drain quantity and content was done in the post-operatively. The drain was removed on the post-op day 3, and collection in the drain was nil, or the collection in the drain was nil. The outcome is measured with the following parameters such as seroma formation, hematoma, pain, surgical site infection, and wound dehiscence. Result of my study is that SSI in the study group is 4%. In group A, only one patient was having surgical site infection, and 24 patients was not having. And seroma formation was 8% in group A, in which the negative suction was placed, and in group B, in which the negative suction was not placed, it was 32%. Wound dehiscence was 4% in group A, and it was 24% in group B. Conclusion: patients undergoing exploratory laparotomy suffer from local wound complications such as seroma, hematoma, wound dehiscence, and surgical site infection. These complications can be reduced with the use of subcutaneous drain to let out the collections in the wound. In our study, we found that patient undergoing emergency laparotomy with subcutaneous drains reduces the incidence of seroma, hematoma, surgical site infection. Only one patient needed intervention in the form of secondary suturing of the wound when compared with the patient without subcutaneous drain, where many patients needed intervention. Also, the hospital stay of the patient with subcutaneous drain is lower when compared with those without subcutaneous drain. Thus, placement of subcutaneous drain in emergency exploratory laparotomy helps in reducing the local wound complications and reducing the hospital stay of the patients, and also aids in the further recovery, which overall affects the total hospital stay of the patient's morbidity, reduces the cost of treatment, and better cosmetic result. Thank you.
Hello.
Hello.
Dr.
Yes,
Bansal.
sir. Yes, sir.
What was the sample size of your study?
Sir, it was 50 patients.
Is it sufficient? Have you discussed with the forensic, preventive and social medicine department of statistics to go through this study?
No, sir.
Do you think so that this type of conclusion you are giving, sample size 50 is more than sufficient? Have you discussed with your statistician how much sample size is needed in such a study? Have you discussed?
Sorry, sir.
No, it's not sorry. It's good to keep it continue.
Okay.
I think so that you should keep continue, because sample size is very larger. Sample size comes very larger in such a study, as I think so. Rest my senior comments, please. Prabha ma'am.
I think P value is insignificant in both groups.
Yeah, that is.
Okay, may conclude the next.
Whatever may be, I have tried.
Sir, Dr. Ashok Yadav is not able to present. So this session is now over, please.
Okay, thank
Thank you.
अभी स्लाइड किसकी दिखाई थी आपने? अशोक कुमार को?
Ashok Yadav.
Sir, I am not able to share my screen. Actually, there is something
बताइए
problem.
क्या आ रहा है आपकी स्क्रीन पे? क्या आ रहा है?
Sir, he is not able to.
Sir, my screen saying your browser is preventing access to your share screen.
तो शेयर स्क्रीन है ना नीचे भाई?
नहीं, इसके ब्राउजर में प्रॉब्लम है।
So let us conclude the session. If he will be able to do it, he will present next time.
In
next session in the day. Okay.
Okay.
जी ma'am.
So,
okay, thank you ma'am.
Thank you all the chairpersons and the
Thanks very much, ma'am.
also.
Thank you very much, ma'am.
Pradeep, please call the next chairpersons. If they are.
Thank you, ma'am.
Dr. Atul Kumar Sharma, sir, Dr. Pankaj Porwal, sir, Dr. Praveen Kumar Joshi, sir, and Dr. KG Sharma, sir.
Yes, good morning, ma'am. Good morning, everyone.
So can we start, please?
Yes.
Yeah, Dr. Bhavdeep Kumar.
Yes, sir.
You please share your screen.
Yes, sir. Okay. Share.
Junior resident दामाद है।
Dr. Bhavdeep, please start.
Okay, sir. Good morning, respected faculties and participants. Myself, Dr. Bhavdeep Kumar Rathod, third year resident doctor in the Department of General Surgery, BJ Medical College and Civil Hospital, Ahmedabad, under guidance of Dr. G.H. Rathod, Professor and HOD. My today's topic of paper is an observational study of risk factors, clinical features, laboratory investigations, and radiological investigations in cases of liver abscess in a tertiary care center. Liver abscess is defined as a collection of purulent material in liver parenchyma. It may be due to bacterial, parasitic, fungal, or a mixed infection. It is a common condition worldwide. Two major types of liver abscess are known, which is amoebic liver abscess and pyogenic liver abscess. Approximately 2/3 of the cases in developing countries are of amoebic etiology, while 3/4 of the cases in developed countries are of pyogenic origin. Amoebiasis is endemic in tropical countries like India due to poor sanitary conditions and overcrowding. And amoebic liver abscess accounts for approximately 3 to 9% of all cases of amoebiasis. The route of infection is mainly fecal-oral. Most common presentation is dysentery. Common causes of pyogenic liver abscess include biliary stone disease, intraabdominal sepsis like appendicitis and diverticular disease. And it has an increased incidence in elderly, alcoholic, and immunosuppressed patients. The diagnosis, treatment, and prognosis of liver abscess have evolved remarkably over past few years. The diagnosis is mainly done by ultrasound or a CT scan, and treatment includes antibiotics and USG guided needle aspiration or percutaneous catheter drainage in uncomplicated cases. So my aims and objective of this study is to evaluate the incidence, risk factors, etiology, and a pattern of clinical features, and laboratory investigation and radiological investigation cases of liver abscess. The present study was a hospital-based observational clinical study carried out in a tertiary care teaching hospital from December 2019 to September 2020. The data was collected from the medical record system of the hospital. A total of 50 patients were enrolled in the study. All the patients with a suspicion of having liver abscess were confirmed on imaging and included in the present study population. The parameters considered in the study were age, sex, symptoms, past history, comorbidities, laboratory investigations, and ultrasonography findings, and interventions done. The data collected were entered in a Microsoft Office Excel sheet and analyzed. So coming on to the results, the total number of patients are 50 with a mean age of 42 years, and the age ranges from 3 to 70 years with male and female ratio of 6:1 in a present study. And the most common age group involved is from 31 to 50 years of age group, which is more commonly involved. Male is 86% are male and 40% are female among the 50 patients. Coming on to the symptoms, almost all the patients were presented with right hypochondriac pain, which is 98%. Fever and nausea, vomiting are also the common symptoms, and jaundice and diarrhea are less common presenting symptoms. 42% patients, which are 21 patients, are alcoholic. Diabetes is the most common comorbidity encountered in the present study, which is 22% in 11 patients. Rest of the other risk factors like history of typhoid, history of appendicitis, and history of jaundice is also present, but that is not that significant. Coming on to the laboratory investigations, all the laboratory parameters, particularly those related with the liver functions, were deranged in a good percentage of patients. Sepsis indicators like total leukocyte count present in about 3/4, which is 72% of the patients. Other parameters are hemoglobin less than 10 in 18 patients. Total leukocyte counts more than 12,000 in 36 patients. INR more than 1.5 in 26 patients. Total bilirubin more than 1 in 34 patients. Direct bilirubin more than 0.5 in 36 patients. SGPT more than 50 in 27 patients. SGOT more than 50 in 20 patients. Alkaline phosphatase in more than 120 in 24 patients. And total proteins less than 6 in 33 patients. Serum albumin less than 3 in 28 patients. Coming on to the radiological findings of liver abscess, according to the number of abscess, the solitary liver abscess was present in 62% of the patients, while the multiple liver abscess was present in 38% of the patients. According to the consistency, 52% patient having partially liquefied abscess, 80% having predominantly liquefied, 60% having predominantly solidified, and 14% having developing liver abscess. Coming to the lobe involved, the right lobe is most commonly involved in 76% patients. Left lobe is involved in 6% patients, and both lobes are involved in 18% of patients. Coming on to the various interventions done, 30% in 30 patients, USG guided aspiration was done. In 10% in 10 patients, pigtail insertion was done. In 3 patients, right-sided ICD insertion was done. It is mainly due to the complication of rupture liver abscess into right-sided pleural cavity, and no intervention done in CYAN patients. It is because of the smaller size of the abscess, which are managed conservatively on IV antibiotics. After total 40% were USG guided aspiration pigtail insertion, out of which encoisos pus was aspirated in 70% of the patient, and purulent pus was aspirated in 30% of the patient. In total study, there is a subcapsular rupture was present in 9 patients, and intrapleural rupture was present in 3 patients. On USG finding, there is typhlitis and colitis was present in 22 patients, which is 44%, and right pleural effusion was present in 90 patients, which is 38%. Most common organism was isolated from blood was Staphylococcus aureus, and from the pus aspirated, it was most common is Staphylococcus aureus, then E. coli and Klebsiella pneumonia. So coming on to the conclusion, male are affected more than females, which in a ratio of 6:1 in present study. Average age of patients was in 40s. Male sex, old age, alcohol intake, and diabetes were the major risk factors for developing liver abscess. Right lobe solitary amoebic liver abscess is more common in the present study. Imaging is the best modality for diagnosis, therapy, and follow-up. USG guided aspiration or pigtail drainage is the standard method of drainage. Pigtail drainage is the better method of treatment than aspiration. Rupture of liver abscess into the peritoneal cavity causes peritonitis, which carries a higher risk of mortality. And all the patients of liver abscess need to be admitted, thoroughly investigated, and managed accordingly. And regular follow-up after discharge is necessary. Thank you, sir.
Hello.
Yes, sir.
Bhavdeep, most common organism was Staph aureus in pyogenic liver abscess. In your study?
Sir, in present study, I have this finding was.
This is quite unusual.
Yes. In a blood culture, sir.
Blood culture organism was Staph aureus. In pus culture of liver?
E. coli, Klebsiella, and Staph aureus.
Most common?
Most common is according to the most of the literature, it is E. coli and then Klebsiella.
In your study.
In my study, first is Staph aureus. In 4 to 5 patients, it was isolated. Staph aureus.
Okay.
Next is Dr. Darshan Parmar.
Hello, Bhavdeep.
Yes, sir.
What are the poor prognostic factor in your study for that it causes more morbidity or mortality in the patients?
First of all, complications like intraperitoneal or intrapleural rupture or subcapsular rupture, which carries a high morbidity and mortality. Other factors are patient is diabetic. It is also affecting its outcome. And alcoholic patient may develop recurrent liver abscess after interventions.
Are there cases of multiplicity of liver abscess?
Yes, sir. Multiple liver abscess.
You haven't mentioned, as if you are saying that it's an observational study.
Yes, sir.
Whether any gas forming abscess are there?
No, sir. It was not encountered in my study.
Okay. So as far as management is concerned, you prefer percutaneous drainage, pigtail, or aspiration?
USG guided aspiration or a pigtail catheter drainage.
No, which one is better, no?
Sir?
Which one is better?
Pigtail drainage is better, sir, because it stays in the cavity for a longer duration, so that it causes complete drainage of the pus. While USG guided aspiration, we can do 2 or 3 attempts only. Multiple repeated.
Can you tell me the condition where we cannot put the pigtail, or it won't be beneficial?
Predominantly solidified abscess.
Yes. Organized sepsis. Thick
Organized.
pus. We cannot aspirate. Okay. Thank you. Nice presentation.
Thank you, sir.
Next is Dr. Darshan Parmar.
Dr. Darshan, please switch on your video camera. Okay, yeah, it's on Deepthi Naik.
Good morning, sir.
Good morning.
Is my screen visible?
Yes, please. Start, please.
Can I start, sir?
Yes.
Am I audible, sir?
Yes,
Yeah.
please.
Hello.
Yes, that's an audible.
Okay. Good morning, sir. Today's my topic is a clinical study on patients of peptic perforation presenting to tertiary care center, sir. Myself, Dr. Darshan Parmar. I'm third year junior resident in Department of Surgery at BJ Medical College and Civil Hospital, Ahmedabad. I've done this study under the guidance of Dr. Rakesh Makwana and Dr. Rajesh Patel. Peptic ulcer disease results from an imbalance between the stomach acid pepsin and mucosal defense barriers. It affects 4 million people worldwide annually. Although 10 to 20% of the patient with peptic ulcer disease will experience the complications, but only 2 to 14% of the ulcers will perforate. The lifetime prevalence of perforation in patients with peptic ulcer disease is around 5%. The perforated peptic ulcer carries a mortality ranging from 13% to 20%. The objectives of my study was to identify and describe the preoperative and intraoperative risk factors in order to identify the ways of optimizing the treatment and to improve the outcome of patients with perforated peptic ulcer. Methodology: all the patients surgically managed for peptic ulcer perforation in the 6-month duration at the tertiary care hospital are included. The association between the patients, the clinical picture, and the preoperative and postoperative factors determining the morbidity and mortality in this group of patients are studied. My duration of my study was from the 1st November of 2018 to 1st May of 2019. Total number of patients were 45. Regarding the sex distribution, all male patients were 39, and out of the female patients were 6 among the distribution, and total mortality among the male patient were 8 and female patient were 4. And regarding the age distribution, all the patients are between the age of 11 to 75 years of age, with large incidence in more than 40 years of the age, with mortality being highest with age increasing above 60 years, which is around 50%. The clinical features: 100 patient presented at the complaint of the abdominal pain. 26% patient had complaint of vomiting. Abdominal distension was present in 13% of the patient, and fever was in 11% of the patient. The constipation was present in 8.8% of the patient. Regarding the examination findings, the generalized tenderness were present in the 100% of the patient, and the guarding and rigidity were present in 80% of the patient. Abdominal distension was present in 13% of the patient, and bowel sounds were absent in 13% of the patient. Regarding the associated factors, various factors, the most common is the smoking. 71% patient had the history of smoking present, and alcohol intake history was present in the 33% of the patient. Other comorbidities were present. Cardiovascular disease were present in 15% of the patient. NSAIDs were present in NSAIDs known case of diabetes mellitus and hypertension present in 6.6% of the patient. Aspirin use, a known case of COPD, known case of peptic ulcer disease and malignancy were present in malignancy and cerebrovascular disease present in 2.2% of the patients. Various complications, the pulmonary complications were 15 out of the 45 patients, which is around 33%. Patient acute kidney injury were present in 8 patients, which is 17%. And 6 patients developed the leak after the first primary surgery, which is 13% of the patient. Out of these 6, 3 patients did undergo reoperation, and there were two mortality among it. One patient developed the post-operative obstruction, and for which a patient was operated. And one patient developed a myocardial infarction post-operatively, and one patient developed hepatic encephalopathy post-operatively. Total mortality was 12 among the 45 patients, which is around 26%. Regarding the various intraoperative and peroperative findings, the first was the ASA grade. ASA 4, 35% patients were in ASA 4 grade, in which mortality is 7%. In ASA 5 grade, 10 patients were in ASA, mortality is 5%, which is around 50%. Regarding the perforation, the 42 patients had perforation in the stomach, and in which mortality was 10 patients. And 3 patients had duodenal first part D1 perforation, which had 2 mortality. Regarding the size of the perforation, and 40 patients had less than 1 centimeter size, in which the mortality was 7 patients, but 5 patients had more than 1 centimeter of the peptic perforation size, in which 8%. Regarding the peritoneal contamination, 6 patients had minimal contamination, in which mortality was nil. 10 patients had less than 500 ml contamination of the peritoneal cavity, in which mortality was around 45%. And in the 13 patient, 3 patient had 3 patient had mortality in peritonitis of 500 to 1 liter, and 16 patient had more than 1 liter of peritonitis and had mortality around 33%. Regarding the operative procedures, for 37 patients underwent the Graham's omentopexy, in which mortality was 9, and 7 patients underwent the omentopexy with feeding jejunostomy, in which mortality
Time over, please.
7. And, conclusion, perforated peptic ulcer disease is common in the old age and associated with higher complication in this age group. Old age, stroke on admission, and associated comorbidities are risk factors for the mortality in patients with peptic perforation. Other factors defining the mortality are the size and site of the perforation and ASA grade. In this study, the duration of presenting symptoms to surgery, time duration was not estimated. Mortality, earlier presenting patient higher mortality, which were attributed to their shock state at present and comorbidity and present acute kidney injury during the admission.
Hello.
Yes.
Duration of presenting symptoms is not important.
In my study, all the 12 mortality, all the 12 presented within the 4 days of their onset of the symptom, and were operated within the 6 to 8 hours of the presentation to the hospital, sir.
Peritoneal fluid amount is important, or consistency, or is exudative or transudative peritoneal fluid is more important. But I mean to say whether amount is important or content of peritoneal fluid is important.
Content is, sir, more important, because in case of peptic perforation, patient will have almost a biliary peritonitis.
You have described amount, which is actually increases with time.
Yes, sir. It increases with time. Always, sir, biliary peritonitis, sir.
Day of presentation to important hai na?
Yes, sir. It is important, but in this study, there was all 12 mortality happened. All 12 patients were presented within the 4 days of the admission. There are patients presented up to 10 days of admission, but the mortality among the mortalities, all the 12 patients presented within the 4 days and were operated within the 6 to 8 hours of the. But the patient presented early also had associated comorbidities like cerebrovascular disease. One patient had liver parenchyma disease.
That death is due to comorbidity, not due to perforation.
And patient were presented had a shock at presentation, and 3 of them had acute kidney injury on admission.
Dr. Darshan.
Yes, sir.
My question is that in how many patients you have did peptic perforation repair along with feeding jejunostomy, and what are the criteria for doing FZ in this? What are the criteria for doing FZ in this patient?
Sir, in case of if the peritonitis is more, sir, patient is having comorbidity, and patient is not nutritionally well. Patient presented after the long time, and duration of the illness is more, and perforation size is if more, and age is more patient. I would incline to do the feeding jejunostomy along with the perforation repair in this type of patients, sir.
And how many patients you have find post-operatively any gastric carcinoma? The patient came with large perforation and you have did FZ and biopsy turned into the malignancy.
In this study, one patient had a malignancy reported, sir.
Okay, Darshan.
Yes, sir.
As if it's a clinical study, do you think the sample size of your study is adequate enough to be claiming it as a clinical study?
No, sir.
As it's a very common condition during the profession, as we have in every day and day out, we have a patient of perforation. So you are having 45 patient study, right?
Yes, sir. 45 patients.
So to claiming it as a clinical study, we should have a large sample size, right?
Yes, sir.
Okay. And the most thing, no one of you who have been presenting from Ahmedabad has been mentioned in the slides that you have taken a approval from your ethical committee, or you've been taken the consent from the patients. Have you mentioned?
Sir,
have you taken the committee approval and the consent from the patient?
Okay. No, sir. It is a retrospective study. And,
okay. So it's been an observational retrospective study rather than a clinical study, right?
Yes, sir. Yes, sir.
So your heading should be corrected.
Yes,
for
sir.
claiming it as a clinical study, we should start prospectively. Okay.
Yes, sir.
Thank you.
Thank you, sir.
Next presentation.
Next is Dr. Dedipya.
Good morning, sir.
Yeah, please share your screen.
Yes, sir. Good morning, teachers. I am presenting prospective. Good morning, sir.
Slideshow.
And your video also. Your camera.
Slideshow.
Yes. Sir, video just stopped due to host. Am I audible, sir?
Yes, yes.
Your screen is not visible, Dedipya. Dedipya, your screen is not visible.
Here mentioned, madam. Yes, madam. Here mentioned the host has asked you to start your. Yes, madam. Good morning, teachers and participants. I am
Slideshow.
Dr. Dedipya.
We cannot see your slideshow.
This one.
Yes.
Go ahead. Go ahead.
Okay, thank you, madam. Good morning, teachers. I am Dr. Dedipechand Shirmali, third year resident, Department of General Surgery, SME Medical College, Bikaner. I am presenting the prospective study of C-reactive protein level in diagnosis of acute appendicitis. Introduction. Acute abdominal pain is a common complaint among emergency department patients. Diagnosis of one of the most common pathologies behind acute abdominal pain, acute appendicitis, has radically changed over the last decade. Traditionally, the diagnosis of appendicitis was made solely based on clinical symptoms and signs, and later diagnosis include result of inflammatory laboratory variables such as leukocytes, neutrophils, and C-reactive protein. This practice in diagnosis led to a false positive diagnosis, negative appendicectomy rates in the range of 15 to 30%. C-reactive protein is a non-specific inflammatory marker that is used routinely in many hospitals in the diagnosis of patient with an acute abdomen. Most studies on the value of C-reactive protein in patients with acute abdomen have focused only on acute appendicitis. Few studies have assessed the diagnostic role of C-reactive protein patients in the broad category of an acute abdomen. An elevated C-reactive protein level, even in isolation, can sometimes generate a cascade of complex investigations that may not necessarily answer of original question about why C-reactive protein was elevated in the first instance. In this study, we correlate the quantitative serum level of C-reactive protein in acute appendicitis. This study emphasized the impact C-reactive protein normal rather than the raised C-reactive protein in reducing the rate of negative exploration. Aim of and objects to study the C-reactive protein level in diagnosis of acute appendicitis. Methods. Study design, hospital-based prospective study. Study duration 12 months. Study place, Department of General Surgery, Sardar Patel Medical College, Bikaner. Sample size 100%. Sampling method, sample random sampling. Inclusion criteria. All the patients who are admitted SC Medical College and associated groups of hospital Bikaner during the study period of diagnosis of acute appendicitis and posted for surgery were included in the study. Patient in the age group 12 to 50 years. Exclusion criteria, children below 12 years and elderly above 50 years was excluded as the C-reactive response is not optimal. Patient was very managed conservatively, or individuals who had undergone appendicectomy for pain abdomen was excluded from this study. Patient was past history of jaundice, sign and symptoms of liver abscess, chronic alcoholic, and with other coexisting acute inflammatory condition were excluded. As C-reactive protein is exclusively produced in liver and raised in acute inflammatory condition. Females taking oral contraceptive pills or pregnant were excluded as C-reactive protein is elevated in these individuals. Patients with appendicular lump, appendicular abscess were excluded. Patients not willing to participate in the study who refused the giving consent. In my study, 36% age group 30 to 20 years and 39% patient 20 to 30 years and 12% patient 31 to 40 years and 10% patient 41 to 50 years and 3% patient were more than 50 years. In study, appendix diameter when 0 to 6 millimeter size and 17 patient examined, and then C-reactive protein level 1.6, mean 1.63, and standard deviation 2.32, and 38% their appendix diameter 6 to 8 millimeter. C-reactive protein 2.89 mean and deviation 3.67. And 39 patients appendix diameter 8 to 10 millimeter. Those C-reactive protein level means 3.6 and standard deviation 3.24 milligram per dl. And 6 patients were 10 to 12 millimeter diameter, mean 3.6 and the standard deviation 2.28, p value 0.001. In this case, my sensitivity result 93.02% and specificity 85.71%, and the projective predictive value 97.56%, negative predictive value 66.67%, diagnostic accuracy 92%. My conclusion: raised serum protein reduce the rate of negative exploration. C-reactive protein values should only be considered in conjunction with other clinical and biochemical parameters, where the combination of one or more of these tests serve better to reach a correct diagnosis. Thank you, sir.
Doctor, you have correlated CRP value with the diameter of appendix.
Yes, sir.
If you can see diameter of appendix on USG, then it is diagnostically already clear. Where is confusion then?
Some patients seriously negative appendicectomy due to increase the C-reactive protein, we can decrease negative appendicectomy procedure.
Where you cannot identify appendix on USG, and in this case, if CRP is elevated,
yes,
then and clinically you think
yes,
it is appendicitis. But you have to confirm radiologically, even it will be increase in Meckel's diverticulitis also.
Yes,
how you will diagnose appendicitis by CRP? As you have already told, na, it is an inflammatory marker.
If diagnostic, yes, sir, inflammatory marker.
Non-specific.
It's non-specific.
Inflammation can be other than appendicitis, na? It could be Meckel's diverticulitis.
Yes,
it
sir.
Could be colitis.
Any infection, any inflammation, any trauma.
So it is basically if the USG, if appendix is not visualized or diameter of appendix is normal, that if still it is CRP is increasing, then it is a sign of inflammation.
Inflammation.
Yes, Dr. Radip. Hello, yes, am I audible?
Yes, sir. Yes, sir.
Yes, sir.
Can you tell me any scoring system which has been included this CRP as a diagnostic criteria for appendicitis? You think it's been a so important parameter for diagnosing appendicitis? Can you tell me any scoring system which has been included CRP? And secondly, you have done this quantitative analysis, right?
Yes, sir. Yes, sir.
So suppose a patient of COVID, as we are having a COVID era, he comes to you with this elevated CRP, with pain and RIF. Do you solely rely upon CRP to diagnose him or her as appendicitis?
No, sir.
So ultimately, you need to rely upon your clinical diagnosis.
Yes,
These
sir.
lab
Clinical and
parameter may suggest you that he or she might have. You are having sensitivity of 92%, 92% specificity. So is that so important parameter for diagnosing appendicitis? As per your study, right? So you are basically augmenting your clinical and laboratory finding with the CRP, right? You cannot solely diagnose on the behalf of CRP.
Yes, sir.
Okay.
Yes.
And the second thing, duration you mentioned 12 months, 10 months. It should never be mentioned like this in the PPT, right? You should mention from this date, this year to this date. Okay. Thank you.
Next presenter.
Dr. Deepak Singh Pawar.
Can you audible?
Share your screen. Dadipya, mute yourself. Dadipya, mute
Good morning, sir. Am I audible?
You are audible, but your screen is not showing. Share your screen.
Ma'am, can I audible now? Can you see my screen, ma'am? Actually, I share my screen.
Slideshow. Your screen is visible, but do it show. Slideshow, please. Hello.
Deepak, press F5 on your screen.
Ma'am, is visible, sir? Is visible, sir?
Not able to see your screen, please.
There is some network issue at your end.
Now it's visible.
Visible, sir.
It is visible. Go to slideshow, which is on top of your screen. Yeah, now it is okay.
I'm audible, sir. Now, can I start, sir?
We cannot see your screen. You have to share your screen.
Can I start, sir?
Deepak, check your network. Your network is not working and we cannot see you. Next, ask the next presenter to present the case.
Dr. Dipti Nayak.
Good morning, sir. Hello, am I audible, sir?
Yes, please. Share your screen.
Sir, I've shared my screen. Is it visible, sir?
Yes, please start.
Good morning, respected faculty and participants. I'm Dr. Deepthi Naik, third year resident under Dr. G.H. Rathod, sir, studying in BJ Medical College, Ahmedabad. And today I'm presenting my study on pattern and causes of major lower limb amputation in tertiary care center. Amputation is derived from a Latin word, amputare, which means to cut. It has been defined as removal of a part or all of the body part enclosed by skin. The most common indication of amputation varies from study to study, and trauma, complications of diabetes mellitus, and peripheral arterial occlusive disease are some of the common indications recorded. Complications of diabetes has been widely accepted as the most common cause, with figures ranging from 25% to 90% depending on the study. The when removing the limb is primarily concerned with saving the life of the patient or getting rid of the diseased or badly injured part of the body. The aim of my study is to outline the pattern, causes, complications of major lower limb amputations among patients at tertiary care center. It is a retrospective study which was done in a tertiary care center in Ahmedabad from July 2019 to December 2019. The data was collected from the medical record system of the hospital, and the parameters which were studied are age, sex, indication of amputation, the level of amputation, and the complications. All patients who underwent major lower limb amputation were more than 18 years of age were included in the study, and patients who were less than 18 years of age and those who underwent amputation from another institute and came to the hospital for follow-up or management of complications were excluded. In case there was a conversion to a higher level of amputation, it was recorded as a revised level. The data that was collected was entered in a Microsoft Office Excel sheet and analyzed. Coming to the results of my study, total 64 major lower limb amputations were performed in the 6-month period. The age ranged from 28 to 76 years, and the average age was 55 years. Out of the amputees, total 87.5% were male and 12.5% were females. Total 47 cases were below knee amputations, out of which 22 were guillotine amputation and 25 were closed flap amputations, and 16 underwent above knee amputation, out of which 2 were guillotine and rest 14 were closed flap, and one of the patient had hip disarticulation performed. Gangrene due to peripheral arterial occlusive disease was the most common indication of amputation in our study, which was found in 34% of the cases, 34 cases total. And 15 cases had underlying complications due to diabetes mellitus. 11 patients had both peripheral arterial occlusive disease as well as diabetes. 3 of the patients had amputation because of trauma, and 1 of the patient had history of something bite over the limb. Infection was the most common complication, involving 24 of the cases, and all the infected stump required debridement with suturing. Then 9 of the patient had gangrenous stump where a revision amputation was had to be performed, and 2 of the cases had wound dehiscence which required resuturing of the wound. The total number of deaths was 18, which was 28% mortality rate. And most of the deaths were due to sudden cardiac arrest due to septicemia. And the duration of hospital stay on an average was 8 days, minimum being 4 days, and maximum was 32 days. The general trend usually is peripheral arterial occlusive disease being the leading cause in developed countries because of the sedentary lifestyle and increased life expectancy. Moreover, males are more prone to risk of peripheral arterial occlusive disease because of smoking and tobacco chewing. And males are also at risk of trauma, especially in developing countries where the male population work outside and they're exposed to accidental hazards. minor amputation can prevent later major amputations, especially in cases occurring due to complications of diabetes, and thus improve the quality of life. So I would conclude by saying that the complications of peripheral arterial occlusive disease and diabetes were the most common indication of limb amputation in our region, and patient education regarding lifestyle modification, that is smoking cessation, exercise, and dietary modifications, and proper control of diabetes and foot care will play a pivotal role in preventing such morbidities. And prosthesis and rehabilitation services will never be good enough to replace any anatomically normal and functional limb. Thank you, sir.
Hello.
Hello, sir.
Dr. Deepti, which type of study you have done? Clinical study, na? Which type of clinical study? It's observational, it's a retrospective, it's a prospective study. Which type of study you have done?
It's a retrospective study, sir.
It's a retrospective.
Retrospective observation study. Yes, sir.
Observation. Okay. The second question is, in how many patients the amputation was done by of failure of your intervention department?
Yes, sir.
How many patients?
So total 64 patients were included, sir.
Total 64 patients. How many patients amputation was done because of failure of intervention by your vascular department?
Haven't.
It's your tertiary center. The many times the patient came from your vascular department with failure of intervention.
Sir, I haven't included that.
Hello.
Yeah, sir, I haven't included that, sir.
You didn't include it.
No, sir.
Yes, Dr. Diti. You said
Yes, sir.
your topic is pattern and causes of major lower limb amputation, right?
Yes, sir.
What do you mean by major lower limb amputation?
Sir, transtibial, sir, below knee amputations and above, sir.
These are major.
Yes, sir.
And what are minor? Is there any classification to divide them between major and minor?
Sir, major amputations are sir, the below knee amputation and sir, above amputations are major amputations.
See the study while you are writing a heading, you are writing a thesis, you are going to be write a
Yes, sir.
research paper later on. So we should not write these vague terms in anywhere in your study. Right? Major lower limb amputation, it's not like a whether you do a specific amputation you should mention. Okay. And the pattern and causes you said, you know? So what are the patterns? I don't find any pattern there in the study. You write in your heading pattern and causes. What are the patterns? Whether you mean pattern by lifestyle of the patients or what the presentation of the patient, what is pattern?
So the most common amputations performed were below knee amputations. And so,
Okay, the pattern of the amputation you did.
yes, sir.
Okay. Whether you done any pharmacotherapy before doing intervention? Any drugs? Pre or post operatively?
No, sir. In case the patient was diabetic and taking anti-diabetic drugs, then those were continued, or whatever previous.
Not any vasodilators or any antiplatelets or thrombolytics like this. You didn't mention any sort of these medication in your study, right?
Yes, sir.
Neither preoperatively, neither post-operatively. Okay, good presentation. Thank you.
Thank you, sir.
Thank you, Dipti. Deepak, you can present now.
Thank you.
Ma'am, can I audible?
No, Be a little louder.
Good morning, ma'am. Now I am audible, ma'am.
Yes, start.
Okay. Good morning, sir. Today I am presenting a clinical study of splenic injury in blunt abdominal trauma. Introduction. Although the protected under the bony rib cage, the splenic remaining is the most commonly affected organ in blunt injury to the abdomen in all age group. Due to the rapid industrialization and urbanization, spleen are at the top of the solid organ listed injury in the blunt trauma abdomen. Motor vehicle accident account for the most of the case of splenic injuries. Study aim and objectives. The aim of the study was know the incidence of splenic trauma, mean of presentation, and graded them. To assess the failure rate of non-operative management of splenic trauma, and to assess the factor responsible for morbidity and mortality. Material and methods. The study was conducted at PBM Hospital, Bikaner, Rajasthan. The 25 patients of splenic trauma of 100% of blunt injury abdomen who are admitted into PBM Hospital. The study was conducted over a span of January 2019 to December 2019. All the patients were first received at casualty department, and general surgery of the patients was done to identify emergency treatment condition. After securing the airway and breathing, an intravenous line are secured. The blood is drawn and sent for routine investigation. A brief history and clinical examination was done. In all case of blunt injury, plain X-ray, erect abdomen, and chest X-ray done, and if necessary, plain X-ray of other part of the body was taken. An emergency ultrasound of abdomen and pelvic cavity of patients was done. Unstable patients are not subjected to ultrasound, and CT scan of the abdomen with or without contrast done for these patients who are stable. The result: total 100 abdominal injuries for 1 year study. The total injury of the splenic trauma is 25. So incidence of the splenic trauma is 25%. And the age of incidence, the maximum number of the patients are in age of group 21 to 30 year of age. In my studies, 40% persons are in between the age group. The mean age of presentation is 28.45 year, and there is no single patient aged more than 60 years. And sex incidence, the male and female ratio is 4:1. The male is 80%, and female is only 20% in our study are affected. The mode of injuries, the about data show the maximum number of the patient presenting injuries due to the road traffic accident. In my studies, out of 25 patients, 18 patients are caused by road traffic accident. And associative injury, out of 25%, the 30% are affected by associative injury, in which the 8 patients had fracture to the various bone of the body, and rest 5% who had the associative injury, in which the 2 patients had laceration on the skin, and rest 3 patients had hemothorax and pneumothorax. The time lapse of admission and surgery. The lapse time of surgery after the admission of the patient was varying from 30 minutes to 11 hours 25 minutes, and the 4% out of 25%, one were operated in within 1 hour. It was actually 30 minutes, and one patients who are operated after the 11 or 25 minutes after admission, and do not respond to resuscitations. The vitals parameter at the admission, the 80%. In study, the 20% presenting with the stable vitals, and 4% are presented with unstable vitals, and 1% presenting with the third pulse and low blood pressure, of which patients died without response on resuscitations. The ultrasounds of the abdomen and pelvic cavity in our series, the 88% patients scan for ultrasound abdomen and pelvic cavity. Of these 22 patients, the pre-operative ultrasound scanning of the abdomen and pelvic cavity was consistent with the CT scan and laparotomic finding in 18%. So the ultrasound sensitivity is approximately 81.81%. The incidence of grade of splenic injury. The most common grade of splenic injury is both grade 2 and grade 3 in our study. The 2 grades constituting 68% of the splenic injury. And management procedure, The in our studies, out of 25 patients, 15 patients are non-operatively managed and 8 patients are operatively managed, and 2 patients are initially managed in non-operatively, then converted to the operative managements. The cause of death, the nearly 8%, the 2 patients are expired. The 1 patient died from primary hemorrhage from open fracture of right femur and both bone of both legs, and 1 patient died for acute respiratory distress syndrome following septicemia. The conclusion: the spleen is most commonly injured organ in intra-abdomen, and age and sex have no associated with any outcome of the management. Male are commonly involved than female. The mean age group of involvement in splenic trauma is 28.45 year. The time lapse between the injury and treatment has a significant association with outcomes. The patients who presenting less than 2 hours of injury having a better prognosis with less morbidity and mortality. The grade of the splenic injury and continuous monitoring of the patient and associative injury have a direct reading on the outcome. The preoperative ultrasound scan of the abdomen and pelvic cavity is diagnostic of splenic and with a sensitivity rate is 81.81%. The overall splenic injury of the grade 1st and 2nd have good outcome, and non-operative management was management when no associated with other organ injuries. The respiratory complications are the most common post-operative complication, and associative injuries added to morbidity and mortality of the splenic trauma patient. The failure of the non-operative management is due to the hemodynamically unstable age older than 55 year and contrast blushing vascular blush on the CT scan. Thank you, sir. I'm okay, sir.
Dr. Praveen, we could not hear your question.
Dr. Deepak?
Yes, sir.
You have told that 8% of the patient was converted to splenectomy. 8% of the patient.
Yes, sir. Out of 25 patients, 2 patients are initially management in non-operative, then converted to in operative.
Which day you converted?
Sir, actually, we are managed for 48 hours, 48 to 72 hours. Then we repeated the CT scan. Then in CT scan, we see the blushing in vessels. So we decided to operating. Sir.
Yes, yes.
Deepak.
Yeah, yes, sir.
Is there any role of diagnostic laparoscopy in hemodynamically stable patient?
Yes, sir. If patients are unstable and we are not.
No, I am talking about hemodynamically stable patients.
Okay.
With
sir, in stable patients, sir, laparoscopic diagnosis is also, sir, because sometimes we are not finding any injury in the CT scan and ultrasound, so we decided for laparoscopic diagnostic. So I think, sir, diagnostic laparoscopy.
no, conservative management without doing anything or doing a diagnostic laparoscopy, which one is better?
Conservative management, we decided for on CT finding and USG finding, sir. So
Okay.
if the splenic injury is grade 1 and grade 2nd, so we don't have any operative indication and any no indication for laparoscopic diagnostics.
Can you name the classification which you have mentioned, grade 1, 2, 3? Which is this classification?
Sir, It is a American social classification 19.
No, it is not American. It is your thesis and you didn't even know the classification. It is World Surgery of WSES classification. It is basically WSES. Okay.
Okay, sir.
Nice presentation. And one thing more, you should mention the references at the footer note while presenting your PPT. This Dr. Deepthi has mentioned this. While you are presenting as a state or a national forum, you should mention the references at the footer note from where you have been taken. Okay.
Okay, sir. Thank you.
Thank
sir.
you.
Thank you, sir.
This session is over. Coming to next session. Chairperson is Dr. Dinesh Chand Sharma and Dr. Vijay Verma sir. And the first presenter is Dr. Giriraj Sharma.
Good morning, sir.
Good morning. Share your screen. Share
Yes,
your
ma'am.
screen.
Good morning.
Slideshow, please. Slideshow.
Yes, ma'am. Aims and objective. Good morning, ma'am. I am Dr. Giriraj Sharma presenting a prospective
Giriraj,
study of
please,
serum C-reactive protein and D-lactate level of.
Giraj.
Yes, ma'am.
Please, slideshow. Slideshow.
Slides.
Dr. Giriraj,
Yes, ma'am.
near your screen, down left, right hand side, 76% is written.
Yes, sir.
उसके पास में एक आइकन है, उसको क्लिक करो. इधर 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 लेफ्ट हैंड साइड में, और इधर. हाँ, इसके नहीं, बिल्कुल उसके पास वाला, 26 के पास वाला. हाँ, ये क्लिक करो. Carry on now.
All right. Yes, sir. Good morning, ma'am. Good morning, sir. I am Dr. Giriraj Sharma presenting a prospective study of serum C-reactive protein and D-lactate level for early prediction of strangulation in intestinal obstruction under the guidance of Dr. Shyamudra sir, Senior Professor and Unit Head Dr. Bhagchan Khorwal sir. Yes. Aims and objective. This study was conducted to emphasize following obstruction. Methodology: hospital-based prospective study was conducted from February 2019 to January 2020 on 50 patients admitted in JLN Hospital Ajmer in various surgical units and who followed with the diagnosis of acute intestinal obstruction. Acute intestinal obstruction was diagnosed by history, clinical examination, and imaging modality. These patients were subject to exploratory laparotomy. Based on the finding of the laparotomy, these patients were grouped into A and B. Group A include those with intestinal obstruction and strangulation, and Group B intestinal obstruction without strangulation. Inclusion criteria: all patients aged 15 to 90 years with suspicion of acute intestinal obstruction and underwent expulsion laparotomy in the emergency operation at JLN Hospital Ajmer. Exclusion criteria: patient with coexisting medical illness such as chronic kidney disease, any cardiac disease, diabetes mellitus, and coagulopathy. Patient with any intraoperative finding apart from simple or strangulated bowel obstruction. Results: Group A, intestinal obstruction with strangulation, and Group B, intestinal obstruction without strangulation. Group A added 20% and Group B 30. The CRP level mean 110.50 and standard deviation delected 5.82, p-value 0.001 significant. Results analyzed using SPSS software show mean CRP level was 110.50 plus minus 27.14 milligram per deciliter in group A, and mean CRP level was 38.96 plus minus 17.40 milligram per deciliter in group B. The mean CRP level difference in both groups were statistically significant. Mean D-lactic level was 5.2 plus minus 0.62 millimole per liter in group A, and mean D-lactic level was 2.87 plus minus 1.04 millimole per liter in group B. The mean D-lactic level difference in both groups. The sensitivity and specificity for elevated serum C-reactive protein. The serum C-reactive protein increase in 70%, normal in 3%. Total 20% admitted included in group A, and serum C-reactive protein increase in 6% and normal in 24% in group B. The p-value 0.001, sensitivity 85%, specificity 80.67%, and positive predictive value 73.91%. Negative predictive value 88.89%. As per above table show that CRP test sensitivity was 85%, specificity was 80.67%, PP was 73.91, and negative predictive value was 88.89% to detect the obstruction with strangulation when using a cutoff value of 60 milligram per liter. Sensitivity and specificity for elevated serum D-lactic level. D-lactic level increase in 60% in group A and normal in 4%. D-lactic level increase in 3% in group B and normal in 27% or 27%. The p-value 0.001, sensitivity 80, specificity 90, and positive predictive value 84.3 and negative 87.1. As per above table show that D-lactic test is sensitivity was 80%, specificity 90%, positive predictive value 84.3, and negative predictive value is 87.1 to detect the obstruction with strangulation when using cutoff value of 4.5 millimole per liter. Conclusion: serum C-reactive protein and D-lactic level can be useful and reasonable marker for predicting strangulation in case of acute intestinal obstruction in an emergency setting. Thank you, ma'am.
Hello.
Yes, sir.
Yeah, Dr. Giraj.
Yes, sir.
On which day you measured these lactate levels?
Yes, sir.
On which day of admission you measured these levels, lactate levels?
Sir, post admission day is second, sir.
Post-op day, admission day, second for all patients.
Yes, sir.
Okay. And what is the concept? What is the concept of this lactate measuring? Why this? This is a marker of mesenteric ischemia. Okay.
Yes, sir. Yes,
As
sir.
per your this concept is a marker of ischemia. So why it is rise? Why does it rise?
Sir, when ischemia occur, the cell go hypoperfusion, and in hypoperfusion, cell from aerobic respiration to anaerobic respiration, and in anaerobic respiration, in a space of CO2, lactic acid is formed, so D-lactate level is increased.
Okay, so the concept is that there will be anaerobic pathway.
In ABG, D-lactate level is increased, sir. So serum.
Okay. So what converts that? Is it bacterial flora or something else?
No, 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 बिल्कुल नहीं कहना चाहिए। ये तो कहते वो बहुत सही कह रहे।
Yes, sir. Yes, sir.
So in mesenteric ischemia, that in strangulation that can be arterial or venous or both.
Strangulation, sir, in mesenteric ischemia, sir, strangulation venous, sir, due to edema or in GIT fluid collection, sir, the venous return is decreased, sir.
Okay, so relapse level will be increased due to anaerobic pathways pursued.
Yeah. Yes, sir.
Yeah. Okay, thank you.
Thank you, sir.
So next presenter is Dr. Hansa. Dr. Hansa.
Hello.
Yes, please. Share your screen.
Sir, I have some problem for uploading the PowerPoint presentation. Sir, 2 minutes I needed.
Okay, then we are going for next, Dr. Ishad.
Yes, sir.
Dr. Ishad.
Hello. Good morning, sir.
Yes, please. Take it slideshow.
Myself, Dr. Shah Khan, second year resident, Doctoration Medical College, Jodhpur, presenting case of abdominal scrotal hydrocele, uncommon clinical entity in adult.
Slide presentation, Harshad. Yes, go ahead.
Sir. Abdominal scrotal hydrocele and uncommon clinical entity incidence varies from 0.17 to 3.1%, characterized by a dumbbell-shaped hydrocele that extends from scrotum into abdominal cavity through an inguinal canal. Embryologically, several theories proposed. More widely accepted theories describe upward extension of scrotal hydrocele into abdominal cavity due to excessive pressure from scrotal component. We report an interesting case of abdominal scrotal hydrocele and emphasizes importance through a thorough abdominal examination to rule out abdominal extension in all cases of large hydrocele. Here is bulge in left inguinoscrotal region, fullness in upper lower abdomen. Method: a 32-year-old male presented to surgery department, Doctoration Medical College, Jodhpur, with complaint of lower abdominal distension with swelling of left scrotum since 5 years. He complained of vague abdominal pain. On thorough abdominal examination, a soft cystic swelling present in lower abdomen associated with presence of cross fluctuation in between scrotum and abdomen. USG findings suggest a large cystic lesion with internal echo seen in left side of pelvis with lower abdomen communicating through left spermatic cord with left spermatic sac. CECT suggests a binocular cystic lesion midline lower abdomen extending to lower abdominal sac through inguinal region with large abdominal scrotal hydrocele, mass effect on left distal ureter with mild proximal hydroureteral nephrosis. As CT suggests hypodense lesion in abdomen and lower sheet suggests of hypodense extension up to scrotum. We patient approached with left inguinal oblique incision and but sac was densely adherent to sigmoid colon and cord structures. Then exploratomy was performed through lower midline vertical incision as large hydrocele sac containing approximately 3 liter clear fluid extending from scrotum into umbilicus through lower. First slide shows text. So, sac is densely adherent to sigmoid colon and large sac, large third slide, so large sac with containing approximately 3 liters of the fluid. The results: on second post-operative day, patient developed left scrotal hematoma. Patient was managed conservatively without further complication. Patient discharged on 7th post-operative day, satisfactory condition. Patient recovered. He was uneventful on 2 months of follow-up. Conclusion: abdominoscrotal hydrocele needs a proper examination and ultrasound in most of cases for diagnosis of a cystic abdominal mass. However, rarely requires CT abdomen and pelvis. Thank you, sir. Thank you.
Dr. Vijay, you have to unmute yourself.
Okay. Yeah. Yeah. Yeah, Irshad, do you mention result in case discussion? Just like that?
Resulting, sir, patient discharge post-operative with satisfactory condition and the result.
So there is discussion. No? This is only case discussion that is written. There is not a result of a case discussion. Result is only of paper for some study. Okay.
Next is Dr. Hansa is ready, please.
Dr. Irshad, one more thing that you mentioned, this is a binocular. It is not binocular. Binocular is for related with the eyes. It is bilocular. I think you have to make a correction in that.
Thank you, sir.
Next, Dr. Hansa, please.
Next.
Dr. Jay.
Yes, sir.
Please share your screen.
Sir, should I start, sir?
Yes, please.
Switch on your camera, Dr. Jay.
Yes, sir. Good afternoon, faculties and participants. I'm myself Dr. Jay Kitroda, third year resident doctor in General Surgery Department in BJMC Ahmedabad. My study title is Observational Study of Levels of Homocysteine, Serum B12 and D-dimer, and Outcomes in Cases of Deep Vein Thrombosis in Surgical Wards at a Tertiary Care Center. Deep vein thrombosis is a major preventable cause of morbidity and mortality in hospitalized surgical patients. The occurrence of disease is related to presence of risk factors which are related primarily to trauma, venous stresses, and hypercoagulability. Main pathophysiological link among vitamin B12, folic acid, and venous thrombosis is accumulation of homocysteine owing to decreased concentration of these B group vitamins. However, all of these vitamins have a homocysteine independent role related to development of venous thrombosis. Additionally, hyperhomocysteinemia inhibits the inactivation of factor 5A by activated protein C and could increase the effect of factor 5 laden. It has been reported in the literature that increased homocysteine concentration is an independent risk factor for deep vein thrombosis. Serum levels of D-dimer may increase in clinical conditions where clots form, for instance, surgery, trauma, cancer, sepsis, and hemorrhage, particularly in the hospitalized patients. Interestingly, these conditions are also correlated with greater risk of DVT. The sensitivity of D-dimer for estimation of DVT is high with relative lower specificity. My aims and objectives are to study levels of serum homocysteine, B12, and D-dimer values in patients of DVT, and to study outcomes in patients with DVT. My study is prospective observation study in 50 patients of DVT, which was done in Tertiary Care Center in Ahmedabad.
from July 19 to December 19. Data was collected from the medical record system of the hospital. The parameters considered in the study were serum homocysteine levels, serum B12 levels, and D-dimer levels. Outcomes of the patients were noted at the 6-month follow-up. Data collected was entered in the Microsoft Office Excel sheet and analyzed. Talking about results, 61 to 70-year age group was most commonly involved. About 24% patients were in this age group. Then 51 to 60-year age group, and then 21 to 30-year age group. Sex distribution, male patients were more noted than the female. 54 patients, 54% of patients were male, and 46% were female. Limbs involved in the deep vein thrombosis. Most commonly involved vein limb was left lower limb, then right lower limb, and then right upper limb. Deep veins involved. Most commonly involved vein was left femoral vein. That was in 27 patients out of 50 patients. Then left popliteal vein, 20 patients after out of 50 patients. These are normal values of serum B12, homocysteine D-dimer, which were done in all the patients on admission. Out of 50 patients, 22% had vitamin B12 deficiency, 12 patients had hyperhomocysteinemia, and 5 patients had increased D-dimer value. All the patients who had hyperhomocysteinemia also had vitamin B12 deficiency. Out of 5 patients with elevated D-dimer value, 1 had vitamin B12 deficiency and 1 had vitamin B12 deficiency with hyperhomocysteinemia. Out of 5 patients with elevated D-dimer values, 4 patients had pulmonary embolism and died within first week of the admission. 40 patients, out of 50 patients, 5 patients had upper limb involvement and 45 patients had lower limb DVT. Out of these, 20 patients had vitamin B12 deficiency. Among these patients, 17 patients had involvement of femoral vein, 8 patients had hyperhomocysteinemia. Among these patients, 7 patients had involvement of femoral vein. 25 patients with normal vitamin B12 values, 25 patients had involvement of femoral vein. 4 patients died due to pulmonary embolism, out of which 3 patients had involvement of lower limb and 1 patient had involvement of upper limb. Outcomes at 6 months of follow-up. There was resolution in 36% of the patients, recanalization in 44% of the patients, recurrence in 12% of the patient, and death of 8% of patients. So my conclusion is a DVT risk increases with the increasing age. In this study, male patients were more in number than female. For better understanding of the sex involvement factor, it requires more number of patients. Left lower limb is most commonly involved limb in the DVT, with most commonly involved deep vein being femoral vein. Homocysteine was found to be negatively related with vitamin B12, and serum vitamin B12, homocysteine, and D-dimers should be investigated in every suspected and proven cases of DVT. And deficiency of vitamin B12 and hyperhomocysteinemia should be corrected if found to prevent future thromboembolic event in addition to anticoagulation therapy. Pulmonary embolism is most fatal complication of DVT. As in this study, all 4 patients who developed pulmonary embolism after DVT had died within first week of the admission. Thank you, sir.
Yeah, Dr. J?
Yes, sir.
Yeah, what were your exclusion and inclusion criteria for this study? All patients of DVT included?
Sir, more than 20-year age patients were included, which were admitted in the general surgical department.
No. You have here you have talked about congenital this hyperhomocysteinemia and this vitamin B12 deficiency. Do you included this post-operative patients and some?
Yes, sir. All the patients admitted in the surgical wards were included.
Okay, so you have included all patients. Some have
Yes,
history of.
Some had history of trauma, some had history of surgery.
Yeah, all patients are included.
Yes, sir.
Okay.
Next is Dr. Hansa, please.
Dr. Hansa, if you are presenting from a mobile, you have to rotate your mobile horizontally.
Yes, sir.
Yes, that's okay.
Am I audible, sir?
Yes, yes, you are audible.
Can I start it?
Yes, start.
Good afternoon, everyone. My presentation is on a clinical bacteriological study of post-operative wound infection. I am third year resident from BJ Medical College, General Surgery Department, under guidance of Dr. Gunwan Rathod, HOD and Professor of Surgery, Head of Department. Then Dr. Ravi Kadani is my Associate Professor. Background and aim, surgical site infection constitute a major public health problem worldwide and are the second most frequently reported nosocomial infection. They are responsible for increase the treatment cost, length of hospital stay, and the significant morbidity and the mortality of the patient. My aim and objective is to determine the incidence of SSI in the post-operative laparotomy wound and the prevalence of aerobic bacterial pathogens involving their antibiotic program. To study the risk factor of SSI in our hospital. Material method, we conducted a study of 270 patients from the January to March 2020 who underwent various surgery in the General Surgery Department of Civil Hospital Ahmedabad. Sample was collected using cotton swab from post-operative wound from 147 patients who clinically diagnosed having SSI in general surgical ward. A few host factor, wound factor, and the surgical related factors that causes SSI were studied. Collected swab from infected surgical wound was processed by conventional microbiological method. Antimicrobial susceptibility was done by cryptid powder disk diffusion method. Result, among the 270 patients, 156 developed surgical site infection. Out of them, 81 patients taking in emergency surgery were developed surgical site infection. It was found more common among the old age, obese, underweight, and the overweight, anemic patient, diabetic, hypertensive, or liver parenchyma disease with ascites and long surgery, and the poor nutritional patients. Discussion, despite of advance in surgical technique and better understanding of pathogenesis of wound infection, management of SSI remain a significant concern for surgeon and the physician in the healthcare facility. Patient where SSI faces additional exposure to microbial population circulating in hospital setup with always charged with microbial pathogens. And unrestricted and rapidly spreading resistance to available eras of antimicrobial further contribute to existing problem. Most of the SSI are hospital acquired or varies from hospital to hospital. The rate of SSI has been reported to be 57.77% in our study. Following factor of development of SSI is old age, because of low healing rate, low immunity, increased catabolic process, and presence of comorbid illness like diabetes, hypertensive, hypoproteinemia, or anemia. Prolonged surgery and emergency surgery was found to be significant risk factor for SSI. A mean age of the patient was 43.8 years and quite peak incidence of SSI observed in the age group greater than 42 years, more in male were commonly affected than female. Among the 157 bacteria isolate is most commonly Staphylococcus aureus gram positive, which is 50.4%, and E. coli gram negative 23%, and Klebsiella is commonest organism. The Staphylococcus aureus strain was showing a high degree of resistance for ampicillin, gram negative isolate showing higher rate of resistance to gentamicin, ciprofloxacin, meropenem. So good activity against the most of gram negative isolate except Pseudomonas aeruginosa strain of gram negative bacteria. Vancomycin, linezolid, and amikacin were found to be most effective antibiotics. Current recommendations for prevalent SSI advised to give prophylactic antibiotic prior to surgery and saving and the beta scrub before the surgery. In spite of modern surgical and sterilized techniques, the use of prophylactic antibiotic SSI still continues important challenge. They impose substantial burden to disease, both patient as well as healthcare services in the term of pharmacotherapeutic, though the SSI cannot be completely eliminated, but a reduction rate of infection minimums can be significant benefit to patient morbidity and mortality. This can be achieved by optimal pre-op, intra-op, or post-operative patient care. Conclusion: to establish the most suitable empirical treatment for each patient is very important to know microbial epidemiology. The information obtained from my study allow better understanding of the microbial etiology of SSI in our hospitals. By using the result of this study, we initiate for establish improve patient general condition, comorbidity, and proper use of antibiotic according to culture report, free of use of antibiotic and post of care, minimize the rate of SSI, and decrease the morbidity and mortality of the patient. Thank you, sir.
Yeah, Dr. Hansa, what was your incidence in emergency and elective surgery? This your post to SSI?
Yes, sir.
What was incidence of SSI? You are segregated in emergency and elective?
Yes, sir. In an emergency patient, the rate of SSI is more, sir. 150. We have taken 270 patients. In which 157 patients develop SSI, which taken in emergency surgery.
So, can you tell me some factors that cause this? It always SSI is greater in emergency
Yes,
surgery.
sir. Yes, sir. In emergency surgery, we have patient like a free gas and intestinal obstruction. We have taking a pre-op, sir, USG and X-ray, then directly send patient to surgery. And no, there is a need, no started proper, sir, IV fluid and antibiotic.
No, in emergency setting, we also do first resuscitation some and then go to all surgeries. But what are the other factors that lead to
Yes, sir.
increase?
But if yes, sir. If patient have an underlying comorbidity like diabetes, hypertension, or liver parenchymal disease with ascites, well, there is
Yes.
no time for this management.
Yeah,
Then,
that is a factor that there
if
are some
patient is old age,
comorbidities. Yeah. Okay. Some other factors, you know.
yes, sir. Then a patient has a obese and the old age and the immunocompromised patient having some more chances of the SSI in emergency surgery.
Okay.
Next is Dr. Kaushik.
Yes, sir.
Dr. Kaushik Patel, please share your screen.
Yes, I had clicked the share button, sir. It required 1 to 2 minutes.
Dr. Kaushik, any problem? Dr. Kaushik?
Dr. Mahesh, can you share your screen, please?
जी गुड आफ्टरनून सर.
Please share your screen.
जी सर. Good afternoon, sir. Hello, can you audible, sir? Hello.
Yeah.
Can I audible, sir?
Yes, please. You please share your screen.
Ji, sir. Good afternoon, everyone. My topic is the study of hormone receptor status and its correlation with S tumor size, histological grade, and lymph node metastasis in carcinoma breast. First of all, the introduction of this topic is the breast cancer is the most frequently occurring cancer in women, with around 1 million newly diagnosed cases each year
Mahesh,
worldwide.
where is your PPT screen? This is PowerPoint. This is PowerPoint.
Yes, ma'am.
This is Word format. This is not PowerPoint.
Yes, ma'am. Ma'am, I have some problem in the PowerPoint. Can I present in this format? Am I audible, ma'am? Hello? Hello? Am I audible, ma'am?
I think people will not be able to read this.
Yes, ma'am.
Hmm.
Can I present in this format, ma'am?
How can we are not able to see this?
See, ma'am.
We are not able to visualize it. No.
Ma'am, I'm trying. Can I present, ma'am? Hello?
Dr. Vijay, can you see it? Dr. Vijay, can you see it?
No, ma'am, it's not properly
No,
visible.
it is not visible.
Yeah, it's not in proper format. Actually, it is not in PPT. Yeah, it is a PDF file that is shared. Yeah, why don't you have made some PPT? Yeah, Dr. Mahesh?
Yes, sir.
Why
Sir.
don't you
I
have
have some
some
problem in presenting the PPT format.
You have made PPT, but you are not
Yes,
able
sir.
to present it.
Sir. Sir, can I zoom this?
You can zoom, but how will we interpret what are you trying to say?
Let next speaker do it. Like you can present afterwards. Mahesh, you can present afterwards. Let this next speaker speak.
Dr. Kaushik Patel. Dr. Kaushik left.
So let the next speaker come.
Only two speakers of this session left, Dr. Kaushik and Dr. Mahesh.
So start the next session. We will take them afterwards.
Next session is at 2 p.m.
Session is at 2 p.m. Okay, then conclude. We cannot do anything.
Yes, sir.
Power,
Yes, ma'am.
conclude the session.
Ma'am, can we wait for 5-10 minutes if Dr. Mahesh wants to present again and his problem is resolved? Dr. Vijay, ask him about to Dr. Mahesh whether he can present within 5-10 minutes. Is it possible or not?
Yes, sir. Yeah, Dr. Mahesh. Is your presentation ready? Is your presentation ready, Dr. Mahesh?
Sir, I'm trying, sir.
Within 5 to 10 minutes, if is it okay, then you can present, because you are the last candidate in this session. Otherwise, we can conclude this session. So we are waiting for you about 5 to 10 minutes.
It is the same PDF file you are trying to share.
Yes, sir.
Please go into PPT format if you have made it.
Yes, sir. I will try, and sir, I will present in the next session, sir. Can I?
Okay, Yadav sir, he is not able to present right now, so.
No, if in next session someone is absent and time permitted, then you can allow.
Sir, can I present in this format, sir? In the Zoom.
We are not able to see, and you will also not able to tell what are the.
Sir, I will read it. Hello.
Yes.
Am I
in this format?
Am I audible, sir?
You have to make in PPT format, and in next session, if there will be time, we will consider. Okay.
Yes, sir.
So Dr. Kaushik is also not available.
Then you labeled as absent.
Okay.
If he is not
Actually,
available, then
he was present, but right now he left.
You call him ki whether he thought ki there may
I'm
be.
just calling him.
Yes. Please call him and confirm.
Just please. When Dr. Kaushik is joining again.
Okay, we can permit Dr. Kaushik if he is joining. Yes, start, Dr. Kaushik. Is there any technical problem? You can't start.
Dr. Kaushik. Yes, please share your screen. Dr. Kaushik.
Yes, sir.
Go to full screen mode.
Yes. Hello. Hello. I'm audible. Hello.
Yeah, go on.
Okay. My name is Dr. Kaushik Patel. I am from BJ Medical College, Ahmedabad. My topic is Alvarado scoring in pre-operative diagnosis of acute appendicitis. The acute appendicitis one is the most of commonest surgical emergency. Acute appendicitis is essential and clinical diagnosis. About 6% of population is expected to have appendicitis in lifetime. Routine history and physical examination still remain the most practical diagnostic modality. For this reason, it is impractical to have a gold standard to definitive pre-operative diagnosis, which lead to an appreciable rate of negative appendectomy as reported in world literature is varying from 20 to 40% with its association with morbidity with 10%. The scoring system of valuable and validity of discrimination between the acute appendicitis and non-specific abdominal pain. Alvarado scoring system is one of the men in the purely based on history, clinical examination, and few laboratory tests is very easy to apply. The use of the objective scoring system such as Alvarez system can reduce the negative appendectomy rate. The clinic parameters included in scoring is migratory right iliac fossa pain with score 1, anorexia 1, nausea and vomiting 1, tenderness over right iliac fossa is 2, rebound tenderness in right iliac fossa is 1, elevated temperature is 1, and leukocytosis is 2, and CYP2 left in hemogram is 1. The aim of the study is to evaluate the efficacy of Alvarado scoring system as a pre-operative diagnostic tool in the acute appendicitis in correction with the operative finding. Role of Alvarado scoring system in cutting down the rate of negative appendectomy without increasing morbidity and mortality. The method is this study is prospective, and the 25% present with sign and symptom of acute appendicitis at the emergency department of BJ Medical College Civil Hospital, Ahmedabad from January 2009 to December 2009. Sample size is 25. Inclusion criteria: the patient who present with sign and symptom of acute appendicitis who are patient of aged 15 and above of other sex, patient willing for investigation and surgery. Exclusion criteria is patient age 14 year and below, pregnant female, appendicular mass, patient with recent history of any abdominal surgery. Then the total score is calculated for each patient, and based of the scoring, they are divided in three groups. Group 1, the patient with a score 7 to 10 underwent appendectomy. Group 2, which is score 5 to 6, where through clinical ground to required appendectomy, it was performed. Group 3, which is less than 5 score, which is observed managed conservatively. The result of Alvarado scoring system is following. The total patient is 25, the male is 15 and female is 10. The score is 7 to 10 is 12 male patient and female is 7 patient. And the 5 to 6 score is male is 2 and female is 1 patient, and less than 5 is male 1 and female 2 patient. The pathological diagnosis as per histopathological report is following. The total patient of 22 is operated. However, 20% have acute appendicitis on histopathological report, and 2 has a normal appendix on the histopathological report. The result of Alvarado scoring system for 7 to 10%, where the male patient is 12, having a 7 to 10, and female is 7. Number of patients is operated is 12 male and 7 female. Number of histopathological appendicitis is male is 12 and female is 6, and on histopathological normal appendix is 1 in female patient. The score is group 2, 5 to 6 is following. For male, 2 patient is operated 2, and histopathological examination 1 have appendicitis and 1 have a normal appendix. Female is 1 patient and 1 is operated, and on histopathological appendicitis 1 and 0 have a normal appendix. The negative appendectomy rate is following. The male patient have a number of negative appendectomy is 1 and female is 1, total 2, 4.5 and 9% total negative laparotomy is done. The discussion is written. The positive predictable value of the score was 19.9. The conclusion: Alvarado score is very effective in the diagnosis of acute appendicitis in both men and female, but some other diagnosis modality may be necessary to assign the diagnosis in female along with the clinical scoring system to rule out other pelvic pathology and to reduce negative appendectomy rate in female. In the diagnosis of acute appendicitis, the Alvarado score is fast, simple, reliable, non-invasive, repeatable, safe diagnostic modality without extra expense and compatibility. It is very handy in daycare hospital or peripheral hospital where backup facility like USG scan or CT scan is not available. The application of this scoring system improved the diagnostic accuracy and consequently reduced the negative appendectomy and thus reduced the compliance rate. Thank you.
So, what is the Dr. Kaushik? What is modified Alvarado scoring? You
The
mentioned
modifier
before.
there are, sir, removal of shift to left in hemogram
Okay.
with scala modification of the Alvarado.
Okay, so have you included some cases that were opened for appendicectomy, but you have find some other pathologies like somebody has find some ovarian cyst ruptured or some PID component is there? Have you included such cases also?
Yes, sir. In female patient which is normal appendix, we have diagnostic laparoscopy. They are finding hemorrhagic cyst of right ovary.
Okay. Yeah. Yeah, Dr. Kaushik has concluded. If Dr. Mahesh is ready, we can go to him or we can conclude now.
Sir, I am having a problem in the PPT format, sir. So can I present in the 2 o'clock, sir? Sorry, sir, for this inconvenience.
Okay, go on. Go on then. If you have any technical problem, go on.
Yes, sir.
Ma'am?
Hello.
Yes, sir. We have finished this session.
So now we conclude the session, or some candidate are still there?
No candidate is still available.
So we conclude the session.
Yes, sir.
Yes, we can conclude the session. Yeah.
Ma'am? Prabha ma'am?
Bhavar, conclude the session.
Yeah, okay, ma'am.
Everyone.
Pardon, ma'am?
Conclude the session.
Yeah. Okay, ma'am. On behalf of Association of Surgeons of Rajasthan State Chapter, we are thankful to our chairpersons who give their time within short invitation and still in their busy schedule. So thank you for their valuable time and judging the session, and also thanks to the participants for their active participations. And we are the next session of our paper presentation will start at sharp 2 p.m. So thank you all. Thank you.
Papa, come.
Hello. 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 पर्दा दोनों लगा दो पर्दे। हाँ रुपेश जी, मैं डॉक्टर पीयूष बोल रहा था।
Hello.
Hello.
Am I audible? Hello.
Yes, please.
Hello.
बोलिए सर.
Whether chairpersons are already joined or
Chairperson right now, only Dr. Bhakchan Khorwal joined.
and other one?
Other one is Dr. Ram Gopal Meena, Dr. Dinesh Dutt Sharma, Dr. Devinder Saini, and I think Dr. Devinder Saini is not there. So Dr. Jagdish will join.
Doctor?
Jagdish.
Okay. So still there is around 10 minutes.
Still 9 minutes left.
आया ही नहीं, ये व्हाट्सएप नंबर ही नहीं है, क्योंकि अगर होता ना तो इसमें आ जाता.
नंबर बोलना.
चूती को क्या चाहिए आज?
सब आ गए।
Sir, we can start now.
Hello?
Yes, sir, we can start now.
Am I audible?
Yes, sir.
So, good afternoon, respected judges, delegates, and dear residents. Welcome all of you on behalf of a Association of Surgeons of India, Rajasthan State Chapter, in second session of the non-competitive paper presentation. So we have already presented lot of paper in the first session, and now there are remaining sessions we will complete it in this session. So I hope that you all enjoy, and I'm hopefully the judges also join. Dr. Bhatsan, Rupesh ji, please unmute Dr. Bhatsan.
Yes, sir.
Bhatsan, am I audible?
Yes, sir.
Okay. So now we start our next session, and I welcome you on behalf of ASIRAJ Rajasthan chapter that you are judge for this session, and hope the remaining judges also join you. Otherwise, myself, Dr. Pradeep, and Prabha ma'am is there, so we also join you.
Dr. JP has joined as the judge.
Okay, that's okay. So you and Dr. JP, please go ahead. So please invite the paper presenter.
Sure, sir.
First presentation is of Dr. Manish Kumar Saini, please. Dr. Manish Kumar Saini, please share your screen.
Unmute, please. Yes.
Good afternoon, sir. Sir, in this message is showing, sir, you cannot start your video because of host has stopped it, sir. Hello?
Hello.
Hello?
Yes, please, just a moment, please.
Sir, video is being stopped, sir.
Yes, please start, please.
Sir, am I audible, sir? Sir,
Yes,
here
please.
video is being stopped, sir, from host side, sir.
Yes, we are seeing your slides.
No, your slide is visible on screen. So bad.
So shall I start, sir?
Yeah.
Very good afternoon, sirs, and my colleague, sir. I'm myself Dr. Manish Kumar Saini, Resident General Surgery, SPMC Medical College, Bikaner, sir. Under the guidance of Dr. M. Salim, sir, Professor and HOD General Surgery, SPMC Medical College, Bikaner, going to present the comparative study on the lichen stain repair and the DISARDA technique of inguinal hernia repair at Northwest Rajasthan. Introduction, sir. Inguinal hernia remain an important surgical problem because of frequency of occurrence. Average lifetime risk for inguinal hernia is 27% for men and 3% for women. Approximately 2/3 of inguinal hernias are indirect and 1/3 are direct. Approximately 10% cases are bilateral and recurrent in about 1 to 5%. Surgical repair is the only definitive treatment for inguinal hernia and is the most common general surgical procedure performed today. Particularly, lichen stain repair is considered as a gold standard. However, it has its own limitations. DISARDA technique is emerging technique for inguinal hernia repair. An aim and objective of this study is to compare the DISARDA tissue repair technique with lichen stain for inguinal hernia repair in terms of various operative and post-operative parameters like intraoperative time, local complications, and return to everyday activity, post-operative pain, foreign body sensation, and early recurrence. Methods, sir. The study was conducted in the Department of Surgery, Sardar Patel Medical College, Bikaner from June 2019 to May 2020. This study was a prospective hospital-based comparative study. Inclusion criteria are male patient, age more than 18 years, and primary unilateral inguinal hernias are being included. Exclusion criteria are patient less than 18 years or more than 80 years, patient with bilateral inguinal hernia, and as well as obstructed, strangulated, and recurrent inguinal hernias are excluded in this study. The patients were explained visual analog scale, written and informed consent was obtained, and were kept overnight fasting of minimum 8 hours. Parts prepared by clipper, injection ceftriaxone 1 gram was given 1 hour before to incision, and spinal anesthesia given. DISARDA repair was performed according to the surgical technique described by Dr. DISARDA, and mesh prosthesis repair, lichen stain, was undertaken as described in textbooks. Results are a total of 51 patients were included in the study. After screening and rest were lost on follow-up. 25 DISARDA repair and 26 lichen stain repair were done on these 51 patients. Mean age of DISARDA group was 54.50 years and lichen stain group was 50.04 years. There was no significant difference in the terms of age, associated illness, and addiction. There is no intraoperative complication in this. However, the operating time was less in DISARDA, that is 28.24 minutes versus lichen stain repair 30.88 minutes, was also significant, p-value less than 0.05. The mean visual analog scale in DISARDA group on second post-operative day was 3.12, while in lichen stain it is 3.73. That is also significant low. Mean time to return to the normal activity was 13.68 days in DISARDA, whereas in 18.54 days in lichen stain repair, which was statistically significant. In DISARDA repair, none of the patient developed seroma and wound infection in post-operative period, while lichen stain group developed 4 patients developed seroma and 1 patient developed infection. That was significantly statistically significant. No recurrence were observed in either of the group over a minimum period of 3 months. These are demographic details and the study group and the age and complaints of pain, swelling, and associated illness like benign prostatic hypertrophy, tuberculosis, COPD, or constipation. Addiction like smoker and alcohol also being included in this, but there is no significant difference between these two groups, DISARDA and lichen stain. Here is a comparison of the characteristics of the inguinal hernia on the basis of site, right and left, types, direct, indirect, or both, reducibility, reducible or content on the basis of momentum, bowel, and both. Here is the post-operative parameters which compared the post-operative pain most average visual analog scale on second day, 1 week, and 1 month are being compared between these two groups. And here is a significant low in the case of DISARDA group as compared to lichen group. Incidence of local hyposthesia, that is more in case of DISARDA group, wherein the incidence of foreign body sensation it's significantly high in lichen stain group. Whereas a return to the normal activity, it takes 13.68 days in DISARDA and 18.54 days in lichen stain. That is also significant difference. Number of patients having seroma and wound infections also significantly higher in lichen stain group. conclusion, the study is designed to compare the outcome of lichen stain tension repair, tension-free mesh repair with DISARDA repair. So both does not differ significantly in procedure complexity, but local complication and pain intensity is higher in case of lichen stain repair compared to the DISARDA repair. The time taken for the return to the normal non-sternus activity is significantly higher for lichen stain group compared to DISARDA group. There is no recurrence of hernia seen in both group during the follow-up period. DISARDA operation is simple to perform, does not require foreign bodies like mesh or complicated dissection of inguinal floor as in Bassini or in Shouldice. The DISARDA technique is cost-effective when compared to lichen stain method and is being done easily, especially in rural areas. The mean hospital stay is also low for DISARDA repair compared to
Dr. Manish?
Yes, sir.
How did you randomize these patients?
Sir, randomization is a lottery system, sir. Not all the patients who are coming and admitted in the hospital are being randomly distributed among the two groups, sir.
Now, what was the method used? Just
Sir, lottery system, sir. Like
exactly.
Name.
What was the lottery means? How did you tell them that this patient will be going for DISARDA and this will be going for lichen stain?
Sir,
either it is a chit method that you have. Okay. And all the surgeries are performed by single surgeon, or there are many different surgeons?
They are different surgeons.
They are different surgeons. And one more, in your complications, you had approximately 6 patient or 9 patient of BPH in the lichen stain group.
Yes, sir.
So, and some patients in the DISARDA group also. Did you manage the BPH previously, or what did you do in those patients?
Sir, in those patients, they are already taking the medication for that, sir. And after that, treatment is going continuous after that also, sir.
Did you evaluate them with the uroflow cytometry and all sort of these investigations before operating to look for the obstruction?
Sir, USG and being done for that all the patients, sir. But
USG will give you only size, because if there is obstruction even after your treatment, that might be on negative side, because 3-month period is not too adequate to look for recurrence. So, but still you have to have in your study that.
Yes, sir. Sir, immediate post-operative, sir, catheterization, and we can prevent the obstruction and but the proper urological investigation have not been done, sir.
Okay, Dr. Bhagchand and Dr. JP.
Dr. Manish.
Yes, sir.
How you came to know that DISARDA is better? How you can decide on time basis? Because time is purely the surgeon dependent. A person who is doing lichen stain hernia repair, I will take name of Dr. Jindal sir, Dr. DK sir, the great surgeon, was doing in with 10 to 15 minutes. So it is purely subjective matter. So how you decided that time outcome? Will you tell me the criteria of comparison of the time outcome in both the procedure, DISARDA as well as your lichen stain?
Sir, time criteria, sir, one is only doing sir both surgeries, sir. So we can easily compare it. We can compare, sir, because in our institute, one or two surgeon in my unit are doing the surgery. So in both surgeries, lichen stain and DISARDA is being done by one surgeon only, sir. So in that case, we can study.
I'm saying it's purely subjective.
Yes, sir.
Suppose that I'm doing my first surgery, and suppose that I'm doing the same hernia after a 2 hours laparoscopic surgery. So it will be purely subjective matter. So I don't think that. Hello.
Sir, yes, sir.
Answer.
Yes, sir.
That's what I'm saying. That
Yes, sir.
How a subjective matter can be manipulated in the result? This is purely manipulated. I can, whatever I want to do, I can spend time. A expert surgeon can spend time 45 minutes as well as 10 to 15 minutes. It's a subjective. So I don't think so that it should be included in a result and conclusion. Rest all depends on the patient and lots of contributing factor. You were saying about the pain, you are saying about the complication, day return, all the things.
Yes, sir.
As that Dr. Dasada in the Pune, Dr. Dasada belongs to Pune, have developed this technique. He may have some expertise in the particular technique. So whatever may be, but the subjective matters can't be calculated in without without removing the contributing and factors. Without removing the subjective material can't be given in the result. I think so that probably all judges will be also agree with me.
Hello?
Yes, sir.
Yes.
Yes. That is the reason that Dr. Pradeep asked the question ki whether it is done by same surgeon or different surgeon. Because if same surgeon is done, then it is definitely influencing. But if different surgeons done, then it's not worthwhile. So it should be done by the same surgeon.
The same surgeon, sir.
The techniques, then we
confounding factor removing.
Yes, sir.
Okay.
Thank you, Dr. Manish.
Yes, sir. Yes, ma'am.
Thank you, Dr. Manish. Next candidate, please.
Thank you, ma'am.
Next is Dr. Maulik Sharma.
Good afternoon, everyone. Good afternoon, everyone. Today I'll be presenting the study, the sensitivity. Hello.
Slideshow. Yeah.
Good afternoon, everyone. I'll be discussing on the study, the sensitivity and positive predictive value of clinical finding, sonography and CT finding to detect the defect size and the number of incisional or ventral hernia. Incisional or primary ventral hernia is defined as any abdominal wall gap from which a bulge in the area of post-operative scar, which is perceptible or palpable by clinical examination or by imaging, like CT or sonography. Also, it represents a breakdown or loss of continuity of a facial closure. Incisional hernias are one of the most common problems which are faced by general surgeons overall. They occur in up to 28% of the patients after initial laparotomies. While abdominal wall defect size may affect the surgical technique, size of the mesh selected, and outcomes, no standardized measurement recommendation currently exists. Our primary objective was to assess the size and number of primary ventral or incisional hernia defect by different methods, that is clinical examination, ultrasonography, and computed tomography. Study was conducted in Mahatma Gandhi Medical College, and the plan of study were patients which were present to the OPD with hernia on the ventral aspect of abdomen and excluding inguinal hernias. Inclusion criteria included all patients with incisional or primary ventral hernia who were fit for general anesthesia were included for surgical correction, either laparoscopically or open operation. Patients who were unfit for GA, incarcerated or strangulated bowel loops, or any evidence of vascular compromise on imaging, and patients who were pregnant, and patients with inguinal hernia, and those who did not give the consent were excluded. All the findings about the size and location of the hernia defect on clinical examination, sonography, and CT scan were noted and were recorded on a pre-structured proforma. A total of 30 patients of incisional or ventral hernia were enrolled in the study, and the location, number, size of defect of hernia were examined clinically by sonography and by computed tomography, and then compared with the intraoperative finding. Although patients of all age group were included in the study, maximum number of patients were between 50 to 60 years of age, that is 33.3%, followed by the age group of above 60 years, which has 26.7% of the cases.
These represent the significant values. Total of 23 females and 7 males were studied. 60% of the patients were housewives, followed by farmers, who constituted 23.3%. Incisional hernias were most commonly seen in patients who underwent LSCS, 36.7%, followed by previous GI surgeries, 20%, and post-surgical site infections. Clinical examination, USG, and CT were equally sensitive in detecting the number of ventral hernia defects. The hernia mostly contained omentum as a content, followed by small bowel, and both have small bowel and omentum together, which constitute about 13.3%. In our study, the defect size measured by clinical examination in comparison to intraoperative finding of the defect size was found out to be statistically significant, different, with mean value more than that of the intraoperative finding. Defect size measured by sonography in comparison to intraoperative finding of defect size was also found to be statistically significant, different, with mean value less than that of the intraoperative finding. Intra-class correlation coefficient of defect size via clinical examination was 0.995, which was showing nearly perfect correlation. Sonography showed strong correlation, and CT finding was suggestive of nearly perfect correlation. In our study, there was incisional hernia followed by epigastric hernia, which included 33%. Others were umbilical and paraumbilical hernias. Hernia mostly contained omentum as content, followed by small bowel, and both small bowel and omentum together constituting 13%. In the present study, among 30 patients, 46.7 patients underwent lap mesh hernia repair, ICOM and ICOM plus, and 36.7% patients underwent double-layered primary suture repair of hernia, and rest underwent primary suture repair of hernia in a single layer. Polyprolene was the most commonly used suture material for primary repair, followed by PDS. Nylon suture and recently V-lock sutures were also used for primary repair of hernia. The defect size assessed by clinical examination as compared to the intraoperative finding of the defect size was found to be statistically significant different, with mean value more than that of the intraoperative finding, and the defect size measured by sonography in comparison to intraoperative finding of defect size was also found to be statistically significantly different, with mean values less than that of the intraoperative finding. Size of defect of hernia measured by CT was almost same as that of defect measured during intraoperative finding, with mean value of 4.6 and 4.85. Intra-class correlation coefficient of defect size via clinical examination was 0.995%, which showed nearly perfect. Sonography was strongly correlated. CT finding was nearly perfect correlation. So the conclusion was, among the three methods of measuring incisional ventral hernia defect, CT was the most sensitive in detecting the number of hernias and measuring the size of the defect, precisely followed by clinical examination. Furthermore, comparative effectiveness studies may be undertaken to determine ideal method for measuring hernia size defect and evaluating the impact of different measurement methods on mesh selection and ultimately on patient outcome. That's all, sir.
Hello, Dr. Mani. Have earlier contestant left the?
No, sir, he is available.
Yes, sir.
Yeah, I'm not able to see.
Is there any question?
Yes, sir, can listen, sir.
My question to you, Dr. Maulik, as you mentioned, the defect size is perfectly
Yes, sir.
caused by the CT scan.
Yes, sir.
But you know, CT scan is costly, and if you are doing the surgery by laparoscopic method, that is IPOM.
Yes, sir.
You can detect the defect size, number as well as size of the defect very well by the laparoscopy. So in
Yes,
that, why you go for the CT or USG, because CT is very costly, and in Indian population, most of the people cannot afford this costly
Yes, sir.
diagnostic evaluation. So in which condition you mainly prefer, or in which condition you prefer this investigation?
Sir, despite CT scan being costly, but it gives a precise measurement of the defect, sir, as compared to yes, sir.
What is the relevance?
Okay.
What is the
In
relevancy of
which
the
condition
measurement?
you mainly
You are saying that
about
you are
CT scan, or whether there is any such procedure in which CT scan is mandatory? Because if you going through IPOM, in IPOM there is no need of CT scan, but there are some procedure which
Yes, sir.
need CT scan in such cases.
Sir,
and how much radiation? How much radiations from the X-ray? 250 times of the X-ray radiation exposure without reasoning. Then what is the relevancy of CT? Kindly prove, as Bhavar sir is asking, please.
Sir, just for the precise measurement of the defect, we are doing the CT.
No, that's I'm agree.
Yes, sir.
Percent agree. Main important role of CT scan, if you want the defect is very large, and
Yes, sir.
to do the component separation, whether it is anterior or posterior,
Yes, sir.
the role of CT scan is there, because in that case you want to know about what is the gap between the two rectus major muscle, and where is the lateral muscles of the abdominal wall, that is the external oblique, internal oblique, and the transversus abdominis. In that case, the role of CT is very important. But if routine surgeries in such type of cases, in our country's scenario,
yes, sir,
no role of CT. But when going for such type of advanced procedure, in that there is definitely role of CT.
Yes, sir.
Next presenter. Next.
Dr. Meenu Rani.
Thank you, sir.
Dr. Meenu Rani, please share your screen.
Yes, sir. Am I audible, sir?
Yes, please.
Yes, sir. Very good afternoon, respected dignitaries, my colleagues. Myself, Dr. Meenu Rani, resident in Department of General Surgery in SPMC Medical College, Bikaner, under guidance of Dr. Ashok Kumar, Professor in Department of General Surgery, SPMC Bikaner. Today, my topic of presentation is comparison of fistulectomy and fistulotomy with marsupialization in management of simple anal fistula. Let's start with background. Fistula in ano is one of the common anorectal disorder in India. It is a chronic abnormal communication which runs outward from the anorectal lumen, in which internal opening lies to an external opening on the skin of perineum or buttocks. Etiology. Most common cause of fistula in ano is previous anorectal abscess. Other causes are Crohn's disease, tuberculosis, lymphogranuloma venerum, and actinomycosis. Simple anal fistula have one internal opening, one external opening with a complete palpable tract. And common surgical techniques in simple anal fistula are, which are used in management of simple anal fistula are fistulotomy, fistulectomy, and fistulotomy with marsupialization. Aims of study: to compare the various clinical outcome of fistulectomy versus fistulotomy with marsupialization in management of simple anal fistula. Methods: study was conducted at Department of General Surgery in Sardar Patel Medical College, Bikaner, and study period was taken from 1st of March 2019 to 30th of April 2020, or till sample size was achieved. Study design: it is a hospital-based prospective comparative study. Sample size, Group A, in which we did fistulectomy. We took 20 cases in Group A and Group B. Group B, in which we did fistulotomy with marsupialization. Sample technique based on simple randomization by chit box method. Inclusion criteria: patients with symptomatic simple anal fistula, age between the 18 to 85 year of either sex. Exclusion criteria: high fistula in ano, recurrent fistula, and last patient with comorbid condition, immunocompromised condition. Process: after taking an informed and written consent, surgery was done. Process: all cases operated under regional anesthesia. After confirmation of fistula by injecting 2 ml methylene blue dye. Then probe was passed into the fistulous tract in Group A, in which we did the fistulectomy. A keyhole incision made over the fistulous tract and encircle the external opening. After that, the whole tract with the surrounding tissue was removed. But in Group B, after injecting the methylene blue dye, the tract laid open and was curated. Then approximation of the wound axis with the axis of fistula tract by using interrupted 3-0 chromic catgut. After surgery, all patients given IV antibiotics, ceftriaxone 1 gram IV BD and metronidazole 100 cc IV 8 hourly, and analgesic injection diclofenac 50 milligram IV IM for 2 days. And then discharge the patient after 2 days with oral medication and advised sitz bath and regular dressing and weekly follow-up up to the 12 weeks. During my study, parameter analysis: number 1, operating time; number 2, post-operative wound size; number 3, post-operative pain; number 4, wound discharge; number 5, wound healing time; then anal incontinence, last one is recurrence. This is the result showing various data of our study and their comparison with the other study. As we already told that in Group A and B, we took 20 patients. In Group A, in which we did fistulectomy, and Group B, fistulotomy with marsupialization. And there is a radial distance of external opening in Group A 2.12 centimeter and Group B 1.90. Operating times 21.10 minutes in Group A and 23.9 in Group B. Post-operative wound size is 2.34 in Group A and 1.16 in Group B. Post-operative pain at 24 hours, after 24 hours is 5.1 and 5.30. Wound healing in days 26.15 in Group A and 12.10 in Group B. And there is no recurrence rate, and anal incontinence is nil. And our study is study and their comparison with the other study is with Bhupendra et al. And Mohammed et al. And Barake et al., which are comparable. Now, wound healing is faster in patients who have undergone in fistulotomy with marsupialization than fistulectomy, might be due to smaller post-operative wound size in Group B rather than Group A. Rest parameters are comparable. Conclusion: result of fistulectomy and fistulotomy with marsupialization in management of simple anal fistula are comparable with respect to duration of surgery, post-operative pain, anal incontinence, and recurrence rate. Fistulotomy with marsupialization had has advantage over the fistulectomy technique in treatment of simple anal fistula. Still, a large study and long follow-up is required for establish standard guideline for surgical treatment for low-lying fistula in anal. Thank you.
Hello, Dr. Minurani.
Yes, sir.
I think so that the last line of your result is only the result, that lots of study and reevaluate and then establish any criteria, because it's purely surgeon based, that which technique he or she prefers and in which he is expertise. That is only the, because otherwise no relevancy of such a study in simple. Either you do fistulotomy or fistulotomy with marsupialization. Why you will leave a tissue which you have devascularized? There is no more reason to leave any blind sac or anything after doing the surgery there. So I think so that the last conclusion, the last line of conclusion, that research and then establish any conclusion is, that's all from my side.
Yes, sir.
I'm not going judgmental, but I'm telling you what. Bhamar sir, please.
Next
Uh,
presenter is
Thank you,
Dr.
Dr.
Neil
for
Patel.
the nice presentation. But because sample size is less, so for your results to validate, it needs further study and number of cases.
Yes, sir.
Thanks.
Thank you so much, sir. Thank you.
Next case.
Yes, sir.
Next part. Call next participants.
Good afternoon. Am I audible, sir?
Yeah.
Yes.
Good afternoon, sir, and my colleagues. I'm presenting patient topic on pancreatic injuries following blunt abdominal trauma and decision making between non-operative and operative treatment. I'm myself Dr. Neil Patel, third year general surgical resident in BJMC Civil Hospital, Ahmedabad. Background is pancreatic injuries occurring up to 3% of patients with significant blunt abdominal trauma, and a slightly higher percentage of those sustaining abdominal gunshot and stab wounds. Mortality rate for pancreatic injuries range from 10 to 25%, with the majority that's occurring in the first 48 hours from massive bleeding and its complications. Among patients with pancreatic injury surviving the initial hemorrhage, nearly half of the patients have complication of their pancreatic wound, like abscess, fistula, pseudocyst, false aneurysm, or anastomotic leak. In victims of blunt trauma, the deceleration and direct compression mechanism of injury explain why the neck of the pancreas in the prevertebral segment of the gland is most commonly injured. And if there is a damage to pancreas, it is often concomitant with injuries to the other viscera, especially the liver, spleen, and the duodenum. Aim of the study is to study the various grades of the injury and study the role of operative and non-operative management. This is a retrospective study was carried out for the patient hospitalized for blunt abdominal trauma and in the civil hospital Ahmedabad in Department of General Surgery and Gastrosurgery between April 2018 and July 2020. Around 50% patients were included in this study. This is the American Association for Surgery of Trauma classification for pancreatic injuries. In grade 1, there is minor contusion and laceration. Grade 2, major contusion and laceration without main pancreatic duct injury. In grade 3, there is distal transection with MPD injury, and grade 4, proximal transection with MPD injury. And in grade 5, there is massive pancreatic head laceration. Results of the study is from 50, 6 patients underwent surgical exploration. Out of 6, 5 had undergone surgical drainage, and 1 patient had pancreatectomy of grade 3. And in conservative management, out of 50 patients, 44 went under conservative management, and endoscopic drainage was done in endoscopic treatment was done in 9 patients, and radiological drainage was done in 12 patients. Most of the initial grade 1 and 2 patients were managed conservatively, And as the grade 2, 3, 4 patients, higher number of surgical exploration was done. Characteristics of patients who underwent operative management. One is, I will describe 6 patients. One is grade drainage and feeding dysautonomy was done. Patient was discharged on day 10. Second is another grade 2 injury. Drainage and feeding dysautonomy was done. And intra-abdominal collection post-operative, which was USG guided aspirated. Patient was discharged on day 10. Another is grade 4 injury, in which also drainage and feeding dysautonomy was done, and patient was discharged 20 days after the injury. And another is grade 3 distal pancreatectomy with splenectomy and feeding dysautonomy was done because there is association injury of liver contusion and splenic laceration, and patient had developed pancreatic fistula, which was managed conservatively, and patient was discharged after 22 days. Another is grade 4 injury in which drainage and feeding dysautonomy was done. Developed pancreatic fistula and patient was discharged after 13 days. And one is grade 5 injury in which drainage and feeding dysautonomy was done, and there is associated injury of duodenum, transverse colon, and mesenteric tear with head injury. There is patient was deceased on day 1. Cause of death was sudden cardiorespiratory arrest. This is the table showing time of operative intervention in patients of blunt abdominal trauma. In grade 2, operation was done on 7th day, grade 3 on 5th day, grade 4 on 9th day, and grade 5 on the first day itself. And the mechanism of injuries in grade 1, most of the patients were a motor vehicle accident, and also grade 4 and 5. And assault and injuries due to fall are mostly grade 1 or 2 injuries. No higher grade of injuries is seen with assault and fall. And non-operative management was key for the grade 1 and 2. And in grade 2, there is also radiological drainage and ERCP was done. So conclusion is the retrospective study shows that the etiology was dominated by motor vehicle accident in 96% of cases, followed by assault and falls, crushing injuries in 4% of cases. Isolated pancreatic trauma is rarely the case, as this study shows the 95% of patients have other associated injuries also. And grade 1 and 2, the non-operative management is most effective as long as there is no involvement of the main pancreatic duct. For grade 3 and 4, pancreatic injury, there is distal pancreatectomy or surgical drainage are the indication of choice for body and tail contused areas associated with distal pancreatic duct injury. And for grade 5 injuries, there are several possibilities, varies from non-operative management to surgical drainage up to pancreatic or duodenectomy. The data favor non-operative management with satisfactory results, even in cases of duodenal and bile duct injuries. Due to pancreatectomy, there is association of very high mortality rate, and mortality of a non-operative management group remains low. When non-operative management is decided, it include resuscitation, analgesia, parenteral nutrition, monitoring of surgical ward, and similar in ways of treatment in case of acute pancreatitis. The issue of antibiotic and octreotide treatment in non-operative group is still controversial. Thank you.
Hello.
Yes, sir.
So a simple thing, as I studied your whole study, that if duct is involved, then we need intervention. If duct is not involved, then it's better to allow the tissue to heal. It's a well-established standard statement from all books. What is the new in it? You'll buy a retrospective. Why you waste your time? Tell me one reason. This is standard. Standard established. All seniors. You can ask to any professor, any seniors, and what is and why a retrospective study, and what is what you have added in this study to the genuine surgery profession. What you added to the surgeon's knowledge.
Yes, sir. In grade 5 injuries, even if there is duct involvement, then we can
Not
go for
grade 5. I'm saying if pancreatic duct is involved, in that case, intervention is required. That, as we all have studied from our teachers, from our experience, as well as from books.
Yes, sir.
This is standard, probably.
Yes.
You might go through the literature. Then what is the role of your study? You took your prestigious time. You studied lots of retrospective paper and lots of those files. Is it possible to decide only by retrospective studies and when to intervene and not? It is only the patient and it is only the bedside and it is your professor's knowledge which tells when to intervene in pancreatic injury case and not.
Yes, sir.
Bhavar sir, please. Hello, Dr. Bhavar sir.
Dr. Neil?
Yes, sir.
As you says ki you doing conservative treatment in grade 5 injury.
Yes, sir.
What are the indications for treating a blunt trauma abdomen patient having pancreatic injury to treat conservative? What are the indications? Or in other words, what are the indications when you change your treatment from conservative to operative?
Sir, one is as sir said, there is if there is MPD injury and there is if pancreatic collection is there, then we should intervene.
No, why you intervene if there is pancreatic collection? There may be pseudopancreatic cyst formation. So you intervene after 6 weeks as a pseudopancreatic cyst. Why you intervene this time? So when you intervene or when you go for intervention in such type of patients,
Sir, if patient is not hemodynamically stable and associated visceral injuries are also there, then we can deal with both of them.
okay, so one is other visceral injuries, right?
Yes, sir. So, because as isolated pancreatic injuries are very rare.
Very. So, what are the clinical parameters? On the basis of that, you decide whether you should go for conservative or you should go for some operative intervention.
Sir, if a patient is not hemodynamically stable, then we should it indicates towards something surgical intervention is needed. And if patient is hemodynamically stable, then we can continue with the conservative management and further investigations can be done.
So how will you define whether patient is hemodynamically stable or not?
Sir, with pulse, blood pressure, temperature of the patient, abdominal girth.
All clinical, na?
Yes, sir.
And what about respiration?
Yes, sir. Respiratory rate needs also be counted.
And as if there is any investigations required, blood investigations?
Sir, we can go with serum amylase lipase, and apart from that,
there is pancreatic injury. They were definitely raised. So they are not indications whether you treat conservatively or by operative methods. Other investigations, other blood investigations.
Sir, hemoglobin, first of all, if there is any vascular injuries, it will fall.
But okay, there is no vascular injury.
Sir,
You should go one for ABG.
Yes, sir.
And other investigations were urea and creatinine. Because of there is, if the abdominal distension is increased, then there is chances of the abdominal compartment syndrome.
Yes.
In such cases, you also need laparotomy for decompression.
Yes, sir.
Okay.
Yes, sir.
Thank you.
Thank you, sir.
Any question?
Thank you, sir. Nice to
see. Judge's side.
Sir, please check the chat box. Question is there.
Okay.
In grade second.
A question to you. Grade second injury, how many days you keep the patient NBN?
Sir, we have to
injuries.
Sir, we have to see the sequential clinical examination of the patient. If the patient is hemodynamically stable, doing well, then we can keep the patient conservatively. If there is no any collection and patient does not have any other condition, then we can manage patient conservatively.
No, they are not
No,
asking
he
about
is
the
asking about
conservation.
the oral
You give
intake.
per oral,
When you
per oral intake. You should give
should
bowel
allow
sound.
patient per oral.
Sir, per 3 to 4 days, sir.
No, whether there is clinical assessment or 3 to 4 days.
Fix.
If after 3 to 4 days there is abdominal distension, then you allow him.
Bowel sound is not present, then what will you do?
No, sir. If
Yes.
not, bowel
So
sound is not
first
present.
clinically assess whether bowel sound is present or not, abdomen is soft or not, whether patient passes flatus or motion, and the investigations
Electrolyte.
are normal range. Then you go for. So it's not whether we allow him in 3 or 4 days or 5 or 6 days. It is depend on patient to patient variations.
Yes, sir.
Please call next participants.
Thank you, sir.
Next is Dr. Parikshit Vishnoi. Dr. Parikshit Vishnoi.
Blunt trauma. Duodenal perforation following blunt trauma abdomen in adult is rare. Most duodenal injuries are accompanied by other intra-abdominal injuries because of close anatomical relationship of the duodenum with other solid organ, major vessels, which makes isolated duodenal injury a rarity, thus difficult to diagnose. Preoperative.
Dr. Parikshit, you are not audible.
Yes, sir. Hello.
Yeah.
Yes, sir.
And also ask kids to keep away.
There are some noisy behind you.
All alone, sir.
Dr. Parikshit?
Yes, sir.
Yes, you can start.
There are preoperative diagnosis of isolated duodenal injury can be very difficult to make, especially, and there is no single method of repair that completely eliminates the possibility of dehiscence of duodenal suture line. As a result, surgeon is confronted with the dilemma of choosing between several preoperative investigations and many surgical procedures. Material method. 35-year-old male patient with abdominal pain after RTA was managed symptomatically in a private hospital. The duodenal injury was missed during the initial assessment in that hospital. He also presented to our emergency department 24 hours later with abdominal pain and vomiting. His vitals were stable. Material method. CT abdomen revealed free fluid in retroperitoneum, minimal perinephric fluid, and with multiple air pockets in the right perirenal and paracolic gutter, suggestive of retroperitoneal hollow viscous perforation. Exploratory laparotomy revealed 3 cm longitudinal tear on the lateral wall of D2 opposite to ampulla of Vetter and 100 ml of periduodenal bile with surrounding bile stained viscera. Duodenography was performed with Ryle's tube pulled up to D4 as a stent. Post-operative period was uneventful except the main wound infection. Discussion. Duodenal injury secondary to blunt trauma continues to pose a diagnostic challenge.
The finding of initial physical examination and CT evaluation can independently identify the presence of initial injury, including duodenal, in approximately 25% of the cases. In remaining of the cases, the awareness of the more subtle finding of bowel injury on CT scan can be complete the physical examination finding and potentially lead to more timely intervention of bowel injury. Conclusion. Surgeon examining a patient with upper abdominal symptoms following blunt trauma abdomen must have an high index of suspicion of duodenal injury and should be aware of various operative choices available and their utility. Thank you, sir. So that was the last slide.
Okay. Dr. Parikshit,
Yes, sir.
this patient was managed in some private hospital,
Yes, sir.
right, earlier? By
Yes, sir.
operative procedure or by some conservative management?
Sir, by conservative management, sir.
And there were some investigation was done or not? Earlier investigation
Sir.
was done like the CT scan, USG abdomen and X-ray.
No,
What type
sir.
of the investigation was done in that private hospital?
Sir, X-ray abdomen and chest X-ray, sir.
In X-ray abdomen, there is some findings may be present. Then how can we say that there is some findings miss in that private hospital and then referred in the government hospital and we are operated for that duodenal perforation, right?
Yes, sir.
So what is the common findings or injury after blunt trauma abdomen? What is the common injury?
Sir, there was pain abdomen in
No.
upper
I am
abdomen.
asking about the injury. What type of the injury is common after blunt trauma abdomen, right? Either
Yes,
it
sir.
is solid organ injury, either it is
Solid.
hollow organ injury. So which organ is most commonly injured by the blunt trauma?
Most commonly, it's the solid organs, sir. Mainly spleen,
organ?
liver, or
Right.
pancreas.
Or what about the whole organs?
So there are very rarely injured.
Rarely injured.
Yes, sir.
It depends on the impact
Yes,
on
sir.
the abdomen, which part is mostly involved. Either upper abdomen, then you can say that involved part is spleen or liver. If the impact is on around them, like as a or subcostal region, there is a chances of the hollow organ injury.
Yes, sir.
Right. So which part of the whole organ is mostly important? You notice,
sir,
whatever findings we look after laparotomy of the blunt trauma, we find that there are the lot of the case of the jejunal perforation.
Yes, sir.
Right.
Yes, sir.
So how many cases you have seen in your PGC of the duodenal perforation?
Sir, 2 cases.
Only 2 cases.
Yes, sir.
And whatever I am thinking, and that residents are routinely performed laparotomy for blunt trauma abdomens. So you yourself conclude your findings. What type of the injury is more common? Right?
Sir, duodenal injury is more common, sir.
Duodenal injury is more common. No.
No. In viscous
Other
injury.
JP sir. No, duodenal injury is less common.
Yes, sir.
Other judge, sir. Any other question?
What procedure you did in this patient?
Sir, we did. Yes, sir.
What procedure you did?
Sir, duodenography was done with the Riles tube was extended till D4 position.
And outcome is good.
Yes, sir.
Okay. What is the ideal procedure for that type of injury? you always do the duodenography, or there are some other type of the procedure that is better for this type of the injury? That injury size is around 2 centimeter longitudinal, right?
Yes, sir.
So there are maximum chances of the leakage, and if there is leakage occur, the mortality rate is high.
Yes, sir.
In that cases, this type of the repair is not suitable for the patient. What other type of the procedure you can do?
Sir, we can omental patch also.
Omental patch. What else? Anything else?
No, sir.
No, only omental patch.
Yes.
Oh, no. Sir, any other questions? Bawar sir? Chaudhary sir?
Nice presentation. Let us have a next presentation.
Okay.
Next presenter.
Dr. Piyush Udawar.
Piyush, slide presentation, slideshow. Make it a slideshow. Make it a slideshow.
Dr. Udayawar. The first one from start. Up, left, up. More left. Yes.
Presenter view. And down there is normal view, then first one, this one.
Which is this software? Are you opening it on PowerPoint or something else? This is Mac. Just click this presenter view from down. Near normal view. Yes. It's not allowing you. Okay, you can continue this way. We are wasting time. You just start.
Piyush, unmute yourself, please. Piyush, unmute yourself. I request all others to please mute your videos. Please mute yourself.
Hello. Yes, ma'am. Now you can hear me, ma'am. Hello.
Yes, we can hear you.
Okay. Now the most common surgical entity encounter is the groin hernia. Out of them, inguinal hernia is the main surgical problem. And for these various surgical techniques evolved from many years, Lycaniston technique is considered to be the surgery of the choice. But this technique has its own limitations in terms of post-operative pain, foreign body sensation, post-operative complications, cord fibrosis, etc. This other technique is newly raised technique in terms of its feasibility, low cost, and less recurrence rate. Professor Desada, who has used it since 1996 to get over the challenges faced with the use of the tension tissue repair and mesh repair techniques. It is based on the concept of providing a strong, mobile, and physiologically dynamic posterior inguinal wall. The technique is simple, easy to learn, and easy to do. It does not require complicated dissection or suturing. There is no tension on the suture line. It does not require any foreign material and does not use weakened muscle or transversalis fascia for repair. The results are superior to those previously published in the field of the hernia surgery. To validate the use of the physiologically dynamic tension-free inguinal herniorrhaphy using external oblique aponeurosis, its comparison to the open mesh that is Lycaniston, the criterion standard must be established. The purpose of this study is to attempt to establish the influence of the new technique on early clinical outcomes of inguinal hernia repair, and if approved to be effective, it will be basis for the promotion of its use. Aims and objectives. Aims was to find out the better surgical technique of primary inguinal hernia repair between the Desada and the Lycaniston methods, and objective to compare the mean operative time, the mean hospital stay, post-operative pain, and the other complications, if any. Inclusion criteria: normal external oblique muscle at preoperative finding, and those who have given the written informed consent. Exclusion criteria is a divided, tiny, and weak internal oblique aponeurosis in the strangulated hernia or forced hernia reduction with subsequent hospitalization. Method: it's a hospital-based prospective randomized control intervention study from period January 2019 to June 2020 on 120 patients of either gender and meeting inclusion criteria, of which 60 selected for non-mesh group and 60 for the mesh group. Sampling procedure: the patient with inguinal hernia seen in SOPD will interview and clinically assess. The purpose of the study and the methods of the treatment were carefully explained to the patients individually. They were allowed to ask questions freely to ensure they had understood. Screening for suitability for surgery included history taking, physical examination, requesting for and reviewing the laboratory test. This was aimed at recording the key research variables and major comorbidities. Those who did not satisfy the inclusion criteria and had other medical problems were offered the routine care given to all patients in SOPD. Those who met the inclusion criteria and consented to participate in the study were enrolled in the study until the required sample size attained. Results developed after the completion of the study show the mean hospital stay in the non-mesh group was around 1 day, 1.72 days, and in the mesh group was around 2.5 days. For evaluation of the pain, the mean visual analog scale pain score at 7 day non-mesh group was 0.16 plus minus 4.22, and in mesh group was around 0.46. On 13th day, the mean pain score in the non-mesh group was around nil, and in mesh group was 0.19, with difference of 0.92 with p-value less than 0.05 with statistically significant, and there were no recurrence found in both the groups up to the 6 months. However, longer follow-up required, and return to the normal activity in terms of the number of days not statistically significant. Conclusion: the technique of the Desada is tension-free herniorrhaphy, which do not require any foreign body like mesh and typical posterior wall dissection, so easy to perform, and it is superior to Lycaniston in terms of less mean hospital stay in terms of post-operative pain. However, no recurrence was observed in both groups during the study. And these are the pictures which showing the steps of my procedure. In the first, as usual, the incision was basically given on whatever the side of the hernia is developed to the patient. Then the dissection is started and the external oblique aponeurosis was incised, and the hernial part is in the hand, and it was the cord structure along with the hernia contents were reduced. And in the fourth picture, the hernial sac is completely separated and is inverted and reduced back. Then the external oblique aponeurosis, the medial leaf is basically sutured with the inguinal ligament, as is shown in the figure, with the 2,0-polypropylene. And then incision is basically made on the medial leaf of the inguinal ligament, which is sutured, and then it is sutured with the conjoint tendon. Now, this way, it's basically giving appearance of the fixation of the mesh as we done in the Lycaniston repair, and it's give the whole stent to the posterior wall. And then the same as the closure of the hernia is done as we done in the normal lichen stent mesh repair. Thank you, sir.
Hello.
Yes.
What about the tension in Desada? And what about the size of the hernia? Size of the hernia, suppose a big hernia is there and you are repairing by this method.
No,
Is
sir,
it possible to?
No, it's not possible, sir. It's weakened the external oblique aponeurosis, and in this procedure, I required a.
And then what about the tension in small hernia? What about the tension? Because it should be tension free. The first classical thing about the hernia repair is that tension free. That's why Lichtenstein tension free. So what about the tension in this? You are taking from the external lacunar ligament, then then that inguinal ligament, taking to the external that pseudo sac, then this internal oblique to this. So I'm concerned about two things. One thing is about the big hernia, and another thing about the that tension of in your Desada repair. Will you answer, please?
Yeah, definitely, sir. If the patient is having a large hernia, then we will not opt this procedure because it's weakened the external oblique aponeurosis fibers, and we're not able to use it like as the Professor Desada used. And in the tension free, as when we take the suture bites from the inguinal hernia to of the external aponeurosis to the inguinal ligament, then we give the another incision on the suture side. This will release the tension, and that we suture with the conjoint tendon on the medial aspect. So this
is it purely? Okay. How much you did at your center?
There is around 60.
Okay. Dr. Bhamar, sir, please.
Dr. Ram Gopal, if you have to ask, you can ask.
Yes, sir. Yes, sir. Dr. Pradeep. Hello.
Yes, sir.
What is the main difference between these two, Lichtenstein or Desada, regarding the tension? Both are tension free. Regarding the tension, both are tension free, or there are some tension in the Desada?
So definitely there is some tension in the Desada as we are suturing the, but that
yes. There are you create some tension by suturing
here and there.
Hello.
Yes, sir.
So what is the major advantage of the Desada? Why you want to do this type of the procedure in this like the old age persons?
There is no use of any foreign material as we use the patient's own tissue in the Desada.
So how many cases you have seen that there is some type of the foreign body mass and irritate the patients or
Proline is also, and proline is also foreign body, which proline they are using for repairing. That is also foreign body. It's less or more.
Yes, sir. I am agree with you. The same material, the proline mass and proline suture you use in the repair of the Desada, right?
Yes.
Then how can you say that is act as a foreign body and other suture material not act as a foreign body? Agree you?
Yeah, agreed, sir. But in the Lichtenstein method, we basically use the mesh, and to the surface area we are basically exposing.
So
the mesh is more in comparison to the suture bite or the suture we have taken.
So it's matter of quantity.
Yes. Yes.
So it's better to use some biological material for Desada repair. Ask Professor Desada, sir, to use some biological material. It may be useful. It's my opinion only. Thank you, Dr.
Thank you.
Thank you.
Dr. Piyush, there is a question in the chat box. What do you do in strangulated hernia?
Yes, ma'am, in strangulated hernia is the exclusion criteria of my study. We're not going to attempt this technique in the strangulated hernia.
Yes.
Why?
You don't attempt these methods in strangulated hernia.
Yes.
Thank you, Dr. Piyush. Next presenter, please. Next presenter.
Thank you, judges. Next session, Rupesh ji, please announce the
Next session is
Dr. Rambabu, can you stay back?
Hello, yes, ma'am.
Stay back to judge.
Okay, ma'am.
Dr. Kalpana ma'am is the judge, Dr. Rambabu Meena, Dr. Sadatullah Khan, Dr. Navneet Sharma. And the first presenter is Dr. Priya Gupta.
Priya, go ahead. Priya, and share the screen. Slideshow.
Am I audible?
Yes. Slideshow. Yes. Thank you. Start.
Good evening, everyone. I am Dr. Priya Gupta, third year surgical resident at BJ Medical College, Ahmedabad. I have done my paper on a study of cases of gallbladder perforation during the COVID pandemic in our hospital under guidance of Dr. Apur Shah and Dr. Vineet Chauhan, sir. Gallbladder perforation is a rare and life-threatening complication of gangrenous gallbladder, which occurs mostly due to acute acalculous cholecystitis or even with polylithiasis. Gallbladder perforation has a high morbidity and mortality rates because of delay in diagnosis. Thus, it still continues to be an important problem for the surgeons, and most cases are only diagnosed during the surgery. Also, it has been proven that COVID-19 is a hypercoagulable state, which is emerging as a major pathological occurrence with serious consequences in mortality and morbidity for the patient. The clinical manifestations of both widespread microvascular as well as large vessel thrombosis have been recorded. The aim of my paper is to study cases of gallbladder perforation during the COVID pandemic and establish increased incidence of gallbladder perforation to delay in seeking of medical attention due to COVID pandemic, and to compare the underlying cause, polylithiasis versus acalculous cholecystitis, and the possibility of COVID infection as a risk factor for acalculous gallbladder perforation. My study is a retrospective study which was conducted with inclusion of 68 patients with acute cholecystitis who presented to our hospital from March 2020 to August 2020. Patients who presented with acute abdominal pain, fever, tenderness, and rebound tenderness were subjected to ultrasonography and CT examination, as well as for laboratory workup for acute abdomen. And the patients with clinical and intra-op diagnosis of gallbladder perforation were included. Cases of gallbladder carcinoma and patients younger than 18 years of age were excluded from the study.
और उसमें टाइम पे लेना zoom.us करके.
Dr. Piyush, please mute yourself. Dr. Piyush.
Results. We included a total of 68 patients of acute cholecystitis, out of which 12 were diagnosed to have gallbladder perforation, which gives us an incidence of 17.6%, out of which 7 patients were female and 5 patients were male. And if we compare the incidence of gallbladder perforation for the same amount of time period in last year, that is from March 2019 to August 2019, we had only 4 cases of gallbladder perforation out of 61 cases of acute cholecystitis. That implies that the incidence last year during the same time period was 6.56%, which is now 17.6% during this study. Gallbladder perforation was most common in the 5th decade of life, mean age being 53.2 years. And mean time for the patient to present to the hospital after an acute attack of acute cholecystitis was 20.8 days. We had done open cholecystectomy in 9 patients, and we had started with laparoscopic cholecystectomy in 3 patients, but it had to be converted to open cholecystectomy. And there was uneventful outcome in 8 patients, whereas due to partial cholecystectomy, bile leak was present in 2 patients, and 2 patients expired due to complications of septicemia. A complete cholecystectomy was possible only among 6 patients, whereas a subtotal cholecystectomy was performed in rest 6 patients due to dense adhesions present in the calyx triangle. We took up 68 patients of acute cholecystitis, out of which 12 patients presented with gallbladder perforation. On histopathological examination, 7 patients were diagnosed to have calculous cholecystitis, whereas 5 patients had acalculous cholecystitis. Out of the calculous cholecystitis patients, 2 patients were COVID positive, whereas 5 were COVID negative. And out of acalculous perforation due to acalculous cholecystitis, 3 patients were COVID positive and 2 patients were COVID negative. Discussion, the inflammation of the gallbladder may progress and cause ischemia and necrosis, thus resulting in gallbladder perforation in 2 to 11% of acute cholecystitis patients. But in our study, we have seen that during the COVID pandemic, the incidence of gallbladder perforation was 17.6%, which is significantly higher. And usually we see that mean time of diagnosis of gallbladder perforation was about 5 to 20 days in a study conducted by Young et al. Who treated the cases of gallbladder perforation in emergency department, whereas in our study, the mean time of presentation to emergency department was 20.8 days. And the majority of people owed this delayed presentation to the factors such as lack of transportation and the fear to approach hospitals during the COVID pandemic. Routinely, we see that between calculous and acalculous cholecystitis, the incidence of perforation due to acalculous cholecystitis is higher, which reaches up to 10 to 20%. But in our study, we see that gallbladder perforation was more common in patients with calculous cholecystitis, which can be attributed to microvascular thrombosis as well as delayed presentation of the patient to the hospital. And the incidence of acalculous gallbladder perforation in COVID positive patients was 25, as compared to 16.6% in COVID positive patients with calculous gallbladder perforation. Thank you.
It is a good study, Priya. But in this era, we are also studying this, and we have started putting drain prior to going for surgery. So, so that we could complete the laparoscopic cholecystectomy. Otherwise, we have to open the abdomen in this case.
Ma'am, we did not go for percutaneous drainage in any patient. We went for surgery.
We have done 5 cases, and we prior to operating, we did drainage, percutaneous drainage.
Okay.
Ram Babu?
Hello, Dr. Priya.
Good
Hello.
evening. Yes, sir.
Good evening to everyone. Incidence of gallbladder perforation more in acalculous cholecystitis in COVID patient. Why? What is the reason of this? What do you think about
Sir,
this?
because sir, usually also gallbladder perforation cases are more in acalculous cholecystitis only. But I have tried to find a correlation between COVID positive.
Okay.
In COVID positive patients, because of so there can be microvascular thrombosis of the gallbladder, which leads to gangrene of the gallbladder and causing subsequent perforation.
In diabetic patient also same features. Acalculous cholecystitis more common in diabetes. Same in COVID positive patient also. Why? Because immunity is also low in both patients. It may be reason of this perforation. Okay.
Yes.
Okay.
Dr. Ram Gopal, if you want to ask any question. Dr. Kalpana, ma'am. If there are no questions, we'll move on to next presenter.
Next is Dr. Rajat Goyal.
Thank you.
Good afternoon, everybody. My topic for today is strawberry gallbladder. And strawberry gallbladder is also known as hyperplastic cholecystosis. These are a spectrum of non-neoplastic proliferative disorders caused by the deposition of cholesterol-laden macrophages within the wall of the gallbladder. Cholesterolosis occurs due to accumulation of cholesterol esters, triglycerides in the subepithelial surface macrophages and gallbladder epithelium. It is associated with bile supersaturation with cholesterol, but not with the increased serum cholesterol. It occurs in two forms, diffuse and localized. The strawberry gallbladder refers to the diffuse cholesterolosis, which is characterized by small cholesterol deposits like strawberry seeds. The yellow uh, macrophages laden is deposited over the epithelial surface of the gallbladder, which resembles the strawberry seeds. It is a pathological finding mainly instead of clinical diagnosis. Gross features in the histopath for the strawberry gallbladder is yellow deposits on the mucosa. Bile in the lumen is generally dark and thick. Microscopic features, foamy macrophages in the lamina propria and epithelium. Usually it is restricted to the gallbladder only. The case report, a patient of 20-year-old female was admitted with a complaint of on and off pain over the right hypochondral area for 4 weeks. And there was no history of vomiting, fever, jaundice. And the patient was asymptomatic. Then she has a pain which was sudden in onset and gradually increasing. And the pain was present only over the right hypochondrium. It was not non-radiating. On examination, patient was well oriented, conscious, vitally stable. On inspection, there was no abnormal findings. And on palpation, the abdomen was soft, no guarding, no rigidity. The tenderness was present over the right hypochondrium. On percussion, there was no fluid thrill. On auscultation, bowel sound was present. And bladder and bowel habits were normal. On investigation, routine blood investigations and was sent, and the LFT was sent. USG whole abdomen, no calculi, and thickened gallbladder wall was seen. As you can see in the USG, there was thickened gallbladder is showing here. And the management, after giving the symptomatic treatment for the acute, patient was not relieved. So we underwent elective laparoscopic cholecystectomy. And on intraoperatively, the gallbladder was inflamed, and on cut section, it shows congestion and thick wall. So biopsy was sent for histopathological examination. These are the pictures which we have find after OT. And on histopathologically, the columnar epithelium with basal place nucleus shows mucosal prolapse into muscularis and foamy macrophages in lamina propria and epithelium. As you can see in the slides, on the right side, the blue lines with the basal nuclei are placed in the columnar epithelium, and the white circular area is the foamy macrophages in the lamina propria and epithelium. So conclusion is cholesterolosis, though cited in many archives, remains a benign ambiguous entity due to its inconclusive epidemiology, controversial association with variety of diseases such as hypercholesteremia, alcohol, smoking, polylithiasis, cholecystitis, and relatively asymptomatic course, but safe and potentially treatable with cholecystectomy. Thank you.
Hello, Dr. Rajat.
Yes, sir.
In
Good
all
afternoon, sir.
case of strawberry gallbladder, indicate a cholecystectomy necessary or not?
Sir, no, necessarily not. If patient is having some symptoms or pain, then only we go through the OT, operative management.
Is it a pre-malignant condition or not?
Sir, it is a pre-malignant condition.
Why? So you should go for cholecystectomy in all case.
No, sir.
It may convert in malignancy.
Sir, it can convert in malignancy, but symptomatic patient only goes to the operative management.
Ram Gopal was.
Hello, Dr. Rajat.
Good afternoon, sir.
Good afternoon. What type of the surgery you want to? Open or lap chole?
So it was a lab.
Why?
Lab
And why? And why?
So because the patient is patient has a complaint of only pain, there was no associated comorbidities. So we underwent for lab, and if there was any problem in intraoperatively, so it can be converted into the open.
So strawberry gallbladder is the pre-operative finding or post-operative findings?
So strawberry gallbladder is a post-operative finding after the histopathological confirmation.
We cannot diagnose by the preoperative by some investigation like the USG, CCT abdominal?
Sir, in the USG also there is thickened gallbladder seen, which can be seen in many other cases also. And sometimes the cholesterol levels in the body is high, but sometimes it can be normal. So it cannot be diagnosed properly or confirmatively preoperatively.
So,
So
okay.
it can
So
be
we
diagnosed
cannot.
intraoperatively or postoperatively.
So if the patient is symptomatic with strawberry gallbladder or cholestasis, then go for the lab chole. Right?
Sir, lab chole, and if there is any complication during the OT, we can do open. Or if patient has some comorbidity and laparoscopic cannot be done, then we can go for open cholecystectomy.
Okay. Right. ठीक है, बड़े nice presentation.
Rajat, what is the precautions we have to take while we are operating such type of gallbladders?
We have to take the precaution that symptomatic patient symptoms are present or not, and ma'am, we can differentiate it between the malignant conditions also like carcinoma or not. So ma'am, biopsy is important after the OT also, as if there is carcinoma, we have to review the OT operation again, and we have to exclude the 1 to 2 centimeter area of the gallbladder around.
More important is that you have to take out the gallbladder in bag.
Yeah, with bag. Yeah, yes, ma'am.
You should remove
Yes,
the gallbladder.
You should put a gallbladder in the bag and then remove.
Sir, whole of the gallbladder should be removed. It should not be
touching with outside.
Yes, sir.
Okay, good presentation. Next.
Thank you. Thank you, sir. Thank you, ma'am.
Next is Dr. Rajesh Chahil. Dr. Rajesh.
Hello.
Rajesh, make it a slideshow. Rajesh, make it a slideshow.
Okay.
Yes.
Good evening, everyone. May I presenting trauma or injury has been defined as damage to body. Trauma is the introduction. Trauma or injury has been defined as damage to the body caused by an exchange with environmental injury that is beyond the body resilience. Trauma remains the most common cause of death for all individuals between the age of 1 and 44 years. It is the most common cause of death regardless of age. Modern day have been a tremendous improvement in man's
Dr.
lifestyle.
Rajesh, speak loudly.
Yes. Modern day have been a tremendous improvement in man's lifestyle and comfort, but along with comfort, serious challenging threats to human health has also been emerging. The rapid increase in the number of motor vehicles and its aftermath has resulted in very rapid increase in number of victims to blunt abdominal trauma. Without increased effort and new initiative, the total number of road traffic deaths worldwide and injury is forecast to rise by some 65% between 2000 to 2020. And in low income and middle income countries, deaths are expected to increase by as much as 80%. The abdomen is a diagnostic black box. Abdominal injury is significant cause of morbidity and mortality. Expedient diagnosis and treatment of intra-abdominal injuries are essential to prevent morbidity and death. Trauma is the most common cause of death in young patients. The abdomen is third most common injured region, with surgery required in about 25% cases. The main cause of blunt trauma abdomen are road traffic accident, fall from height, or fall from object or body, and assault. Majority of abdominal injury are encountered in emergency are due to blunt trauma abdomen. Majority of blunt trauma abdomen cases, 75% are related to motor vehicle collision. In spite of the best available technique and advances in diagnostic and supportive care, the morbidity and mortality remain at large. The reason for this could be due to the time interval between the trauma and hospitalization of the victim, inadequate and lack appropriate surgical treatment, delay in diagnosis, post-operative complication, and associated trauma, particularly to head and thorax. During the past 3 decades, there has been a major shift from operative to selective non-operative management of the injured patient. Traumatologists caring for adult patients began to follow the trend initiated by their pediatric counterpart after an increasing amount of evidence supported non-operative management of great majority of pediatric splenic and hepatic injury. It was subsequently shown that even the presence of hemoperitoneurosis and altered mental status do not seem to negate initial non-operative management in blunt abdominal trauma, even in patients with higher grade injury or those of older age. The increased utilization of non-operative and conservative management of abdominal solid organ is facilitated by the various sophisticated and highly accurate non-invasive imaging tools at the trauma surgeon disposal. The non-operative approach relies heavily on the availability of trauma-trained surgeon, advanced radiographic imaging, with JLN Medical College Ajmer being tertiary care center and the availability of blunt injury cases in abundance. This study would serve to evaluate the mode of clinical presentation of various blunt abdominal organ injury, additional to operate or non-operate management depending on the outcome of clinical examination and result of diagnostic test with the reference to its post-operative morbidity and mortality. The aim and objective study are to evaluate the pattern and outcome of blunt abdominal trauma with solid organ injury using hemodynamic stability status, USG and CT as parameter. To evaluate role of various available investigation for detection of solid organ injury. To compare conservative and operative management of solid organ injury in the blunt abdominal trauma. To arrive at a treatment protocol for management of solid organ injury abdomen. Methodology. The source of data will be from pre-tested pro forma, which takes into account clinical history, general physical examination, relevant investigation, imaging modalities, and follow-up of patient, which will be spread over the study period from January 2019 to December 2019. The study will perform on 50 patients selected from inpatient in trauma ward, Department of General Surgery, JLN Medical College, and associated group of hospital Ajmer. They will be diagnosed clinically after satisfying inclusion and exclusion criteria in the study. Inclusion criteria: patient admitted with blunt abdominal trauma with solid organ injury with age more than 18 years. And exclusion criteria include patient admitted with penetrating abdominal injury and patient admitted with hollow viscous injury. Result: there is a sex incidence there is male at gender have 86%, and whereas in female there is 14% sex incidence in blunt trauma in solid organ injury. The incidence of age majority include group 21 to 30 year of age, and the second most group which it include is 31 to 40 year of age. There is a mode of injury which include 31% only due to road traffic accident, accounts 62% of fatality. In clinical presentation, the abdominal pain account the most significant symptom by patient in 90%, followed by abdominal distension in 29 cases, and hematuria, guarding rigidity, and shock. The organ in my study, the organ injury in 21 cases, there is 42% is liver, followed by spleen, which is 26%. There is a ratio of operative conservative treatment include 34% we have done conservative treatment, while rest needs surgery. It can be concluded from this study that depend on patient's hemodynamic stability and finding of imaging studies, timely initial resuscitation and correct diagnosis, prevent morbidity and mortality in patient. Non-operative management hemodynamic stable patient is better option as there will be less hospital stay and less complication. Conservative management of liver and splenic injury can be done in patient with stable vitals and grade 1 and 2 grade 2 splenic and liver injuries. Early diagnosis and repeated clinical examination and use of appropriate investigation forms the key in the managing blunt abdominal injuries. Thank you.
Judges, questions, please.
Hello, Dr. Ravinder.
Sir, Dr. Yes, sir.
Dr. Rajesh.
Yes, sir.
Yes, sir. Your study is based only for the solid organ injury. First,
Yes, sir. Yes, sir.
you not include the hollow viscous injury.
Yes, sir.
What is the most common organ injured in your study?
Sir, liver.
It is liver or spleen?
Sir, liver.
How many percent? How many percentage?
Sir,
You have done the study and you don't know the percentage of the injury. How much percentage involved in the livers and how much percentage involved the other organs like the kidney,
46%.
spleen?
Yes, sir.
46% in.
Yes, sir.
You find the liver injury. And what is the major type of the injury, like the grading? What type of the gradings you find in liver injury?
Sir, grade 1 and grade 2 are.
How can you define?
Sir, by CCT abdomen, sir. In
What is the definition of the grade
in,
1?
sir,
I
liver.
want to.
Yes,
I
sir.
want to know what is the definition of the grade 1 injury of the liver, grade 2 injury, grade 3, grade 4.
Sir, grade 1 it account the injury of hematoma, subcapsular hematoma less than 10%, or in grade 2 it include 10 to 50%.
No, it's not like that. You should go again and study properly. It's not like that.
Hello.
How much?
Dr. Rajesh, continue.
Yes,
Continue.
Sir, in the grade 3,
Without knowing the gradings, you can't manage the patients. If you know the proper grading, one side you say that grade 1 and grade 2 can you manage by the conservative management.
yes.
But you should know the first you should know the grading of the injury for the liver, for the spleen, for the kidney. Right? After that,
Yes,
you can manage the patients. So what is the ideal protocol of conservative management?
Sir, when patient first come in our casualty, we have checked its vitals. Sir, if mainly patient come with abdominal pain and in shock or with feeble pulses, then our first step is take to stabilize the patient, otherwise giving sir fluid or sir blood. Or if then if patient is responding from our initial resuscitation, then we then our next is to do sir USG fast or X-ray FPA to rule out if there is any other perforating injury or not, or any other injury. Or in that scenario, sir, if the patient is stable, then we have monitor its vitals regularly, and sir, it's we send her hemogram, and repeatedly, sir, we check whether the pulse is the patient is deteriorated or it becomes stable. If the patient is stable, then we go for the conservative, or otherwise, if patient is deteriorate with our effort, then we go for the operative procedures.
What is the definition of the stability? Patient not deteriorating. What is the definition of the stability?
Yes, sir.
When
Sir,
you can say that this patient is stable. What is the criteria for that?
The patient come with some vitals after improving our effort. If rapidly the pulse and BPR falls down, then it becomes.
If the BP is 120 and pulse was 120 or 124, what is your plan? If the pulse rate is 124 at the time of the admission, so whatever is the plan?
Sir, if it remain that same, then we opt for conservative treatment. But if they regularly if the pulse is increasing and the BP is fall, then we we may thought that there is maybe some
What other parameters you want to check?
sir, hemoglobin, sir.
If the patient is a BK with road traffic accident, what other parameters you want to check?
Sir, there is no other chest injury or any head injury or sir with any bone injury, sir.
Good. Any others? You should examine whole of the body.
Yes, sir.
From bottom to head to bottom.
Head to leg, sir.
Right? Head, chest, neck, abdomen, pelvis, limbs.
Yes,
हो सकता है वहाँ फेमर फ्रैक्चर हो, वो आपने चेक भी नहीं किया हो, तो उसी वजह से जा रहा हो, pelvic फ्रैक्चर हो, स्प्लेनिक इंजरी हो, mesenteric इंजरी हो, solid organ इंजरी नहीं हो रहा हो, है ना? तो you must follow the rules of the treatment before deciding whether it is managed by conservative or by the operative procedure.
Yes.
Next, Dr. Ravind.
Yes, sir.
Next, sir.
Good afternoon, everyone. Today I am going to present a study of evaluation of continuous versus interrupted abdominal facial closure in patient with peritonitis. Under guidance of Dr.
Everyone else, please mute yourself. Everyone else, please mute yourself. Continue, Ravindra. Ravindra, continue. Dr. Ravindra, start.
I think his network is down. That's why he's not able to connect.
No, the host have probably in the conference office have muted all.
No,
That is the
No,
reason.
sir. No, sir.
No, JP. It is problem of Dr. Ravindra.
The screen is stuck, so I think it's a network issue only.
So I have to stop this presentation.
Can we call next participant?
Yes, sir.
Call the next participant.
And myself, Dr. Rohit Soni.
Just a moment.
Hello.
Dr. Rohit Soni, please share your screen.
Yes, sir.
पूरा चेक करना बेटा, ढंग से खोल लो ना।
Dr. Ravinder. Dr. Ravinder, can you hear?
Hello.
Dr. Ravinder, can you hear us?
Closing. Not stopping shit. Now Rohit Kumar Soni, please. Dr. Rohit,
Yes, sir.
please continue.
Sir, I'm presenting a comparative study of three-stage mesh hernioplasty versus conventional Lankenstein inguinal hernia repair. Sir, background and aims. Prosthetic mesh are routinely used to repair abdominal wall hernias. Several techniques are used to mesh implantation and most involve suture to encroach and mesh. Suture placement is time consuming and often challenging. In addition, these sutures cause extensive tissue tension, predisposing to infection, nerve entrapment, causing prolonged post-operative pain. In order to avoid the above disadvantage, it was proposed to that propylene mesh is applied with a less or without suture fixation to the surrounding tissue. The aim of the study is mesh fixation with suture and on its recurrence and to compare outcome of tension-free mesh fixation using three-stitch conventional Lankenstein tension-free mesh hernial repair. So method patient between 18 to 60 years were admitted to elective inguinal mesh hernial repair were enrolled in the study after signing an informed consent. Exclusion criteria include the following: age less than 18 or more than 60 years, patient with recurrent or complicated hernia, emergency inguinal hernia repair, laparoscopic inguinal hernia repair, chronic steroid treatment, coagulation disorder, ongoing chemotherapy, connective tissue disorder, and psychological and physical disorder that could affect the ability to feel and elaborate pain. 50 hernia patients who fulfill the sample selection randomized divided into two groups, group A and group B. Each group will have 25 patients. Group A was operated in classical Lankenstein technique, and Group B Lankenstein technique with three-stitch fixation method. In Group B, the mesh will be fixed only three proline stitches. First stitch on the pubic tubercle, second stitch on the inguinal ligament 1.5 centimeter lateral to the pubic tubercle. Third stitch is from the medial most part of the conjoint tendon. The two posterior wing of the mesh will be stitched with a single proline stitch, paying attention to take only the mesh, not any tissue. The fascia will be closed in both groups with a vertical running suture. Skin will be closed with a nylon simple mattress interrupted suture. Now will never be prepare or cut in either group. All operations will be performed in spinal block. The operative time will be recorded by operative theatre nurse. The operative details will be recorded in performer. During post-operative will be measured by the visual analog scale. This will be compared in first week, month and third month. Result in discussion. Inguinal hernia is the most common surgical abdominal entity in the adult. In the past decade, Lankenstein repair has become gold standard for the treatment of inguinal hernia, mainly due to the reduction in the recurrence noted and due to the reproducibility of the procedure. It is used as a gold standard surgery for all type and size of inguinal hernia, with very few exceptions. One of the most crucial criteria for successful modern inguinal hernia repair is short recovery time combined with post-operative pain as minor as possible. Although the laparoscopic approach for the hernia repair is gaining popularity, the open technique remains the operation of the choice for the beginner. The first slide, first table show the demographic age distributions. So most commonly, the patient are in the older age. In Group A, the 10 patient or 40% are 51 to 60 age group, and Group B is 8 patient or 32% in 51 to 60 age group. Sir, second slide involved distribution of the two groups of the patient study. Most commonly, the right side inguinal hernia are most common in both of the group A and Group B also. And sir, 4 table type of hernia distribution in 2 groups of the patient. In this right-sided indirect inguinal hernia are most common, and sir, bilateral indirect hernia are least common in my study. So operative time in the present study, the mean time difference between the conventional group and the stitch group with respect to operative time is 4.88 minutes. The duration of the study was shorter in 3 stitch group. The main time difference. These are the other study that we have that I compare with my study. Kim Folks and other Novoski and Tennessee's pain assessment. In the present study, the post-operative VAS score in the 3 stitch group was significantly lower than the conventional group. The VAS score is considered in post-operative table showing post-operative day 1, post-operative day 3, and post-operative day 7. The VAS score is lesser in the group B of the patient. Comparison of the complication. In comparison of chronic pain and recurrence is in the different study. As I compare with the other study, it shows similar result as chronic pain is more common in classical Lankenstein repair in compare with the 3 stitch study. And the comparison of the complication, the seroma rate is more common in classical Lankenstein repair is compared to the 3 stitch repair. And duration of the hospital stay is lesser in the 3 stitch repair that was similar to the other studies. So conclusion, the present study compare classical Lankenstein repair with 3-point mesh fixation for the inguinal hernia, come out with the following conclusions. The operating time for the 3 stitch fixation is lesser overall by 4.88 minutes. 3 stitch fixation of the mesh is easy to perform and easily reproducible. 3 stitch fixation of the mesh can be done in younger and older age group with equal efficacy. The post-operative pain is significantly lesser in the patient who underwent 3 stitch fixation for the mesh compared to the patient who underwent classical fixation of the mesh in the early and the late post-operative period. 3 stitch fixation mesh fixation group has lesser compared to the classical mesh fixation, and the incidence of other complication was similar in the both of the group. The patient who underwent 3 stitch fixation of the mesh had earlier discharge and compared to the patient who underwent classical fixation of the mesh. There is a dramatical difference in the incidence of chronic growing pain in 3 stitch fixation of the mesh as compared to classical fixation of the mesh, as there is a lesser risk of nerve entrapment. After 3 months of follow-up, 0% of chronic growing pain in 3 stitch group as compared to 16% in the classical group. After 3 months of follow-up, there was a 1 recurrence in 3 stitch group in our study. The patient has large defect and has thinned out musculoepineuritic fiber. The incidence of long-term complication of 3 stitch hernioplasty are compared to that of other standard tension-free open hernia repair as well as other laparoscopic procedure. However, the only limitation that we have in our study is duration of the follow-up. Moreover, the 3 stitch hernioplasty method is simple method, easy to beginner to adopt, has less foreign body reaction, less time consuming, causing less tissue trauma and lesser chance of vascular injury. So that's all from my side, sir.
Judges, questions, please.
Hello. Hello.
Hear you.
Yes, Rohit, nicely presented by you.
Thank you, sir.
But your results are like they are manipulated. They are looks like not real outcomes of this study.
Sir, in what scenario?
In everything, you can say there is foreign input.
Hello, Dr. Rohit.
Hello.
Hospital stage less in 3-stitch hernioplasty. Why?
Well, that is not much a difference
Hospital
between three.
not related to this.
Three.
And any difference in the results of direct hernia or indirect hernia? Dr. Rohit.
Dr. Rohit, can you hear me? म्यूट कर लिया था उसने फिर।
अब आप ऐसा करोगे तो करेगा ही ना।
Stay में, I think according to
we have to look for the time also. Can we go on to the next candidate, please?
Next is Dr. Sahil.
Good evening, sir and teachers. Am I audible?
Yes.
Here my presentation, sir. Myself, Dr. Sahil Midha, finally Resident General Surgery, Sardar Patel Medical College, Bikaner. Here going to present the case of Sister Mary Joseph Nodul, present in a case of stomach or gallbladder carcinoma, a case report with my co-author Dr. Sonali Ala. For introduction and aims, the slide is visible, sir?
Yes, please.
Okay, sir. For introduction and aims, Sister Mary Joseph Nodule or Sister Mary Joseph sign referred to a palpable nodule.
Please, Dr. Sahil.
Into the umbilicus as a result of metastasis of a malignant cancer in the pelvis or the abdomen. Sister Mary Joseph Nodule could be the first sign of internal malignancy, which is usually found in the GIT, 52%, female genital tract, 28%, and non-specified origin, 18 to 20%. The majority of them are gastric or ovarian origin. However, cases from appendix, gallbladder, pancreatic, hepatobiliary, or endometrial carcinoma are also described. Such nodule is identified. It's suggestive not only the presence of malignancy but also the worst prognosis. Sister Mary Joseph Nodule, name was Julia Dempsey, was working as a superintendent nurse at St. Mary Hospital, Rochester, Minnesota. When she identified as a umbilical nodule could be the sign of intra-abdominal malignancy or pelvic malignancy. Sister Mary Joseph was the first surgical assistant under the guidance of Dr. William, who first reported the condition as pant button umbilicus in 1928. The eponym was coined to her by Hamilton Bailey in 1949 in his book entitled Demonstration of Physical Sign of Clinical Surgery. Now, the aim of the study is to describe how a clinical presentation of umbilical nodule at the umbilical can reveal underlying intra-abdominal pathology. Case reported method. A 61-year-old woman presented to our OPD with bluish umbilical nodule of 3 cm with mild gastro-umbilical discomfort for 3 weeks. There was a lump in right hypochondrium. Percussion revealed ascites with shifting dullness. There was a unique finding that the gallbladder reaching up to the right iliac fossa. Actually, it was lump which was shifting to the right fossa. Now, triple phase CECT was done. The CECT of whole abdomen shows irregular, thickened, enhanced gastric wall involving cardia, fundus, and body of stomach. Gallbladder was distended, reaching up to pelvis. Soft tissue density mass in pouch of Douglas with thickening of rectal wall, indicating of metastasis. Ascites was present as mentioned earlier. On upper GI endoscopy, stomach mucosa thickened and erythematous. Biopsy taken at that time. On sigmoidoscopy, thickening and narrowing of rectum was noted 15 centimeters from the anal verge. And the mucosa was over thickened and biopsy also taken that time. Now result. Biopsy of stomach and peritoneal deposit revealed well-differentiated adenocarcinoma. Now the primary of this stomach and gallbladder carcinoma considered, and because this is fully metastasized, so patient received chemotherapy as primary treatment. Conclusion. Sister Mary Joseph nodule is an uncommon sign of advanced malignancy. Only 1 to 5% patient reported this. Now, cause of Sister Mary Joseph nodule carcinoma ovary. carcinoma cervix, pancreas and gallbladder, carcinoma stomach, carcinoma rectum, colon and small bladder was also there. Now, a single finding of umbilical nodule can be missed many a time, could be a sign of intra-abdominal malignancy, hence examine and noted carefully. Thank you.
Dr. Sahil, what is
Yes,
the
sir.
root of this metastasis?
Sir, transcoelomic spread. When it comes to the Sister Mary Joseph nodule or even pouch of Douglas, the transcoelomic spread was there.
And lymphatic also?
Yes, sir. Lymphatic spread was also there. Sir. Am I audible, sir?
Yes, yes.
Yes. Rambabu, sir, can you repeat the question? Last question.
Hello.
Hello. Yes, sir. Yes.
Any other differential diagnosis of Sister Mary Joseph nodule?
Sir, as I mentioned, sir, carcinoma, stomach carcinoma, even gallbladder, we
No,
consider
no.
carcinoma.
Suppose patient come to us with a node on umbilicus region. So what is the other differential diagnosis of this? It may be periumbilical hernia. It may be
Yes, sir.
foreign body.
Yes,
And
sir.
other.
Yes, the periumbilical hernia can be there. But sir, the classical bluish presentation, are suspect as to diagnosis of Sister Mary Joseph nodule at that time, sir.
Endometriosis also in female patient.
Yes, sir. Endometriosis in female. Yes.
And what about prognosis of patient with Sister Mary Joseph nodule?
Sir, Sister Mary Joseph nodule itself as a indicator of poor prognosis. Whenever it's appear, either with stomach carcinoma, gallbladder carcinoma, carcinoma ovary, it's always show poor prognosis. When it comes to our patient, sir, we send the patient to the onco physician, sir, because whole the metastases are there, sir, from the stomach to the pelvis. So, sir, poor prognosis was there.
Okay, good. JP boss.
Sir, next presentation is from Dr. Ravindra Kumar.
Thanks, sir.
Hello.
Yes, sir.
Yeah, please.
I am audible, sir?
Yes.
Today I am going to present a case study of evaluation of continuous versus interrupted abdominal fascia closure in patient with peritonitis under guidance of Dr. R.S. Meena, sir, who is a senior professor in Department of General Surgery and GMC Kota. A major surgical complications after emergency midline laparotomy is abdominal facial dehiscence. It may appear either as an early burst abdomen with evisceration, partial dehiscence, or a late complication like incisional hernia. Post-operative complete wound dehiscence is an unfortunate condition, and a serious complication is associated with high morbidity and mortality rate. These patients usually undergo multiple dressing fecal fistula formation, surgery for secondary facial closure, which is associated with markedly increased morbidity with high incidence of incisional hernia. A conventional continuous closure technique has been shown to compromise blood supply and thereby poor wound holding during initial phase of wound dehiscence. This study is aimed at comparing effectiveness of interrupted crisscross technique versus continuous closure of rectus with non-absorbable monofilament polypropiling, number one feature in midline laparotomy in emergency setting. Method is this is a randomized controlled study conducted among the patients presenting to the Department of General Surgery and NDS Hospital Kota during the period of January 2019 to June 2020. The inclusion criteria were patients who underwent laparotomy for peritonitis in emergency setting by midline incision, and the exclusion criteria were the patients with history of previous midline laparotomy and extreme aphasia. Group A, which is test group, includes 30% with the interrupted crisscross technique group, and Group B 30% conventional continuous closure group. Decision for emergency laparotomy made based on through history, clinical examination, emergency laboratory investigations such as CBC, blood glucose level, blood urea, serum create, LFT, emergency radiological investigations such as ultrasound of abdomen, chest X-ray PA and FPA after blood group and cross match. Group A underwent interrupted critical technique closure of rectus sheath as follows. A bite taken at A point, a point 2 cm from cut edge. The needle immersed at B point, another point 2 cm from cut edge. 4 cm cranial or caudal to A point. Two ends of suture strand crossed. Needle enter at D point and come out at C point. Point C is 4 cm away from A and 2 cm from cut edge. Point D 4 cm away from B and 2 cm from cut edge. Two ends of suture tied in front of linea alba. Small three end of suture pulled inside with an artery forceps or a right single forceps. Small free end of suture tied with long extent of suture. Group B was conventional continuous closure of rectus sheath as follows. Each bite taken 2 cm from the cut edges of linea alba. Successive bites taken 2 cm from each other. The edges of linea alba centrally approximated without strangulation with an attempt to keep suture to wound length ratio of equal or more than 4:1. Patients were assessed during post-operative period till discharge and subsequent follow-up at 2 weeks, 1 month and 3 months of procedure for wound digestion, sinus formation and surgical site infection. Length of wound, time taken for closure, length of suture material, duration of hospital stay, wound complications were recorded. Factors influencing wound healing such as anemia, hyperproteinemia, immunocompromised state like diabetes mellitus, hypertension, liver disorder, renal disorder were recorded. Results: the study included patient age 19 to 65 years of age, with majority belonging to 30 to 50-year-old age group. The most common cause for laparotomy was gastrointestinal suppuration found in 32%. Next was intestinal obstruction in 18%, blunt trauma abdomen in 7%, and other causes in 3%. The interrupted criss-cross technique rectus closure Group A, as compared to the conventional continuous closure, Group B has significantly less wound infection, less wound digestion, less period of hospital stay, less incisional hernia, more length of suture material, and more time taken for suture, with mean time difference of 8 to 10 minutes. The ratio of wound length to suture length was 1:5.1 and 1:4.6 respectively. This is a comparison of post-op complications. In continuous infection and chances of incisional hernia are more. Out of 60 patients in the study, 18 patients with continuous closure developed wound infections, while only 11 with interrupted closure had wound infection. Out of 60 patients, 5 patients with continuous closure had wound adhesions, while only 2 patients with interrupted sutures had wound adhesions. Incisional hernia in the follow-up period of 6 months was found in 5 patients with continuous closure, while only 2 patients with interrupted closure had incisional hernia. Conclusion: in view of post-operative wound infection, wound adhesions, and incisional hernia, interrupted facial closure of midline emergency laparotomy is better than continuous closure. In patients with delayed presentation of perforation peritonitis and more amount of pyoperitoneum, the rectus sheath should be preferably closed with interrupted crisscross closure technique to prevent post-operative wound adhesions and reduction in the period of hospital stay. Thank you. Oh.
Dr. Deshraj, please ask questions. Unmute yourself and ask question. Unmute yourself and ask question.
Hello, I'm audible.
Yes.
Yes, sir.
So, Ravindra, what is the marginal distance in interrupted sutures?
Sir, in interrupted suture margin, it from cut edges there is 2 centimeters, and from one point to another point, difference the distance is 4 centimeters.
Okay. So, if there is a pyoperitoneum and there is a splage of pus and fecal matter in the suture line, so
Yes,
you
sir.
are saying
Interrupted is better, sir, in continuous. Yes.
Is there any difference in age groups? Whether
Yes,
the
sir.
old age is
In sir, old age where there is a laxity is more in and weakness is more in abdominal wall. So there should mass closure is more better than this both interrupted or continuous.
And the suture material applied. What is the suture material?
Sir, polypropylene, sir. 1 number suture material.
Interrupted suture for closure of the sheath.
Yes, sir.
Okay.
Thank you, Ravinder. Next presenter, please.
And this session is over now. We have come to next session from 4 to 5 p.m. Chairperson, judges is Dr. Deshraj Chawla, sir, Dr. Shivraj Binaji, Dr. Devesh Bhumia, and Dr. Narendra Sharma. First presentation is Dr. Sajal.
Dr. Kalpana? Dr.
Good morning, sir. Good morning, teachers. Hello.
Dr. Sajal, please share your screen.
Yes, sir. 1 minute. Is it visible?
Not.
It's not visible. 1 minute, sir.
Still not.
Is it visible now, sir?
Yeah, it's big.
Good afternoon to my dear teachers and my dear colleagues. Today, I, Dr. Sajal Gupta, second year resident of the Department of General Surgery from SMS Medical College and attached group of hospitals, Jaipur, is going to present on the topic the large and neglected giant phyllodes tumor of the breast. First, the introduction. Phyllodes tumor of the breast are the rare biphasic fibroepithelial lesions that contain two types of breast tissue. That is the stromal tissue, that is connective tissue.
Hello.
Good evening, ma'am.
And the glandular tissue, that is ducts and lobules. There is a resemblance with the benign fibroadenomas, and it's important to differentiate between the two entities. Phyllodes tumor contain a large spectrum from benign to borderline to malignant varieties according to the features such as tumor margins, stromal overgrowth, tumor necrosis, cellular atypia, and the number of mitoses per high power field.
Hello, Sajal.
Yes, ma'am.
Please give your PowerPoint presentation, not this in PDF. Where your PowerPoint presentation?
It is, ma'am, PowerPoint only.
It is not PowerPoint. In the Word.
What, ma'am?
In the Word presentation, not the PowerPoint presentation.
Ma'am, I have opened in the MS PowerPoint only. Ma'am, I have opened this in the PowerPoint only.
This is not PowerPoint presentation. Not always in the points, not in the paragraphs. Okay, go ahead.
Okay. They account for the less than 1% of all the breast neoplasms of the women between 35 to 55 years and are commonly affected. Median age of presentation is at 45 years. A tumor larger than 10 centimeter is called as giant tumor. These are found in 20% of the phyllodes tumors. Often they present as a rapidly growing and the painless mass, as in our case, with the patient presented with a breast lump of 35 centimeter in the greatest dimension, which started growing rapidly a few months earlier. Now the case report. A 55-year-old female homemaker presented with the complaints of huge left-sided breast lump from the last 4 years, with a history of breathlessness from the last 6 months. The Kanofsky performance status of the patient was 60. Patient also has a history of pain in the left breast since the beginning, that is from the last 4 years, for which she went to the local doctor and got some painkillers and was used to get relief. At that time only, patient also underwent the needle biopsy of the lump and was told to have the tumor, but there was no documentation with the patient, and the patient refused for the surgery at that time. Inspection showed a giant bosselated lump of the left breast with a fungating ulcer over it, which developed in the last 20 days. The lump measured 35 into 24 centimeter in the greatest dimension. The skin was stretched, surface appears bosselated with dilated veins over the mass, and there was a fungating ulcer over it. Palpation of the axillary, mediastinal, and the clavicular group of lymph nodes were negative. The right breast appears normal. The patient noticed this mass 4 years ago, which was of very small size at that time. Then it gradually increased in size. But since the last 6 months, it has grown rapidly, reaching the current size and exhibiting the overlying skin changes. There was no documented medical history. X-ray of the chest was normal, and CT scan of the thorax and abdomen were done, which were negative for staging. Neither the CT nor the sonography showed the axillary lymphadenopathies. There was no evidence of metastasis anywhere. A core needle biopsy of the tumor was performed in our institution, which showed a benign spindle cell proliferation, presumably a fibroepithelial tumor suggestive of a Phyllodes tumor. A simple total mastectomy on the left side was performed. No axillary lymph node sampling was done. Macroscopically, the specimen was 35 into cross 24 into 15 centimeter. The tumor weighed 12 kg. Microscopic examination confirmed the diagnosis of the Phyllodes tumor, varying from benign to borderline changes. Neither the skin nor the nipple showed the pathological changes. Surgical margins were also negative, and the laboratory examination of the patient was unremarkable. These are the post-op images of the patient, which shows a scar with the stitches, and the SP of the sample. Then the discussion. Phylloan is a Greek word for the leaf because of the tumor displays the characteristics of a large malignant sarcoma, which takes on a leaf-like appearance when viewed histologically. A Phyllodes tumor has a wide range of biological behavior, from benign, similar to fibroadenomas, to borderline to malignant with metastatic potential. These categories are based on the degree of stromal cellular atypia, mitotic activity per 10 high power field, and the degree of stromal overgrowth. These three are the main criteria. Others are the tumor necrosis in the margins. In contrast to fibroadenomas, a Phyllodes tumor grows very rapidly. The peak incidence is between the 45 and 49 years old. That is about 20 years later than the appearance of the fibroadenomas and earlier than most invasive ductal and lobular carcinomas. The radiologic examinations like mammography, sonography, and magnetic resonance imaging cannot differentiate between the two types of breast tumors. Whenever there are the indications of Phyllodes tumor, the diagnosis has to be made through the core needle biopsy. Because of the tumor heterogeneity, it is possible that core biopsies of the Phyllodes tumor show only fibroadenoma, so excisional biopsy is always indicated in all the cases. The results: patients underwent simple mastectomy with a negative suction drain placement, and the excised specimen weighed 12 kg with an uneventful post-op period and the symptomatic relief to the patient. Histopathology was suggestive of the low-grade Phyllodes tumor, benign to borderline in nature. And in the conclusion, the diagnosis of the Phyllodes tumor should be entertained in the patients presenting with a progressive enlargement of the breast lump. Emphasis should be given on the proper health education of the breast cancer and the negative consequences of alternative or delayed treatment. Excision should be done as soon as possible, as unnecessary delay can lead to disease progression and increase morbidity and mortality to the patient. Thank you. Hello.
Hello.
Hello. Yes, sir.
Dr. Sajal, how
Yes, sir.
will you differentiate between a giant fibroadenoma with Phyllodes tumor?
Sir, histologically they can be differentiated, and pathologically by the fibroadenomas will have a low mitotic index per 10 high power field, and the Phyllodes tumor because of this variety of the benign, borderline, and malignant, three categories can be there, so it can have high mitotic index per 10 high power field, and also the tumor necrosis and margins and cellular atypia will also differentiate between the two fibroadenomas and the Phyllodes tumor.
And clinically, how will you differentiate?
So clinically, fibroadenoma is a freely moving mouse-like structure in the breast. Like it slips under the hand when it is palpated. And the Phyllodes tumor, it's not like that. It's the size is also big, and it does not reach the chest wall, and it moves freely over the chest wall. but it does not slip under the finger like the fibroid characteristics of a typical fibroadenoma.
So it shows feature like malignancy to adherent with the skin or the chest wall.
Yes, sir.
It gives clinical picture like a malignancy to adherent with the chest wall or skin. It is true
No,
or
sir.
not?
No, sir. It was not adherent to chest wall, and the skin, because of the giant phyllodes due to the enlargement stretched skin, it was not pinchable.
So the to develop phyllodes mostly seen in which age groups?
Sir, it is classically seen between the 35 to 55 year age group, with the peak incidence in between 45 to 49 years, or it can happen earlier also.
So what is the surgery you will prefer with a
Sir,
simple excision?
Usually wide local excision is performed with 1 centimeter normal healthy tissue margins all around the breast tissue. But if it is a giant tumor or a recurrent tumor, or if it comes to be malignant, then the simple mastectomy can be done.
Okay. Okay, Dr. Sir.
Thank you, sir.
Next is Dr. Saket Patel. Dr. Saket Patel.
Dr. Saket is there?
Ashok Kumar is there. Who's this?
So
Okay.
please move on another speaker.
Dr. Satyam Shukla.
Hello.
Yeah, please share your screen.
Yes, sir. Just a moment, sir. Share करना screen. ये है ना नीचे. Hello.
Yes, please share your screen.
So just a second. Is it visible, sir?
Yes. Presentation. Presented view. Yeah, please. Okay.
Good evening to all the teachers and my fellow colleagues. Today I'll be presenting a clinical study of perforation peritonitis, a study of 100 cases. नहीं हो रहा. क्या हो रहा है ये?
Dr. Satyam.
Sir, I'm actually trying. Yeah, just a second. Sir. It's not moving. The slides were not moving, sir, previously. Okay, the introduction. Peritonitis is defined as an inflammation of the peritoneal cavity. Perforation peritonitis is one of the most common surgical emergency in India. The spectrum of etiology of perforation in India continues to be widespread, to be different from Western countries. And there is paucity of data regarding the etiology, prognostic indicators, morbidity, and mortality pattern. In majority of cases, presentation to the hospital is late with well-established generalized peritonitis with virulent fecal contamination and varying degree of septicemia. Now, the aim of my study was to attempt to know the etiology, the clinical profile, the aids to diagnosis and management of perforation peritonitis, including the management of complications encountered after the surgery. Now, the material methods was used. It was a prospective study conducted on 100 patients with signs and symptoms of perforation peritonitis admitted in PBM Hospital, Bikaner. The duration of study was 1 year, spanning from January 2019 to December 2019. All patients underwent necessary investigations, including detailed history and physical examination. Apart from that, blood investigation like CBC, biochemical analysis, and urine analysis was done. Diagnostic investigation included X-ray chest and abdomen, USG whole abdomen, and CT abdomen was done in selected cases. All diagnosed patients were subjected to surgery, and post of follow-up was done for a period of 3 months to look for complications and try to rectify them. Now, the results was as such. The site of perforation, the most common site which was identified was stomach in my study. It was the next most common site was identified as terminal ileum, and after that was appendix, and after that cecum and duodenum and so on. The cause of perforation was the peptic ulcer, that is ulcer in duodenum and stomach, was the most common cause for perforation. It was found in 55 cases or 55% cases. Enteric fever or post-typhoidal perforation was seen in 23 cases. Appendicular perforation resulted in 10 cases. Tubercular perforation was seen in 5 cases. Intestinal obstruction led to perforation in 4 cases. Now, the surgical procedures which were done, the most common surgical procedure done was omental patch repair, done in 55 cases. And after that, for enteric fever, it was closed primarily in 13 cases. Resection anastomosis was done in 5 cases, and ileostomy was made in 5 cases. Appendicular perforations were managed by appendectomy alone. 4 cases were there of obstruction. Out of those, 2 cases ended up in resection anastomosis, and 2 cases had ileostomy was to be done. Now, post-operative complications that were encountered after the surgery, the most common post-operative complication seen was fever in 90% cases. Paralytic ileus ranging for more than 2 days was seen in 84 cases. Wound infection and dehiscence was seen in 45 cases. Now, I would like to draw your attention here that wound infection and dehiscence, the total was 45 cases, and not all the patients with wound infection had wound dehiscence. Abscess, deep or superficial, was seen in 5 cases. Burst abdomen in 12 cases. Chest infection was pretty common. It was seen in 20 cases. Anemia and hypoproteinemia was encountered in 30 cases. And incisional hernia was seen in 2 cases. Now, because of lack of space, I have compiled 2 of my results instead of in tables. The management of complication was done in the follow-up period of 3 months. Out of 35 cases of wound dehiscence, 15 cases, that is 42.86% required resuturing of the wound. The rest of the cases were treated by local wound management. All the cases of burst abdomen were managed by resuturing. Ileostomy closure was, we were able to do ileostomy closure in 7 out of 9 cases. Out of 4 cases of anastomotic leak, 2 cases had to go for resection anastomosis again. Rest were managed conservatively. Out of 4 cases of obstruction, 2 cases, that is 50%, had to undergo exploratory laparotomy with adhesiolysis. Rest 2 cases were managed conservatively. All the cases of incisional hernia were managed by mesh repair of the defect. Overall mortality of the study was 9%. Highest mortality was present in obstruction pathology. That is, 1 out of 4 patient died during the course of treatment. Mortality in post-typhoidal perforation was 13%, and peptic perforation was 9%. Now, my conclusion: peptic ulceration is the most common cause of perforation peritonitis. The most common site of perforation is stomach. Diagnosis is made by clinical examination and confirmed by detection of pneumoperitoneum on X-ray chest, abdomen, USG of abdomen, and often by 4-quadrant aspiration. Pain abdomen was present in all the cases. It was present in 100% of the cases. Other symptoms were distension in 92% and fever in 77% cases. Abdominal tenderness, muscle rigidity, and guarding are the most common signs of perforation peritonitis seen in all the cases. Omental patching was the most common surgical procedure done in peptic ulcer perforations. Fever was the most common post-operative complication in 90%, followed by paralytic ileus and wound infection, anemia, hyperproteinemia, and chest infection. Incidence of resurgery in patients of perforation peritonitis was 40%, with most common surgical procedure performed was a resuturing of the laparotomy wound. That's 27%. Oral mortality in perforation was 9%, with highest mortality in obstruction patients. Thank you. Sir, your voice is inaudible, sir. Hello.
Hello. Hello.
Yes, sir.
Now audible?
Yes, sir.
So how will you manage a case of perforation peritonitis?
Sir, firstly, when the patient came to us, we tried to manage the patient to make the patient more hemodynamically stable. For first 4 to 5 hours, we tried to resuscitate the patient. We tried to correct the electrolytes. We tried to correct the dehydration. And only after that, when the patient was stable enough to be taken for the surgery, we explored the patient further, sir.
So in a case of peptic perforation,
yes,
which part is most commonly involved?
Sir, lesser curvature, sir, incisura angularis, which is the site for type 1 ulcer, according to modified Johnson classification, is the most common site involved, sir.
So the post-operative complications, you said there is a
sir,
wound dehiscence.
Yes, sir.
Most common is?
Most common, sir, that we found in our study, sir, it was pain, obviously present in all the patient, and fever, sir, in 90% cases, and 84% patient face paralytic ileus extending for more than 2 days.
Okay. So you always do ultrasonography for a case of perforation?
No, sir, not necessarily, sir. In old age patients, sir, where we suspect some cause of some malignancy where that could have led to obstruction and later it led to perforation, sir, there we would prefer, sir, to do ultrasonography, sir, not all cases. But in this
perforation there.
Yes, sir. But in this study, sir, all the cases underwent ultrasonography. Sir.
Okay,
Desraj, there is one question in the chat box.
Yes, ma'am. Just a second.
There is one question in the chat box. What is the clinical sign to differentiate from carcinoma in peptic perforation?
The clinical sign to differentiate it from
How will it differ between the benign and the malignant perforation in peptic?
Ma'am, histologically, we take a biopsy, ma'am, in all the cases.
For operative finding. For operative finding.
Ma'am, I'm not sure, ma'am. I can't say.
By only the perforation, you can diagnose it is because of the malignancy.
Okay, ma'am.
Okay, thank you.
Thank
Next.
Dr. Saurabh Garg. Dr. Saurabh Garg.
Hello, am I audible, sir?
Yes, please. Share your screen.
Okay, sir. Sir, is my screen visible?
Here it is visible. Go ahead.
Okay. A case of porcelain gallbladder by Dr. Saurabh, SMS Medical College. Introduction. Porcelain gallbladder is a very rare manifestation of chronic cholecystitis that consists calcification of the gallbladder wall. The pathogenesis is still unknown, and it is found in 0.05 to 0.08% of the cholecystectomy specimen. Porcelain gallbladder may be associated with gallbladder cancer in over 60% of the cases, and many asymptomatic patients with confirmed porcelain gallbladder will have advised to go for surgery to treat current or prevent future malignancy. Case report. A 50-year-old woman was admitted to hospital. Her medical history excludes all comorbidities like hypertension, diabetes mellitus, tuberculosis, and asthma. She was obese, and the only examination was notable was only for the diffuse distension, for which we got done an ultrasonography abdomen and thyroid profile. USG reveals porcelain gallbladder, minimum intrahepatic duct dilation, and with enlarged periportal lymph nodes, with no ascites. At time of admission, patient had no complaints in her abdomen, but incidentally diagnosed at porcelain gallbladder. Laboratory test showed total bilirubin 0.9 gram per dl, direct bilirubin 0.4 gram, AST 32, ALT 41, calcium level was 11.4, hemoglobin 12.9, lymphocytes 5%, neutrophils 71%, thyroid profile was within normal limits. For further clinical examination, IV contrast CCT abdomen was done, and it revealed that the gallbladder was completely calcified. The wall thickness was 10 mm, and the gallbladder was 73 into 5 into 2, 7 into 5 into 2 centimeter in size. She was classified under ASA physical status class 1. The patient was planned for an open cholecystectomy. The right subcostal incision was made to the abdomen. During surgical exploration, claimed calcification of the gallbladder wall was with hepatic extension, cystic duct and cystic artery was identified and ligated with cell 20, and complete dissection from liver bed for cholecystectomy was done. Multiple enlarged lymph nodes were cleared, and the specimen was complete solid form, and the post-operative period was uneventful. And on second day, oral soft diet was started and discharged on the third day of her operation. Biopsy specimen reveals calcified lesion of the gallbladder, that is porcelain gallbladder. This was the pic of the calcified gallbladder. Discussion. Porcelain gallbladder is defined as calcification of the GB wall. It is a rare condition and is seen in 0.6 to 0.08% of the cholecystectomies. It was first described in 1929. It is the most observed in patients in their 60s and has a greater incidence in women, ratio 4 to 5:1. The etiology of porcelain gallbladder is still unknown. Thus, some hypotheses suggest it is a rare manifestation of chronic gallbladder disease due to gallbladder wall hemorrhage and its subsequent calcification. We believe that the symptomatic patients should be treated with cholecystectomy. Asymptomatic patients should also be indicated prophylactic cholecystectomy, given that there is a relationship between GB cancer. Controversy remains, although the percentage of patients with gallbladder cancer and the porcelain gallbladder is low than is published in the past decades. Conclusions. Porcelain gallbladder is a relatively rare disease. Calcification of the gallbladder wall is associated with risk of gallbladder cancer. Prophylactic cholecystectomy is the treatment of choice for porcelain gallbladder. Thank you, ma'am.
Hello.
Yes, sir.
Dr. Saurabh, how the porcelain gallbladder develops?
Sir, in a patient with a long-standing gallbladder disease, it could be chronic cholecystitis, multiple attacks. Calcium can be encrusted in the GB wall, leading to the calcification of the gallbladder wall, leading to porcelain gallbladder.
So this is a dystrophic calcification in a long-standing case of chronic, say, cholecystitis cases. So, what is the plan of treatment in these cases?
Sir, as it is a pre-malignant condition, so we should go, even in asymptomatic patients, we should plan for cholecystectomy, preferably open.
Can you identify a case of porcelain gallbladder by X-ray?
Yes, sir. Calcium can be seen in X-ray. So, but in X-ray, suspicion can be there that it could be a case of calcification in the right hypochondrium. So it could be porcelain gallbladder. Then confirmation will be by CT scan only.
Saurabh, can we go laparoscopically?
Yes, ma'am, it can be attempted if the size of the gallbladder is small. Actually, we have to take gallbladder out of the 10 mm port. It could be extended and the gallbladder could be put in a pouch and polybag, and then it could be taken out. But if the size of gallbladder is large, then open cholecystectomy is preferred.
Thank you.
Okay, thank you.
One question is on chat box.
Okay. Hello, Saurabh.
Yes, ma'am.
What was lymph node biopsy revealed?
So, ma'am, it was insignificant. No malignant changes were present.
Okay. Actually, in all porcelain gallbladder are not always malignant. There may be chances of malignancy. Okay. Okay, thank you.
Next is Dr. Shiv Arora. Dr. Shiv Arora.
Good morning, sir.
Yeah, please share your screen.
Yes, sir. Good morning, sir. Uh, am I audible, sir?
You are not audible. Hello, Dr. Safe? Dr. Safe. If there is any next speaker, Safe, your voice is not audible.
Hello. Yes, ma'am.
Shiv, share screen. Hello, Shiv. Hello. Hello.
The next speaker is Dr. Sukhveer Singh.
Yes, sir. Yes, sir. I'm Dr.
Hello,
Sukhveer
ma'am.
Singh.
Yes,
Just a
Sukhveer.
moment, please.
Yes, sir. Am I audible, sir?
Yes, audible.
Can we allow Dr. Sukhveer, please?
Yes, sir.
If the voice is not audible, then allow next speaker.
Okay, ma'am. Dr. Sukhveer, please proceed.
Yes, sir. Yes. Yes, sir. Myself, Dr. Sukhveer Singh, third year resident, Department of General Surgery from JLN Medical College, Ajmer. I am presenting paper on estimation of difficulties in laparoscopic cholecystectomy by preoperative clinical and ultrasonographic measures. My co-author, Dr. Shyam Bhutra, sir, Senior Professor and Unit Head, and Dr. B.C. Khorwal, sir, Assistant Professor. Background. Laparoscopic cholecystectomy is the surgical procedure of choice in uncomplicated gallbladder disease with gallbladder calculus, gallbladder polyp, and gallbladder malignancy without metastasis. Though laparoscopic cholecystectomy is a standard procedure for the gallbladder disease. It may sometimes also require conversion to open cholecystectomy. These difficulties are traditionally predicted by detailed clinical history with clinical examination and preoperative ultrasonographic study, which provides information about probability of difficulties. Material and method. In the present study, the difficulties encountered during laparoscopic cholecystectomy were investigated using the preoperative ultrasound findings. 150 patients with symptomatic gallbladder disease, out of which 120 females and 30 males, mean age 45 plus minus 10 years, referred to Department of JLN Medical College and Associated Group of Hospital, Ajmer, for cholecystectomy were recruited for the purpose of study from January 2019 to March 2020. All patients underwent detailed ultrasonographic examination 24 to 72 hours prior to laparoscopic cholecystectomy. The overall difficulties were determined based on the following operative parameters. To access the peritoneal cavity during insertion of port, duration of surgery, bleeding, dissection of Callot's triangle, separation of gallbladder from gallbladder fossa and adhesion, spillage of bile, spillage of stones, and difficulties of gallbladder extraction. The sonographic criteria were used to determine size of the gallbladder in form of transverse diameter, number of gallbladder stones, size of stones, maximum size of stone in case of multiple stones, location of gallbladder stone, thickness of gallbladder wall, common bile duct diameter, and liver size, liver span. The clinical criteria from previous upper abdominal surgery, obesity, history of acute pancreatitis were also used in estimating the intraoperative difficulties in laparoscopic cholecystectomy. The studies show results. The study showed that 3 out of 120 female and 1 out of 30 males required conversion to open cholecystectomy. All conversion were due to difficulties in dissection of Callot's triangle. The average duration of surgery was approximately 45 minutes. On the study basis of 3 category was divided. Number 1 category easy laparoscopic cholecystectomy. Number of cases were performed in easy laparoscopic cholecystectomy were 98, which are the percentage of 65.34%. Difficult laparoscopic cholecystectomy, number of cases were 48, 32% of the total cases. And laparoscopic conversion to open cholecystectomy were number of cases were 4, percentage of cases is 2.66. Few pictures during the study. A 42-year-old female which have multiple cystic artery which were not diagnosed by sonographic measures and operated by laparoscopic cholecystectomy. Second image is showing 38-year-old female which has normal CVD diameter and no previous history of acute pancreatitis and any upper abdominal surgery, but dissection of Callot's triangle could not be possible even after conversion to open cholecystectomy. So partial open cholecystectomy was done. My conclusion is that studies show that the preoperative ultrasound help in prediction of the preoperative difficulties to an extent. However, alone it is not the sole factor in determining the operative difficulties. Thank you, sir.
So, Dr. Supir, what are the clinical criteria to determine whether the laparoscopic cholecystectomy is easy or it will be difficult?
Sir, patient's BMI or history of cardiac disease or anterior abdominal wall thickness or previous upper abdominal surgery or previous history of acute pancreatitis or any other liver disease.
And the sonographic findings, you saying you are doing a sonography for the prediction of the outcome in laparoscopy. So what are the sonographic findings you will find that this can be troublesome during laparoscopy if we are doing laparoscopy?
Sir, like sonographic finding, like during study prior to 24 to 48, 72 hours, size of gallbladder in which volume and transverse diameter of gallbladder and thickness of gallbladder wall more than 3 mm, sorry, more than 3 mm gallbladder wall thickness maybe, or size of gallbladder stone maximum size which may be difficulties during extraction of gallbladder or multiple stone and location of stones.
So how will the clinical and sonographic findings helps us for the surgeons and for the patients?
Sir, For patient, sonographic finding is better for counseling of patient, that we can explain to patient and there is her attendant that
So
may
adequate consent we can take that
Ji,
there
sir.
is a
Ji,
chances
sir,
of
for counseling.
open cholecystectomy.
Ji,
And
sir.
for the surgeon,
For surgeon, for preparation of any like open cholecystectomy or like a perfect surgeon, like the
if a beginner is there, it is better to open initially.
Ji, sir. Ji, sir.
Or we are prepared for that
Ji, sir.
at a time, not to struggle.
Ji, sir. Ji, sir.
Ma'am.
Feel if the size of gallbladder wall is 4 millimeter,
Ji, ma'am.
then you directly go for cholecystectomy and plan for another investigation.
Ma'am, plan for another investigation.
What?
Ma'am, like CT abdomen.
Why?
Ma'am, maybe for a porcelain gallbladder or maybe any malignancy, suspected for any malignancy, or maybe acute pancreatitis, no, sorry, acute cholecystitis, which is not suitable for surgery.
You want to see the comment on sonography about the mucosa or directly go for CT scan? If mucosa is normal, smooth,
Smooth and normal, then
and they need a CT scan?
no, ma'am.
No. Thank you.
Thank you, ma'am.
Next speaker.
Next is Dr. Purvesh Doshi.
Good evening, respected faculty. I'm Dr. Purvesh, third year general surgery resident from BJ Medical College and Civil Hospital, Ahmedabad. And I'm going to present a paper on a study of efficacy of preoperative prophylactic antibiotic for prevention of surgical site infection. So the Center for Disease Control and Prevention defines SSI into incisional, divides into two categories: incisional SSI, which are further classified into superficial or deep, and organ or space SSIs, which affect the rest of the body other than the body wall layers. Surgical wounds can be classified as clean, contaminated, and dirty. The study was designed to evaluate the efficacy of a single-dose antibiotic prophylactics in elective surgeries for the prevention of SSI and compare the rates of SSI with preoperative antibiotic versus without antibiotic. So I've taken 100 patients which were admitted at the civil hospital from the period of January 2019 to January 2020, and the 100 patients were divided into two groups. Both groups contained 50 patients each. Each group was further subclassified with 25 patients undergoing clean surgery and 25 clean contaminated surgeries. Group A patients received 1 gram of injectable ceftriaxone 30 minutes prior to surgery, while Group B patients received no preoperative antibiotic. Both the groups were split randomly into two groups, taking into account the type of surgery, that is clean or clean contaminated, age of the patients ranging from 10 to 70 years, presence of other risk factors, and associated medical conditions, all of which were represented almost equally in both the groups. Other factors such as post-operative antibiotic, changing of dressing, removal of drains, etc. were similar for each group. So the results in the present study, the incidence of infection in group 1 was 0 for clean cases, while there were 2 cases for clean contaminated cases, that is around 8%, while compared to 1 case of clean surgery showing SSI in group B, with 10 cases of SSI in clean contaminated surgery in the group B. So the number of cases in the clean contaminated surgery showing SSI in group B was far more than group A, which was statistically significant.
risk factors. Out of 100 patients, 40 patients were found to have one or more risk factors, which were like anemia, obesity, diabetes, old age, or prolonged duration of surgery. Out of the 13 patients, total of the 13 patients who developed SSI, 10 had one or more of the above mentioned factors, with the table showing each group with the patients having the different risk factors. As you can see, both the groups had almost equal distribution of patients with the similar risk factors to omit the bias. So the significance of risk factors, age, with increasing age. In our study, out of the 13 patients who developed infections, 10 patients were more than above 50 years of age. Patients having anemia were given preoperative correction, and so none of these patients had developed post-operative infection. 7 patients were obese with BMI more than 30, out of which 4 patients developed SSI. 15 patients were diabetic, out of which 10 developed SSI, despite being under monitored insulin regimen, showing that diabetes is an independent risk factor. And the duration of surgery, 14 patients had prolonged surgery, that is surgery lasting more than 2 hours. Out of these 14 patients, 6 patients developed SSI. So presence of more than one risk factor has a significant impact on development of SSI, and these patients were at definite risk of developing SSI when not given the prophylactic antibiotic. So to conclude, from this study, we can conclude that in cases of clean surgeries, prophylactic antibiotics do not have a significant role, while, however, in clean and contaminated cases of surgery, antibiotic prophylaxis is recommended as it reduces the SSI significantly, improving the overall morbidity and the outcome of the patient. The presence of risk factor further complicates the situation, necessitating the prophylactic antibiotic coverage in such patients. Thank you.
So, Dr. Purvesh.
Yes, sir.
What is SSI?
Sir, the SSI,
What do you mean?
Surgical site infection is defined as infection that is occurring within 30 days of any surgery, or in case of an implant within 1 year of the surgery.
Okay. So you are using prophylactic antibiotic in both clean cases and contaminated cases.
Yes, sir.
The results were good if clean surgeries, or there is a contamination.
Sir, for clean surgeries, there wasn't a significant difference. While for clean contaminated surgery, most of the surgeries that are included were for clean surgeries. There were surgeries like sebaceous cyst excision or lipoma excision or hernioplasty. While for clean contaminated, it was mainly surgeries like cholecystectomy or appendicectomy. And prophylactic antibiotic proved to be better for clean contaminated surgeries. The p-value was significant when prophylactic antibiotic was given.
Okay.
So it is better to use, or it is recommended to be used for at least clean contaminated surgeries, if not for clean surgeries.
And you are giving antibiotics post-operatively if there is a prophylactic antibiotic?
Yes, sir. Post-operative antibiotics were given. The rest of the criteria, such as the dressing, the day of changing of dressings, and everything remained same for each group.
Okay. So what is the time period for the prophylactic antibiotic?
Sir, the antibiotic is given single dose 30 minutes prior to the surgery, prior to the incision.
Ma'am.
Hello.
Yes, ma'am.
You are giving antibiotic in both the group after prophylaxis, even in the clean cases also.
Yes, ma'am. As long as the patient is admitted, we over here we have a protocol that we continue the antibiotic.
How will we know the pre-operative prophylactic antibiotic working or not? If we are giving afterwards also.
So, ma'am, the only difference between each group was the administration of pre-operative antibiotic. Otherwise, the rest of the criteria, as I mentioned, including the patient factors as well as the treatment factors, were almost same for each group.
You are going for the pulse culture and sensitivity?
Yes, ma'am. In case of any discharge, swab culture and sensitivity.
What are the common causes for the bacteria you found in study?
Ma'am, on our setup, most commonly it is either E. coli or Streptococcus, which was found from the swab results.
Okay. Actually, commonly it is because of the staphylococci, and then
Yes,
strep.
ma'am.
Yeah. Okay. Thank you.
Thank you, ma'am.
Next is Dr. Shiv Arora.
Dr. Save? He's there.
Good evening, ma'am. This is Dr. Mahesh Kumar Agrawal, ma'am. May I present my presentation? I have.
After Dr. Shiv. After Dr.
Okay.
Shiv, please.
Thank you.
Hello, Dr. Save? Are you there? Hello? Dr. Save? And she's not listening.
Dr. Mahesh,
Yes, sir.
you please.
Good evening, everyone. Myself, Dr. Mahesh Kumar Agrawal, resident doctor. Today's my presentation on the study of hormone receptor status and its correlation with age, tumor size, and histological grade in lymph node metastasis in carcinoma of breast. In the introduction, breast cancer is the
Mahesh, you
most
are
frequently occurring
presenting with
cancer
your
in women.
mobile? Hello?
Yes, ma'am.
Hello, you are presenting with mobile?
Yes, ma'am.
Okay. Okay, go ahead.
My introduction is the breast cancer is the most frequently occurring cancer in women with around 1 million newly diagnosed cases each year worldwide and responsible for about 375,000 deaths in year 2000 alone. It is a heterogeneous disease with different subtypes and classified disease on the basis of hormone receptor status. Different biomarkers are routinely used in the laboratory for diagnosis of breast cancer. These biomarkers plays an increasingly important role in disease detection and treatment. Tumor biomarkers are the range of molecules from nucleic acid to metabolites. However, protein biomarkers convert most readily into targeted therapies, as most pharmaceuticals tend to target protein and clinical diagnostic assay using standard existing platforms. Breast cancer shows heterogeneity in its clinical behavior. Clinicopathological factors like tumor grade, size, lymph node status, and histological type plays an important role in predicting prognosis and response or resistance to the therapy. Determining the estrogen receptor, progesterone receptor, and human epidermal growth factor receptor 2, HER2 new receptor status in breast cancer becomes medical practice nowadays. Clinical trials have also shown the survival advantage for patients with a hormone receptor positive status by treatment with adjuvant hormonal or chemotherapeutic regime. It is well known that strong ER positive cases benefit from endocrine therapy alone, in contrast to those with low to moderate estrogen receptor positivity. Progesterone receptor status is independently associated with disease-free and overall survival. Patients with estrogen receptor, progesterone receptor positive tumors have a better prognosis than patients with negative expression of ER and PR tumors. Immunohistochemical analysis of these receptor is used for predictive purpose is routine breast cancer patient management. Reduction in the mortality will require successful strategies for early detection and screening of the disease. The present study aimed to evaluate the expression of estrogen, progesterone, and HER2 new receptors as biomarkers and their relation with the clinicopathological factors in human breast cancer. On the basis of expression of human receptors, estrogen and progesterone receptors, and HER2 new receptor breast cancer Classification at molecular level is developed at luminal A, luminal B, basal, and HER2/neu. The method and materials of this presentation: sample collection. The present study were conducted on patient with carcinoma breast admitted in various surgical wards. Various surgical ward of Government Medical College are associated group of hospitals quota. All patients with cytologically, histopathologically proven operable breast carcinoma undergoing MRM, yeah, breast conservative surgery in Department of Surgery were be included. 71 cases of carcinoma breast from July 2019 to June 2020 were included in the study. All samples were taken after institutional ethical committee permission and personal consent of the patient or guardian. Histological examination. Histological assessment of tumor grade, low, intermediate, and high. Tumor size less than 2 centimeter and 2 to 4.9 centimeter and more, 2 to 5 centimeter and more than 5 centimeter. And lymph node status positive or negative were performed. Diagnosis age was categorized by less than 40 years, 40 to 49, 50 to 59, and more than 60 years of age. The histological parameters of all cases were reviewed by pathologist, and the histological grades were determined for each case according to noting a modification of the Bloom and Richardson grading system. Immunohistochemical scoring. The estrogen receptor and progesterone receptor results were screened manually and interpreted as positive or negative on the basis of scores for proportion as well as intensity. The expression of ER and PR was scored between 0 and 8. 0 negative, no nuclei staining. And the 1 is the borderline, 1% of the nuclei is staining. In this score 2 is a positive, 1 to 10% of nuclei is staining. In the score 3, positive 11 to 33%. In the 4, 34 to 66%. 5, 6, and 7, all 100% of nuclei stained. Expression of the HER2/neu scored 0 to 3 as follows. 0 scoring for the negative, no membranous staining identified. In the 1, faint staining involving 10% of positive cells. In the 2, positive, weak but definitive staining of the membrane, at least 10% of positive cells. When in the score 3, strong positive staining, more than 20% of cells. Statistical analysis was performed with the SPSS version 21 for Windows statistical software package. The categorical data were presented as number and were compared among group using a chi-square test. Probability was considered to be significant if less than 0.05. Results. This study was conducted on 71 women who fulfilled the inclusion criteria of the study. Hormonal ERPR and HER2 receptor status of all women were studied using immunohistochemistry, and following observation were seen. We are divided in result in the more tables. In the table 1, the age-wise distribution of the patient. Majority of patients in the present study belong to fifth decade, 25%, and sixth decade, 23.94%, accounting for a total of cases. Patients were in the age group between 26 and 75 years, with main age group 50.5 years. This is the graphical presentation of age-wise distribution of this patient. Number 2, relation of hormonal receptor status to age in breast cancer. In younger age groups, luminal A, 61.9% was most common subtype, followed by luminal B, and then basal-like. In older age group, luminal A was most common subtype, followed by the basal-like and HER2/neu, and then luminal B group. This is the graphical presentation of hormone receptor status to age. Number 3, the distribution of patients according to molecular subtypes. Maximum number of cases in our study were seen in luminal A, 45%, followed by the basal subtype, followed by luminal B and HER2/neu receptors. Relation of hormone receptor status to size of tumor in breast cancer. In our study, the size of tumor, we saw that out of 71 cases, 28 cases were between the 2 to 5 centimeters, and the 23 cases were less than 2 centimeter in size, and 20 cases were more than 5 centimeter in size. Tumor size less than 2 centimeter, luminal A, 69% was most common, followed by basal-like, and more than 5 centimeter in tumor size, basal-like, triple negative was most common, followed by the luminal A. relation of the hormone receptor status lymphovascular invasion in the breast cancer. In our study, out of 71 cases, 47 cases lymphovascular invasion, HER2 tumors were having maximum percentage of metastatic pathology. In lymphovascular invasion is the 85% followed by the luminal V 80%, and the basal like 63%, and luminal A is around 59%. On the discussion, the study entitled Study of Hormone Receptor Status and its Correlation with Age, Tumor Size, Lymph Node Metastasis in Carcinoma Breast was conducted in the Department of General Surgery, GMC Medical College, Kota, during July 19 to June 2020. The aggressive biological behavior of invasive and metastatic cancer is considered to be the most insidious and life-threatening aspect for breast cancer patients. In India, most of the patients present with a palpable breast lump and even with lymph node metastasis at the time of first visit. Stratification of patient according to nodal status and results of estrogen progesterone receptor and HER2 status has assumed a great therapeutic importance. The prognosis of breast carcinoma is related to large variety of clinical and pathological factors such as age, tumor size, lymph node metastasis, and hormone receptor status, which may help in predicting the prognosis and need for adjuvant therapy. Hormonal receptor status is the most acceptable in predicting prognosis, response, or resistance to treatment. In the age factor, out of the 71 cases which were studied, the age of patient ranged from 26 to 75 years of age group, with the mean age is the 50.5 years. In our study, the mean age in younger age group was 33 years, and the mean age group in the older patient group was the 58 years. This is similar to a study done by the Gupta P, Rai Anand, Agarwal L, and et al. 13. The mean age in the younger age was 37.3 years, while it was 54.2 years in the older age group. And Aisha S and Eljaman et al., where the mean age at the diagnosis in the younger age group was 34 years, and in the older age group it was 60.5 years. And the second is the tumor size. In our study, the size of the tumor, we saw that out of 71 cases, 28 cases were between 2 to 5 centimeters. 23 cases were less than 2 centimeters, and 20 cases were more than 5 centimeters in size. In the tumor size less than 2 centimeters, luminal A was most common, followed by the basal-like. And more than 5 centimeter in tumor size basal-like triple negative was most commonly followed by the luminal A. In India, due to lack of awareness and absence of breast cancer screening program, the majority of breast carcinoma are diagnosed at an advanced stage. Lobna Eddy et al. Documented in their study that in 12.9% the size of tumor was less than 2 centimeter, and in 87% greater than 2 centimeter. A study by Nikra et al. Have found a significant association between increasing tumor size and HER2 expression. In our study, tumors size more than 2 centimeter had high rate of HER2 expression than those of tumor less than 2 centimeter in size. In the another is the lymphovascular invasion. In our study, out of 71 cases, 47 cases lymphovascular invasion, HER2 receptor were having maximum percentage of metastatic pathology in lymphovascular invasion. 85% followed by the luminal B, and then basal-like, and then luminal A. And the
conclude, please conclude.
Yes, ma'am. The summary and conclusion of this. The present study was performed on 71 cases between the age group of 26 to 75 years, with a mean age of 50.5 years. The mean age in younger age group was 33 years, and the mean age group in older patient group was 58 years. There were 50 cases in old age group and 21 cases in young age group. Hormonal ERPR and HER2 status of all patients were assessed, and they were grouped into molecular subtypes as luminal A, B, HER2 and basal-like. Maximum number of cases in our study were seen in luminal A, followed by basal type, followed by luminal B, and then HER2. HER2 tumors were having maximum percentage of metastatic pathology in lymphovascular invasion.
Mahesh, please stop. Mahesh.
Yes, ma'am. Yes, ma'am.
Okay.
Hello.
Yes, ma'am.
Desraj, we already going late, so please don't ask question.
Okay, ma'am.
We are going late.
Madam, last Dr. Shiv Arora, please. If
शिव अरोड़ा और साकेत भी बचा हुआ है.
Saket is not presenting paper, sir.
Okay, sir.
He denied. Shiv Arora.
Shiv is there.
फिर से बात करना कर
Hello.
He is not here.
He's left.
Left, ma'am.
Shiv
Voice
there.
is no.
Hello.
No, ma'am.
Hello. Hello.
Shiv is not there.
If
Dr.
Shiv
Shiv.
is not there, then move to another. Move to
No,
another
no.
session.
Yes. Competitive paper session, please.
Yeah, yeah.
Thank you, ma'am.
Because judges are waiting there.
Ma'am,
Thank you, Desraj.
Thank you, ma'am. Thank you.
Thank you,
very
Desraj.
much.
For competitive paper presentation, judges are Dr. Ashok Parmar sir, Dr. Shyam Luthra sir, Dr. Sanjay Singhal, and Dr. Siddharth Verma sir. And the first presenter is Dr. Ankit Kumar. Dr. Ankit, please share your screen.
Good evening, sir. Parmar sir, good evening.
Good evening, madam.
Good evening, ma'am.
Good evening.
Dr. Ankit.
Hello. Hello. Good evening, sir.
Good evening.
Sir, my today's topic is sir, a clinical study in management of non-traumatic acute abdomen. Myself, Dr. Ankit Kumar, General Surgery, Medical College, Kota. Sir, background of my study is sir, acute abdomen is defined as a spectrum of surgical, medical, and gynecological conditions from trivial to life-threatening condition which require hospital admission, investigation, and management. This may be due to surgical as well as the acute abdomen may be due to surgical as well as non-surgical causes. The common non-surgical causes include a metabolic and cardiac emergency like acute inferior valve MI. Idea about a geographical distribution of acute abdominal etiology may help in quick and more precise diagnosis, especially in emergency situation, and may help in rapid revival of patients. A well-conducted history, surgeon's clinical diagnostic accuracy, laboratory test, and radiological findings are the most important component in diagnosing patient with an acute abdomen. The aim of our study was to study the frequency and etiological spectrum and management of acute abdomen in our center. And next is to analyze the prognosis of early and late diagnosed cases, and to study the lacuna of healthcare infrastructure at peripheral healthcare centers. The study was conducted on patients admitted with the non-traumatic acute abdomen from December 2019 to April 2020 at Department of General Surgery, Government Medical College, Kota, Rajasthan. Including criteria was patient admitted with the non-traumatic acute pain abdomen, both surgically and conservatively managed cases, and patient willing to participate in study with informed consent. The exclusion criteria was traumatic cases of acute abdomen, non-traumatic pain abdomen in pregnant women, and pediatric patients less than 5 years of age, and patient with serious condition. Finally, for every case, a detailed history, associated sign and symptoms, necessary blood and radiological investigation, management details including intraoperative finding, and post-operative follow-up details were collected and noted. The results of our study was the study included 100 cases of non-traumatic acute abdomen. The age at presentation was from youngest being 6 years and the eldest was 80 years. Third decade had the most number of incidents, that is 25% of all cases. Next is followed by second decade accounting to 18%, and the collectively more common the cases was in second to sixth decade of life. The mean age was 27 of year. Total number of male patients were 74 and female were 26. The male predominance was present. The male to female ratio was 2.85 is to 1. Out of 100 cases, there was 30 cases of hollow viscous perforation. Next is acute appendicitis, accounts for 24 cases out of 100, and next one was subacute intestinal obstruction. There were 23 cases. and the 23 cases were related to others: kidney, ureter, bladder pathologies, pancreatitis and its complication, gallbladder pathologies, and liver and spleen pathologies, and others. Uh, the the holoviscous perforation cases were increasing from second decade onwards, but the acute appendicitis cases were more in second and third decade. The incidence of acute abdominal conditions, out of 100 cases, the 30 was holoviscous perforation. Out of these 30, the 3 cases which had expired after the treatment, and 24 cases was belong to acute appendicitis. 23 was subacute intestinal obstruction. Kidney, ureter, bladder pathology related cases were 8. Cholelithiasis and its complication related cases were 4. Pancreatitis and related cases were 3. Then the 3 cases were non-specific pan abdomen. Obsogeny related cases were 2. Makers diverticulitis was 1. Liver abscess 1. And splenic infarct with abscess was 1. Sex distribution of acute abdomen. First, we talk about the holoviscous perforation. Out of 30 cases, 26 were male and 4 was female. The ratio was 6.5:1. In acute appendicitis, out of 24, 20 were male and 4 was female. The ratio was 5:1. And intestinal obstruction, total out of total 23 cases, 16 were male and 7 were female. The ratio was 2.29:1. Other cases were 23. The male and female ratio was almost equal. The overall male-female ratio was 2.84 equals to 1. Incidence of holoviscous perforations are out of 30 cases, 19 were belong to peptic perforation peritonitis, and 11 were ileal perforation peritonitis. Next are pathological type of appendix. Out of 24 cases, 17 cases were inflamed appendix without perforation. Next one is gangrenous appendix without perforation was 1. Next is gangrenous appendix with perforation. The case was 1, and appendicular abscess was 1, and the appendicular lump was 4. In our study, there were 24 patients having appendicitis related pathology. Out of these, 20% underwent laparoscopic open appendicectomy, while 4 were managed conservative. The causes of intestinal obstruction in our study was out of 23 cases, 5 cases belong to obstructed inguinal hernia, 1 case was belong to obstructed incisional hernia, and 4 cases with the post-operative intestinal adhesion, and 3 cases were volvulus. Out of these, 1 was cecal volvulus and 2 were sigmoid volvulus. 1 case was with paralytic ileus, 1 was ileal stricture, tubercular abdomen was 1, and mesenteric ischemia was 2 cases, and the adhesions were in 2, fibrous band present in 2 cases, and constipation was 1. Next is kidney, ureter, bladder related cause of acute abdomen. The 4 cases were nephrolithiasis related cause. Next, 1 case with nephrolithiasis with bladder stone was 1, and bladder stone only was 1. Acute retention of urine with prostatomegaly was 1 case, and right pyelonephrosis with non-functional kidney was 1. So these are total 8 cases. Next is a distribution of associated symptoms among the study patients.
Hello, Dr. Ankit.
Voice.
Hello. You are not audible.
Presentation has also stopped.
So most probably there is some net problem there.
Dr. Ankit.
So distribution of associated clinical sign among the study patient, the 90% has 92% has abdominal tenderness, 72% has absent bowel sounds, and 66% has rigidity and guarding. 55% has free fluid in peritoneal cavity. So if we talk about the management, out of 100, 16% manage conservatively, 20% in 20% we go with the open oblique lap appendicectomy, 19% as laparotomy with gram patch repair. In 3% we go for the primary ileal repair, 5% we go for the resection anastomosis, and in 13 cases we go for the ileostomy. In tubercular cases, sir, in single tubercular case we go for the jejunostomy, and in sigmoid volvulus we go for the colostomy, 2 patients. In 3 cases we go for the addusolysis, and in diverticula cases we go for wedge resection of diverticula, and in liver abscess we go for the peritoneal lavage, and splenic abscess and with infarct we go for the laparoscopic converted open splenectomy. One we go for the suprapubic cystolithotomy, and in one case we go for the nephrectomy with SPCL. So out of these 100 cases, 92 were discharged once treatment completed, and 3% were transferred to the respective specialty, 2 in the obs-gynae and 1 in the gastro department. And once the once the final diagnosis is achieved, while 5% died during the course of treatment in hospital. The conclusion of my study, sir, it is extremely important for emergency doctor to develop the skill of identifying patient with acute abdomen requiring immediate intervention, play an important role in a better clinical outcome. Sir, the demographic related knowledge, sir, should be necessary because the demographic influence both the incidence and the clinical expression of the abdominal cases. And the lack of knowledge, lower socioeconomic status, and inadequate health care infrastructure at rural areas with less access to tertiary care leads to a delay in proper management of acute abdominal emergencies. Health education and improving access of health service at primary and secondary health care level may help in early hospitalization, accurate final diagnosis, and early treatment, decreasing the incidence of hospital stay, morbidity, and mortality. Thank you.
Dr. Ankit?
Ji, sir.
What was the common site of peptic perforation in your study?
Sir, pre-pyloric region was the common site.
Overall, which is the common site?
Sir, pyloric region, sir, pre-pyloric region.
Incidence of D1? First part of duodenum?
Sir, second was the first part of duodenum.
What will you do if there is large ulcer, large peptic perforation? And what will be your decision?
Sir, in case of large ulcer, first we go for the primary closure and gastrojejunostomy, maybe the.
Any other option? Suppose it is not
Sir,
repairable, the ulcer is large and margins are inflamed and friable, it is not repairable, you cannot close that large perforation.
Sir, we go for the Bilirubin type 1, and second we go for the Bilirubin first and type surgery.
What are the other sites of peptic perforation?
Sir, pre-pyloric and then sir duodenal ulcer. Next
Any
are
other?
duodenal ulcer.
Any other site, the rare site? And Dr. Siddharth?
Yes, sir.
Yeah. From your side.
You mentioned that you had
Hello.
done exploratory laparotomy and you had done oophorectomy. What was that for? Even though you said that
ovarian torsion, sir, one case was the left ovarian torsion, intraoperative finding, sir. In CT scan, sir, there was a indefined sir lump was given in lower abdominopelvic region.
that case was not sent to the concerned specialty. You operated that, right?
Sir, sir, intraoperative finding was that left ovarian torsion. Then,
Two
sir,
cases were put on conservative. Is there any lump in that?
Sir, hello.
16
cases were managed conservatively.
Were managed conservatively.
Sir.
What was the reason for that?
sir, sir, ultrasound finding was the sir appendicular lump. Preoperative finding was the appendicular lump, sir. So we go for the conservative management, sir.
All right. And one case was
Hello.
colostomy. That was for tubercular.
This sir, tuberculosis, the addition was sir. Sir, there was the cocoon present, sir, plaster abdomen. So, sir, we cannot go for the sir proper addiculysis. Then, sir, we go for the sir.
And cholecystectomy
jejunum.
symptoms of cholecystitis. Was it purely cholelithiasis, or is there a cholecystitis associated with that?
Sir, associated with that. Sir, the duration was sir in 24 hours duration था sir उसका. Sir, वो go for the cholecystectomy.
At any given state, did you use laparoscopy to just diagnose and treat this acute abdomen?
No, sir. The diagnostic laparoscopy is not our institute.
Diagnosis in your hand before you intervened.
Ji sir, ji sir.
Sir, we have spent 15 minutes on this first case. I think time is over. We have spent 15 minutes. Hello. Hello. Hello.
Hello.
So next speaker, please.
Hello. Sir, assessment sheet is sent on the WhatsApp group.
Yeah, yes, madam.
Okay. So normally the time duration would be 8 minutes plus 2 minutes?
Yes, sir.
Okay.
Next, Dr. Ashok Yadav is not able to present. Next is Dr. Avinash Maheshwari.
So you have given the numbers to them, these candidates?
Yeah, it's G1 is Dr. Ankit Kumar, G2 is Dr. Ashok Yadav, and G3 is Avinash Maheshwari.
So Ashok is not presenting, right?
Yeah, yes, sir.
Okay. Now the next candidate is G3, right?
Yeah, Dr. Avinash.
Fine. Yes, Dr. Avinash.
Dr. Avinash.
Present your screen. Avinash, please present your screen.
I think Dr. Avinash is not there.
So Dr. Avinash is there. Can I call next one, please?
Yeah, next one.
It's G4, Dr. Aviral. Dr. Aviral,
Yes, sir.
please present, share your screen. Yes, please.
One respected teachers and my colleague. I am Dr. Aviral Nagar, JR3, Department of General Surgery, SMS Medical College, Jaipur. Today I am presenting a rare case report on duodenal interception presenting as a acute pancreatitis due to the duodenal adenocarcinoma. Interception is a condition in which a proximal part of the duodenum, posterior part of the gut is invaginated in the immediate adjacent part of the gut segment. Most commonly seen is the infants, but it can also be seen in the adult patients. It can occur anywhere in the intestinal tract, but it also rarely seen in the fixed and retroperitoneal part of the bowel segments. That's why duodenal interception is very rarely encountered, because duodenum is fixed into the retroperitoneally, but seldomly it is sometimes found with the malrotation abnormalities. But in my cases, duodenal polyp is the leading point which causes intussusceptions without any malabsorption, malrotation abnormalities. In my case, a 40-year-old non-alcoholic gentleman presenting with complaint of intermittent abdominal pain since 8 months, associated with loss of weight and appetite for last 4 months, with complaint of recurrent bilious vomiting episodes last 5 days. On examination, tenderness is present in epigastric region and palpation vagus mass seen in the umbilical region. On routine blood investigations, and the LFT was normal, but only serum, amylase, and lipase were raised. On further localization of the pathology, we go for the ultrasound whole abdomen with suggestive of duodenal mass. For further workup, we go for upper GI endoscopy for rule out any obstruction and find out the point of the obstruction site. With suggestive obstruction are found in second part of the duodenum associated with bile stasis. For seeing the rule out of resectability and any point of the metastasis seeding, we go for the CCT whole abdomen with suggestive of the 3 into 3 centimeter heterogeneous enhancing mass lesion present in proximal part of the duodenum with bulky pancreas. On the basis of clinical history, examination, and blood investigations and radiological findings, and taking proper PSC workup, we plan for the exploratory rhabdotomy and proceed. During PAROP, we find the gallbladder was distended and stomach was dilated, associated dilated first and second part of the duodenum. So first part of the duodenum is also invaginate in the second part of the duodenum with associated of polyp present internally. Polyp was 4 into 3 into 1.5 centimeter sessile present in posterior wall of the second part of the duodenum, which cover 1/3 part of the circumference of the it and just 2 centimeter above the papilla. Then we plan for the surgery of a pancreatic duodenectomy with feeding jejunostomy with drain placement. After surgery, we remove the abdominal drain on day 5 and start start orally on day 7, and taking proper orally a passing flatus motion, we discharge the patient on day 10 and uneventually. On histopathologically of the specimen suggestive of the moderated differentiated adenocarcinoma. Adult intussusceptions are uncommonly accounted approx 5% cases of the all intussusceptions, but presentation and etiology and management are differ as compared to children's. Duodenal intussusceptions are rarely, but it can occur any lesion which is present in the wall and any irritant which present in the luminum, which altered the normal peristaltic movement of the duodenum or promote the invagination of the duodenum. The leading point, this leading point may be the benign or maybe malignant or maybe idiopathic, but presenting symptoms of this is usually non-specific, coincidentally find during the surgery. But it is most commonly may be present with obstructive symptoms or obstructive jaundice or pancreatitis. If it is involving the ampullary region due to the obstruction of the CBD and pancreatic duct. Pancreatitis secondary to the duodenal intussusception is very rare presentation of the duodenal adenomas, as seen our case, which is presented also with gastric outlet obstruction. Approx 6 to 30% of the all cases of intussusception associated with the malignant pathology, which are the maybe primary or secondary. But in case of duodenal polyp, which was a leading point, suggestive showing histopathologically adenocarcinoma. Adenocarcinoma of the duodenum is rarely metastatic to lymph nodes. That's why in our case, lymph node adenectomy is not recommended. And management point of the we plan for the endoscopically and open surgery. It is depend on the size and site of the lesion where it is present. On conclusion, duodenum being a retroperitoneal structure, it is a rare to intussusception, but is a very rarely occur due to the respiratory duodenal adenomas or adenocarcinoma, which act as a leading point for it, and it may be presented with complication like gastric outlet obstruction and pancreatitis. Surgery is only option depending on the size and location of tumor. Maybe it's endoscopically or maybe it's a open surgery. Thank you.
Dr. Aviral. Hello, Dr. Aviral.
Yes, sir.
Which is the commonest site of interception?
Sir, in adults, sir, cholocolic interception is most common, sir.
And in infants?
Infants, sir, ilia, sir.
In this case, you have removed pancreas also.
Yes,
Was it involved?
Sir, the growth are obstructing the pancreatic duct and causing the obstruction and pancreatitis, and adhesions are densely pancreas are densely adherent to duodenum also. That's why we plan for a pancreatic duodenectomy.
Dr. Shyam, your turn.
Hello. There was there was bile stasis and there is still their LHP were normal, right?
Yes, sir.
How do you explain that? And during surgery, did you have any bowel wall ischemia because of intussusception?
Pardon?
Intraoperatively, was there any bowel wall ischemia because of intussusception?
Sir, after during the op, we reduce the duodenal interception mass and see the slightly pregangrenous changes are seen. After waiting the 100% oxygen for 5 minutes, it just look like normal. But mass is feel is large and hard. That's why we plan sir pancreatic duodenostomy, which look like a malignant, sir.
You said that it is quite rare. It is rare indeed. And because it is respiratory in structure. So usually you don't see it in duodenum. How do you differentiate it from mucosal prolapse?
My sir, no idea. Hello. Hello.
Hello.
Sir. No idea.
If he is not audible, we can switch to other next candidate because we have spent 11 minutes in this case.
Sir, I am calling again Dr. G3 number, Dr. Avinash Maheshwari.
Am I audible?
Yes, please.
Yes.
Yeah. Just a minute.
Hello. Hello.
Hello. Is it visible? Hello.
Yes, please.
Screen is visible?
Visible, screen visible.
Yeah, okay. Good evening, everyone. I'm Dr. Avinash Maheshwari from SMS Medical College and Hospital, Jaipur, Rajasthan. I am presenting a case report on a rare presentation of choledochal cyst as choledochal cystocutaneous fistula. First of all, introduction. Congenital cystic dilatation of the biliary duct is defined as choledochal cyst. Though most of the patients with choledochal cyst present in childhood, about 20% present in adulthood. The classical triad of clinical presentation, abdominal pain, jaundice, and lump is present in only 6% of cases. 15 to 20% of patients with choledochal cyst present with complication of which cystolithiasis is the commonest complication. Other uncommon complications ranges from hepatolithiasis, intrahepatic abscess, secondary biliary cirrhosis, portal hypertension, and cholangiocarcinoma. Biliary cysts are congenital cystic dilatations of the intra and extrahepatic biliary tree. Women are more commonly affected than men. in a ratio of 3 to 4:1. Traditionally, lesions affecting only the CBD are referred to specifically as. In 1969, established that the most probable cause of biliary cyst relies on an anomalous pancreatico-biliary junction. According to Yotu Yangi, an anomalous proliferation of the biliary epithelial cells before bile duct cannulation during development is one possible explanation. Biliary cysts have the ability to produce a wide spectrum of complications, including strictures, cholangitis, rupture with biliary peritonitis, and malignancy. In this paper, we present the rare case of choledochal cyst as choledochal cystocutaneous fistula. The most well-known classification system for biliary cyst was established by Todani. There are 5 types, type 1 being the most common. Type 1, 2, 3, and 4b are extrahepatic, and type 4a and 5 are intrahepatic. Type 1, fusiform dilatation of the CBD. Type 2, bile duct diverticulum, and type 3, saccular dilatation of the common bile duct inside the duodenum wall and choledococele. Type 4a, intra and extrahepatic, both components are present. In type B, involves only the extrahepatic bile duct. And in type 5, fusiform or saccular cystic dilatation of the intrahepatic bile duct, whether or not associated to hepatic fibrosis, also known as Caroli's disease. Case report. A 29-year-old female presented with pain in right hypochondrium, fever with yellowish discoloration of eyes on and off past 4 years. Patient was asymptomatic for 1 to 1.5 years, then presented with similar symptoms and discharged from anterior chest wall sinus past 4 months in OPD. Patient at first, patient underwent USG guided aspiration for liver abscess. Around 50 to 60 ml pus was drained from the right lobe of liver. 3 months later, patient was diagnosed as liver abscess, for which she underwent a diagnostic laparoscopy with pelvic drain placement done in 2016. Pelvic drain was removed after 1 month along with ERCP and placement of CBD stent. After 1 month, patient was readmitted and removal of subhepatic drain was done. Patient again presented with jaundice and pain abdomen. Therefore, USG guided PCT placement done for collection in right lobe of liver. Around 500 ml biliopurulent discharge was collected. Then she came to OPD and we received her, and we did TPC and MRCP. TPCT was which was suggestive of heterogeneous density cystic lesion of approximately size 62 into 60 into 60 mm in segment 4 and 8 of liver. Query liver abscess communicating with biliary duct with post-procedural changes. MRI whole abdomen with MRCP suggestive of heterogeneous signal intensity cystic lesion seen in porta hepatis expanding into the adjacent liver parenchyma measuring 79 into 78 into 68 mm, suggestive of bilioma. Then patient underwent exploratory laparotomy with excision of fistulous tract plus en bloc removal of choledochal cyst with Roux-en-Y HJ of all segmental ducts plus transanastomotic drain placement and subhepatic drain placement done. Per-op findings were a fistulous sac was present on right costal margin with continuous draining biliopurulent fistula. Right subcostal incision given. The fistulous tract was extending from right costal margin up to the anterior surface of liver. On exploration, fistulous tract biliopurulent putty-like material started to come. Around 8 into 8 centimeter cyst was present embedded in liver bed. Initially looked like gallbladder, which on further exploration confirmed to be a choledochal cyst. Lower end of cyst was communicating with the duodenum and upper end communicating with the hepatic ductal system. There were 4 segmental ducts present. 7 French stent retrieved from choledochal cyst and copious amount of putty material evacuated. 2 major ducts were present, likely right or left hepatic ducts, and 2 minor ducts were also present. Roux-en-Y HJ was done in sequential fashion for all 4 ducts. Leak test was done and was negative. Transanastomotic stent was placed and exit through the safe fistulous opening from skin. Lower end of CBD was closed and subhepatic drain placed and abdomen closed in layers. In this picture, there are 4 segmental ducts. This is the putty material and the stent retrieved from the cyst. And the biopsy report shows choledochal cyst. So the conclusion is the current series highlight various unusual presentation of choledochal cyst, which may pose diagnostic dilemma and significant impact on its surgical management. One should be aware of these variations both in the pre-operative and intraoperative period, or else inadvertent injury may occur with significant post-operative complications. Thank you.
And Dr. Avinash, why there was jaundice?
Pardon, sir?
Why there was jaundice? Because there was no obstruction to the biliary flow.
Yeah. Obstruction. So there was obstruction. No?
There was fistula.
The cyst was.
Bile was draining outside.
Yeah.
And you said there is a yellow discoloration of the skin. It means jaundice is there. Jaundice was there.
Yeah. Yeah, jaundice was there, sir.
What was the bilirubin level?
So bilirubin level was around 2.8.
So what was the cause of jaundice?
So maybe the size of the cyst was very large, which it was compressing the CBD.
CBD.
Yeah.
What is choledochal cyst, Dr. Avinash? What is choledochal cyst?
So it is dilatation of the CBD.
Yeah. So what was compressing the CBD then? You said something was compressing the CBD.
Sir, the size of the cyst was very large, so it may be compressing all the ducts, like segmental ducts we found intraop.
Okay, what is the cause of this choledochal cyst?
Sir, that abnormal pancreaticobiliary junction, it is due to APBJ. The pancreatic duct, the pressure of the pancreatic duct is higher than the biliary duct, so the pancreatic fluid goes into the CBD and form this choledochal cyst.
Now, can you give the answer for the question which sir has asked, the raised bilirubin? Okay, which classification does this cyst fits in? You had enumerated the classification of choledochal cyst, right? So what is the type of this cyst which you have encountered?
Sir, this is, I think, type 4B.
Type 4B.
4 is multiple systems.
Okay, what was the cause of the connection between the cyst and the cutaneous? Like you said, it is a biliocutaneous fistula.
Sir,
what could have led to this?
Sir, previously it was misdiagnosed as liver abscess. So we explored and placed a drain inside this, and also PCD placement was also done 2 times. So I think the fistula, because of that only.
Yeah, so that could have been the cause of the fistula. Otherwise, choledochal cyst need not present as a fistula.
Do you mean to say that it is iatrogenic fistula? Hello?
Sir, pardon?
Yes, you mean to say that this is iatrogenic fistula?
Yeah.
Due to the drainage, placement of the drainage.
Yeah.
Inside the choledochal cyst.
Yeah, sir.
You said that, was there a liver abscess?
It was, yeah, sir. It was misdiagnosed as liver abscess. So the PCD placement and also explored by diagnostic lab also. Then also there is a drain. So maybe the cause was that only, iatrogenic.
Okay, so we have spent 12 minutes in this case. So we can switch to next case.
Okay. Thank you, sir.
Yeah, next candidate, please.
Next
Rupesh
is, yes, sir.
Yeah,
Next
Rupesh
is, next is Dr. Divya.
G5.
Yeah, G5, Dr. Divya.
Fine. Yeah, Dr. Divya, please go ahead.
Dr. Divya, you are taking too much time. You are not audible, Dr. Divya.
Sir, we can go for another speaker.
Yeah.
Next one is, oh, sorry. Next one, G6, Dr. Girija HR. Dr. Girija,
Good evening, sir.
please share your
Hello?
screen.
Yes. Good evening, everybody. Myself, Dr. Girija. I am a general surgery resident third year from Dr. SNMC Jodhpur. Today, I would like to present a case report on Kimura's disease, which is actually unusual presentation in gallbladder and mesenteric lymph node. Coming to introduction, Kimura's disease is a benign chronic eosinophilic inflammatory disorder. It usually presents with a slowly enlarging soft tissue mass and regional lymphadenopathy, most commonly seen in head and neck region. And in the blood picture, we usually have eosinophilia, which is common, and serum Ig levels are usually elevated. And coming to histology, we'll have eosinophilic infiltrates in the interfollicular and sinusoidal areas in the lymph nodes as noted. Although Kimura's disease mainly affects head and neck region, involvement of extremities and inguinal lymph node has also been reported. Hence, we report an unusual case of 40-year-old female who presented to us with 6 months history of pain in the right hypochondrium and abdominal distension. Clinical examination findings revealed shifting dullness, which indicated moderate ascites only. And then we proceeded with USG abdomen of this patient, which showed cholelithiasis with moderate ascites. And just to confirm the diagnosis, we went with CECT abdomen, which showed cholelithiasis with moderate free fluid and mesenteric lymphadenopathy. So the patient was planned for elective open cholecystectomy and mesenteric lymph node biopsy. And on routine investigation, the blood picture showed high total leukocyte count, which was 13,000, and marked eosinophilia, which was 48%. And on laparotomy with cholecystectomy, intraoperative finding was mesenteric lymph nodes were enlarged and bowel were edematous along with contracted gallbladder. Approximately 500 cc of ascitic fluid was drained, and the gallbladder after cholecystectomy and the mesenteric lymph node, which was taken for biopsy, sent for histopathological examination. And the ascitic fluid which was drained was also sent for biochemical examination and cytology. And on histopathological examination of the excised specimen showed lymph node architecture with marked hyperplasia of germinal centers. Extensive infiltration by mature eosinophil was present with occasional area of eosinophilic abscess, sinusal and paracortical sclerosis was also present. There were plenty of plasma cells and mast cells were also seen. And after surgery, patient was managed post-operatively and successfully, and she was advised to come for regular follow-up after discharge. And till now, she has no any developed any new lesions or any complications. And as you all can see, this is a histological picture of mesenteric lymph node, which was removed for biopsy, which showed eosinophilic infiltrate, but the lymph node architecture was maintained. And in gallbladder also, the same picture was noted with multiple eosinophils. Coming to discussion, Kimura's disease actually first reported in China, and it was named after a person who identified some abnormality in the vessel and named the disease as Kimura's disease. Actually, it is endemic to Asians, and it has a male gender predominance, and it presents with painless soft tissue nodules and lymph node, as I earlier mentioned, mainly in the head and neck region. The cause of this rare disease remains unknown, but it is thought to be an immune-mediated disorder, but not neoplastic. And common sites of involvement are specifically parotid glands and epitrochlear, axillary, and inguinal lymph nodes. Although masses enlarge slowly, as in our case, the patient presented with history of chronic history, patient remain otherwise asymptomatic. Pruritus and dermatitis may occur, and skin lesions can present as reddish brown papules or as subcutaneous nodules. Etiology is thought to be an abnormal immune response to an unknown antigenic stimulus. The constant histological feature is noted in this. This is that is preserved lymph node architecture, florid germinal centers, eosinophilic infiltration, increased amount of post-capillary venules. The frequent features are sclerosis, karyocytosis in both germinal centers and paracortex, necrosis of germinal center, eosinophilic abscesses, and atrophic venules in sclerotic areas. Coming to the treatment of the disease, is mainly the surgical excision of the lesion, which is considered to be the first line of therapy. Even though there are relapses, which are very frequent, for relapses, the treatment advised is systemic corticosteroid, that is prednisolone, which is indicated for relapse. And for renal involvement, literature shows that 20% of the patients have renal involvement. And for those which have renal involvement, corticosteroid is advised, even though there is risk of relapse when the treatment is withdrawn. And if they are not responding to steroids, radiation treatment is advised. Total dose of approximately 20 to 30 have been proved effective. And irradiation should also be considered in young patient in whom the long-term side effects of steroids may be deleterious than a limited course of irradiation, which may prevent relapse. Now, coming to conclusion, this case report actually signifies the need for increased awareness about the unusual presentation of Kimura's disease. Optimal treatment protocol and long-term prognosis of patient with Kimura's disease are not established due to lack of long-term follow-up data in the literature, and also rarity of these lesions. There is no evidence that Kimura's disease of gallbladder and mesenteric lymph node carries an exceptionally poor outcome, as our patient had a wonderful outcome, and also there is no potential that these lesions will turn malignant. With this, I would conclude my presentation. Thank you.
What happens in the case of untreated patients?
Sorry?
If patient is not treated, not operated,
yes, sir.
Then what is the fate? What is the prognosis?
It depends on the site of involvement. If it is involving mostly parotid gland and other glands in the head and neck region, they might have necrosis and other complications.
What are the other sites other than head and neck?
It is, sir, it is also reported in inguinal lymph nodes, and And also, sir, as in our case, gallbladder and mainly lymph nodes and glandular tissues, sir.
Dr. Shyam, your turn.
So it was more of a post-operative diagnosis, histological diagnosis,
Yes,
right?
yes, sir. Yes,
Yeah.
sir.
How would you suspect? Yeah.
Sir, may I ask a question?
Sure, please.
Dr. Girija, have you reported this case?
Yes, sir. Actually, in 2019, we have reported from
Okay.
our.
Did you find any literature reporting from our region? जोधपुर से और कोई केस भी मिला आपको लिटरेचर में?
Sorry, sir, no idea.
No,
We have reported it in SNMC journal, sir, in 2019.
So, Dr. Girija, it's basically a benign disease. Actually, we
Yes, sir.
reported a similar case around 5 years back, bilateral
Yes, sir.
auricular swellings. So, in your case, as Dr. Bhuta is pointing out, did your post-operative management will differ in a simple lab chole for cholelithiasis you have done and you have found this to be a humoral disease. So, how your post-operative treatment or follow-up will differ?
Can you pardon me if I ask you to repeat the question?
How did your post-operative follow-up and management will differ in your case as you do in a case with a routine laparoscopic cholecystectomy for Colston disease?
Sir, in our case, if there is Kimbra's disease post histological diagnosis, we have to consider the relapse of we have to take into consideration the recurrence of the disease. So we need, if there is any relapse, we need to take them on steroids.
Have you started your patient with steroids?
No, sir. We are till now on follow-up. She don't have any complaint or any complications like relapse or recurrence.
Okay, or from my side, sir. Over.
Thank you, sir.
Dr. Devia, why did you go for ascites fluid examination pre-op? Were you confident about the diagnosis pre-operatively?
No, sir. There was no. Ascitic fluid we went because there was no definitive diagnosis we could for ascites from the pre-op presentation.
No, ascitic fluid examination.
Diagnostic type we did.
Operatively, isn't it?
Sorry, sir.
Ascitic fluid examination was done post-operatively, right?
Yes, sir. We had post-op ascitic fluid examination.
Any other disease would you like to take into account when this such presentation is there in these patients?
Like sir, cholelithiasis with lymph adenopathy.
No, particularly when patient is having ascites. You said it's moderate ascites. Okay, what was the histopathology of gallbladder, which make you conclude that this is Kimura's?
So gallbladder, there were no gallbladder histology. It showed high number of eosinophilic infiltrates, not the lymphocytic.
Any correlation with CD4 count or IgE?
IgE levels were increased.
I think time is over, so we can switch to next candidate.
Thank you so much.
Next is G7, Dr. Kaichu.
Good evening, sir.
Please share your screen.
Hello.
Dr. Kaichun, you are not
Yes, sir.
audible.
Good evening, sir.
Good evening.
Am I audible, sir?
Yes, you are audible.
Sir, can you see the screen, sir, that I have shared?
Yeah.
Good evening, sir. I'm Dr. Kaichan, third year PG resident from SMS Medical College, and I'll be presenting a case report on persistent Mullerian duct syndrome, which was managed laparoscopically. Persistent Mullerian duct syndrome is a male pseudohermaphroditism, which was characterized by persistent Mullerian derivatives in a phenotypically and genotypically normal male, such as rudimentary uterus, fallopian tubes, and upper portion of vagina. The patients usually have a 46XY karyotype with normal male external genitalia, virilization, and internal Mullerian duct structures. There are approximately 200 cases documented globally. Case report. I'm presenting a case of 25 years of male, which was presented in surgery OPD for primary infertility. On examination, he had normal secondary sexual characteristics with normal pattern of external genitalia, with normal penis and scrotal sac, with bilateral cryptorchidism. We did ultrasonography for this patient, and he had a bilateral testis which was situated in intra-abdominal cavity with an elongated structure which was present posterior to urinary bladder. We also did a magnetic resonance imaging, and he had a bilateral cryptorchidism. There was left testis of size 36 into 20 millimeter and 24 into 10 millimeter size of right testis. And the left testis was showing malignant changes in MRI. And there was also a blind ending tubular muscular structure of size 86 into 16 mm in the pelvis on the right side of urinary bladder. We did markers, serum alpha fetoprotein, beta HCG, they were all within normal limit with mildly raised serum LDH. His semen analysis showed azoospermia. So we decided to undergo diagnostic laparoscopy and proceed. The picture here shows the picture from diagnostic laparoscopy. Here we can see both the testis, which was attached to the rudimentary uterus through a elongated structure, which is fallopian tubes. So we decided to do a left orchidectomy due to malignant changes, signs of malignant changes in MRI. And we did right orchidopexy. We took out right testis in the inguinal region for further examination for any malignant changes in the future. And we removed the entire Mullerian remnants, like rudimentary uterus and fallopian tubes. And in the histopathology of the left orchidectomy, the specimen shows features of classic seminoma. And discussions. Persistent Mullerian duct syndrome is a rare form of male pseudohermaphroditism, which is characterized by presence of Mullerian duct derivatives such as underdeveloped uterus, fallopian tubes, upper vagina in a phenotypically and genotypically normal male. It is a familial syndrome of autosomal recessive mode of inheritance. And this syndrome is caused either by insufficient amount of Mullerian inhibiting factor, which is usually produced by Sertoli cells, or it can also be due to insensitivity to the target organ to Mullerian inhibiting factors. Persistent Mullerian duct syndrome, it is further classified into 3 types. Number 1, the uteri-inguinal type, in which a testis is present in the harnal sac or the scrotum, and the opposite contralateral testis is present inside the abdominal cavity. And the transverse testicular ectopic, in this type, both the testes are present in the same harnal sac, along with the uterus and the fallopian tubes. Here, the entire structure is pulled to one side of the patient. And the third type, which is also the type that I am presenting here, which is female type. In these cases, the bilateral testis and epididymis are connected to the fallopian tubes in the intra-abdominal cavity. Ultrasonography and magnetic resonant imaging are important diagnostic tools to diagnose this type of conditions. But laparoscopy offers distinctive advantage in both being diagnostic and therapeutic, along with its minimal invasive nature. Though some advise retaining these structure due to risk of jeopardizing blood supply and integrity of vas deferens. Nevertheless, removal of these Mullerian remnants must be done wherever possible due to the risk of further development of Mullerian malignancy in the future. And literature records about 10% of Mullerian remnants develop into malignancy in the future. Conclusion. Persistent Mullerian duct syndrome is a rare entity that may be presented as infertility or undescended testis, or encountered incidentally during other abdominal surgeries. Although ultrasonography and magnetic resonant imaging have important role in diagnosis, laparoscopy has a distinctive advantage in being diagnostic and therapeutic, along with its minimally invasive nature and familiarity of the operating surgeon with this kind of condition would thus increase chances of proper diagnosis and management, and it prevents future development of malignancy. Thank you. Thank you, sir.
What is the incidence of this syndrome?
According to the literature, I quoted it around 2,000 cases have documented globally, sir. 200 cases.
And what are the late complications if not treated in time then?
Sir, it can be divided to due to cryptorchidism, the testis in the intra-abdominal cavity can develop into malignancy. Here in this case, we find a classic case of seminoma, and due to the persistent Mullerian derivatives, it can also develop into malignancies like adenocarcinoma of the uterus.
In all cases, cryptorchidism is present?
It depends on types, sir. In the female type that we have presented, both the testis is present in an intra-abdominal cavity, and the other ones, one side of the testis can be inside the scrotum, and the other one can be cryptorchidism.
Okay, Dr. Siddharth.
In some cases, you have fallopian tubes also coming there.
Yes, sir.
What challenges you faced doing the scape laparoscopically? Particularly when you have to keep in mind, you have to not to injure vas deferens.
Yes, sir. When we try to pull out we try to do orchidopexy. We have to pull that the testis outside the intra-abdominal cavity. That time the structure is pulled and the vascularity might be compromised.
Okay. What was the age of this patient? Was it?
The patient is 24 years old, sir.
24 years. By any chance, did he have any hematuria?
Hematuria, the patient didn't complain of any hematuria. His main complaint was unable to conceive, get his wife pregnant after marriage of 2 years.
Okay, fine.
Okay, next person.
Okay.
Thank you, sir.
Next is G8, Dr. Lavina.
Good evening, sir.
Yeah, please share your screen.
Good evening.
Good evening, everyone. Myself, Dr. Lavina Balani from JLN Medical College and Hospital Ajmer. I'm going to present a paper on a prospective study for predicting the outcome of patient of perforation peritonitis using Apache 2 score. Introduction: peritonitis is defined as inflammation of serosal membrane that lines the abdominal cavity and the organs contained therein. Currently, peritonitis is organized into three divisions based upon the source and nature of the microbial contamination. Primary peritonitis is an infection without any visceral perforation. Secondary peritonitis follows an intraperitoneal source, usually from perforation of hollow viscus, which is most common type of peritonitis all over the world. Tertiary peritonitis develops following treatment failure of secondary peritonitis. Secondary peritonitis usually presents as acute generalized peritonitis, which is potentially life-threatening condition. It is a common surgical emergency in most of the general surgical units in all over the world. It is often associated with significant morbidity and mortality. Grading the severity of acute peritonitis has assisted in decision making and has improved therapy in management of severely ill patients. Many scoring systems have been found useful in predicting the outcome in critically ill patients, thus allowing application of resources for effective use. Amongst them, we have considered Apache 2 scoring system for prediction of mortality risk in patients with peritonitis due to hollow viscous perforation. Apache 2 has three parts. First is acute physiological score, which consists of 11 physiological variables, that is temperature, mean arterial pressure, heart rate, respiratory rate, arterial oxygen, arterial pH, serum sodium, serum potassium, serum creatinine, hematocrit, WBC count, and Glasgow Coma Scale. Scores for each variable rank from 0 to 4 except for serum creatinine, which has score range of 0 to 8. Glasgow Coma Scale scores ranges from 0 to 12. Thus, total APS range is from 0 to 60. Second is age score, which range from 0 to 6. And third is chronic health status score, which range from 0 to 5. Total Apache 2 score is sum of above three parts. It ranges from minimum 0 to maximum score of 71. Apache 2 provides a pre-treatment estimate of risk which is appropriate for stratification of patient. Aims to estimate the severity of intra-abdominal sepsis and mortality risk in cases of perforation peritonitis by Apache 2 scoring. To study age and sex incidence of perforation peritonitis, to study association of mortality with clinical presentation of the patient, to study incidence of peritonitis and risk of mortality according to site of perforation, to study duration of hospital stay and its relation with Apache 2 score, and last is study of post-operative complication. Methods. A prospective study of 50 patients was done in JLN Hospital Ajmer, presenting with features
Dr.
suggesting
Lavina, quickly, you have taken too much time.
yes, sir.
Quickly.
Suggesting of perforation peritonitis from June 2019 to May 2020. Sampling method, patients presenting to the hospital with features of perforation peritonitis after considering the inclusion criteria, which is patient with features of peritonitis due to hollow viscous perforation and patient more than 16 years. And exclusion criteria are patient less than 16 years, primary and tertiary peritonitis, traumatic perforation, peritonitis due to ruptured liver abscess or appendicular abscess. Data was collected by meticulous history taking, careful clinical examination, appropriate radiological and routine pathological investigation, operative finding and follow-up of cases. On admission, all the parameters to calculate the acute physiological score, age score, chronic health score were recorded, and then Apache 2 score was calculated by adding all the points of the parameters mentioned earlier. Data was analyzed using parametric and non-parametric tests based on the distribution of values obtained. Result. Patient with score between 0 to 5 had 5.8% mortality as compared to 100% mortality above score of 15. Mean score of those who survived was 6.5 as compared to 15.06 in those who died. Most of the patients were in age group 36 to 65 years. 46 of our patients were males. Mortality rate were higher in those in second and third decade of life and those who were more than 60 years. Mortality increased as we go down the gastrointestinal tract. Ileal perforation showed 44.4% mortality as compared to 14.2% in gastric perforation. Pain and vomiting were most common presenting symptom. Patient with score 0 to 5 had average hospital stay of 12.6 as compared to 20.6 days for those with score between 6 to 10. About 64% of patients had post-operative complication. Most common were respiratory complication and fever. Conclusion. Apache 2 score had performed well and thus reliable objective scoring test for prediction of outcome. It can be used for assessing severity of sepsis in patients with perforation peritonitis so that intensive treatment can be given to high-risk patients in a hospital with limited resources. In Indian setup, because of prevalent malnutrition and patients reporting late due to socio-economic reasons, the disease process itself has worse course than their counterparts in Western world. If some parameters or variables with appropriate weightage for malnutrition could be included in scoring system, taking in view rural Indian population, perhaps we could come up with better scoring model. Thank you, sir.
What is the aim of the scoring system? Ultimately, your hollow viscous perforation, you are operating all the patients, or maybe you are putting some brain in case if he is seriously sick. But what is the ultimate aim?
So we can decide, we can predict the mortality or morbidity rate of the patient pre-operatively or at the time of admission only.
Do you feel all these scoring systems fulfill all the expectations you have?
No, sir, every scoring system has some drawbacks.
Do you feel combination of scores will give you a better outcome, if at all?
Yes.
Lavina, do you have any idea about this Kawasaki's rule for PowerPoint presentation? Kawasaki rule क्या होता है?
Sorry, sir. I have not.
Please go and do read. It will give a new message to you and head to your presentation styles. So do read Kawasaki's rule of PowerPoint presentation. Okay.
Okay, sir.
Okay, thank you, Dr. Lavina.
Thank you.
One Dr. Divya Khator is ready now to present G5. Dr. Divya.
Yes, sir.
Please share your screen.
Sir, is this slide visible?
Yes, please.
Yes, visible.
Good evening, everyone. I am Dr. Divya Khator, General Surgery resident from SMS Medical College, Jaipur. I am presenting a case report on primary adrenal histoplasmosis in an immunocompetent person. Histoplasmosis is a fungal infection caused by a dimorphic saprophytic fungus. Histoplasmosis is an uncommon opportunistic infection in the general population, and it is more prevalent in the immunocompromised patients. When it is inhaled by humans or animals, then it produces the yeast phase, which has an affinity for the macrophages that compromise the reticuloendothelial system. Inhalation of Histoplasma capsulatum produces a lung infection with widely varying symptoms. On the other hand, in some predisposed individuals, it may cause chronic pulmonary disease or a disseminated disease. Disseminated histoplasmosis infrequently affects the adrenal gland. However, unilateral involvement in an immunosuppressed patient is the usual presentation. The case report of a 56-year-old male resident of Jaipur, Rajasthan. He presented with complaints of weight loss, decreased appetite, and malaise for the past 6 months, which was not associated with fever or hemoptysis. He had mild dyspnea, no chest discomfort or cough, or night sweats or fever or any other infective symptoms. He was normotensive, non diabetic, immunocompetent, no history of cigarette smoking or alcohol intake, and not taking any prescription medications or any drugs. He had no significant past medical history. He was a shopkeeper by profession. He was not involved in any kind of field work. On examination, his BMI was 23.86. His supine blood pressure was 122 by 78. He was not febrile, not tachycardia, no tachypnea, and oxygen saturation was normal on room air. He had no palpable lymphadenopathy. An examination of cardiovascular and respiratory system was unremarkable. On the investigations, his serum cortisol level was 30. The normal level is 133 to 537, and ACTH was 187.9, which was consistent with primary adrenal insufficiency. The 24-hour urine metanephrine level was within normal limits, and it ruled out the possibility of a pheochromocytoma. Serum sodium of 139, potassium of 4.1. The patient's leukocyte count, differential leukocyte count, liver function test, and renal function test were within normal limits. The HbA1c was 5.1. Chest X-ray and urine microscopy were normal. PSA, CEA, and CA19-9 assays were normal, as were the serum immunoglobulin levels. Blood culture was negative for bacterial and fungal growth. Abdominal ultrasound revealed bilateral heterogeneous hypoechoic adrenal masses measuring 5.4 into 5 into 4.5 centimeter on the right side and 5.6 into 3.5 into 3.8 centimeter on the left side. Abdominal CT showed as the only finding bilateral adrenal masses with central hypodense areas and minimal peripheral enhancement, suspicious for metastasis, but there was no other evidence of malignancy, adenopathy, or hepatosplenomegaly. On contrast, chest X-ray revealed no abnormalities. Chest tomography revealed no abnormalities. C2 thorax was also suggestive of peripheral atelectasis in the left lower lobe, and the rest of the bilateral lung field appears normal. Anticipating image-guided needle biopsy, pheochromocytoma was ruled out on the basis of absence of hypertensive spells and normal urine metanephrines. Given a negative imaging workup for malignant disease, we attempted an ultrasound-guided biopsy of the adrenal glands for further characterization of the patient's bilateral adrenal masses, but the adrenal biopsy was not successful. Grossly, the material was necrotic and hemorrhagic, and it was inconsistent with culture. As patient was symptomatic and pheochromocytoma was ruled out, therefore patient was planned for bilateral adrenalectomy. On the intraoperative findings, with anterior approach for open adrenalectomy, midline laparotomy incision was given and the abdomen was opened in layers. The right side was assessed. Hepatic flexure of the colon was taken down inferiorly. The liver was retracted superiorly, and Cocker's maneuver was performed, and exposure of the retroperitoneal space was done. The gyrotose fascia was identified and incised. Once the adrenal gland was exposed, lateral and superior aspect of the gland were mobilized and adrenal vein was ligated and divided. The size of the right adrenal was 6.5 into 5.5 into 3 centimeters. Similarly, the left adrenal was exposed by medial visceral rotation of the stomach, spleen, splenic flexure of colon, and pancreas towards the midline, and the left adrenal vein was ligated and divided. Left adrenal size was 5.4 into 4.5 into 2 centimeters. Both adrenal glands were taken out as a specimen and it was sent for histopathological examination, which came out to be bilateral adrenal histoplasmosis. Discussion. A patient presented with primary adrenal insufficiency, most likely secondary to bilateral adrenal histoplasmosis, which is a rare presentation in an immunocompetent host. Irrespective of a patient's immune status, disseminated histoplasmosis develops when the primary infection at the site of inhalation undergoes lymphatogenous spread to the solid organs. This case emphasizes the fact that adrenal histoplasmosis does occur in the immunocompetent patients, and it has to be considered in the differential diagnosis of bilateral adrenal masses. Adrenal insufficiency has to be monitored, and antifungal therapy should be maintained for at least 1 year. The differential diagnosis of adrenal histoplasmosis can include a bilateral primary adrenal malignancy, tuberculosis, adrenal blastomycosis, adrenal coccidioidomycosis. In a country like India, where tuberculosis is very common, it is often misdiagnosed as tuberculosis and the patient is put on an anti-tubercular therapy. Immunocompetent patients may also present with adrenal histoplasmosis. Thank you.
Dr. Divya?
Yes, sir.
When you said that you suspected adrenal metastasis, so in a case of adrenal metastasis, what is the most common site of primary? So in a case of adrenal metastasis, what is the most common site of primary malignancy?
Sir, breast.
Okay, it's something else. No issues. So you have removed both adrenals in this patient. So how you have managed post-operatively?
Sir, post-operatively, the patient was put on steroid therapy and antifungal treatment was started for managing the systemic disease if any occult systemic disease was present.
What kind of steroids and any dosing, you know? What kind of steroid therapy you have given post-operatively? Is it lifelong or short-term therapy?
Sir, long-term therapy in divided doses.
So what is the dose of the drug? What is the drug?
Sir, prednisolone.
Okay, all from my side, sir. From our side.
No, okay. Thank you, Dr. Divya.
So, sir, we are going to next session. And the judges are Dr. R.S. Meena, sir, Dr. Ellen Meena, sir, Dr. Ramkaran Chaudhary, sir, and Dr. Ashok Lunia, sir. And the first presenter, number H1, Dr. Mehak.
Hello. Hello.
Sir.
Hello. Rupesh ji.
Yes, sir, please.
Please request to Sham sir and Parmar sir, Dr. Siddharth and all the judges, please send the score sheet on the same group. So we can make result also.
Which is the group, Dr. Bhawan, which is the group?
E group. Sir, that is the G group.
You have made this thing. Any WhatsApp group you have made?
So group already made. It's your session.
Rupesh ji.
Yes, ma'am.
There is no group for the first session.
There was no group. That's why I'm asking.
There is no group for the first session.
Okay, let me check.
Either you form a group or like you.
Sir, actually they formed, but they missed for your session.
Okay, I'll check. I'll check, please.
That is why.
Okay.
Okay, sir. I have a query. Bound boss. I was communicated about this G group on my WhatsApp group. So should I continue with the next session or should I quit?
You
No sir,
continue.
you are in H group, not G group.
मेरे को तो जी की डिटेल आई हुई है कुछ ऐसी लग रहा है.
नहीं सर, H में है.
Okay, I am continuing. Okay, now
you continue.
Okay, madam.
Yes.
Good evening, sir. Good evening, teachers. Can I start?
Yes.
Am I audible, sir?
You are audible. You can start.
Thank you so much. Good evening, everyone. My name is Mehak Sipani and I am a third-year resident, general surgery resident at Sardar Patel Medical College, Bikaner. I am going to be presenting a case series of transverse testicular ectopia, which were observed in the pediatric surgery department. May I start?
You continue.
Yes. For background and aims, transverse testicular ectopia is a rare congenital anomaly where both the gonads migrate towards the same hemiscrotum. Embryologically, several theories regarding the origin of transverse testicular ectopia have been suggested, including adhesion and fusion of the developing Wolffian canals, aberrant gubernaculum, testicular adhesions, defective formation of the internal inguinal ring, and traction on the testis by the persistent Mullerian structures. Associated abnormalities may include persistent Mullerian duct syndrome, true hermaphroditism, inguinal hernia, hypospadiasis, pseudo-hermaphroditism, and scrotal anomalies. At any one of the developmental stages of the testis, anomalies occur, which results to problems after birth. So, according to the literature, at about 100 to 150 cases have been reported about transverse testicular ectopia. And we have observed 5 cases in our department in the last 5 years. The ectopic testis may lie in the opposite hemiscrotum in the inguinal canal or at the deep inguinal ring. It can also lie in inguinal hernia, and inguinal hernia is invariably present on the side where there is ectopic or undescended testis. Also, this study, we want to emphasize that we should avoid the excessive dissection during surgical management of transverse testicular ectopy solely to gain length of transeptal orchidopexy. Instead of doing that, we can place this testis in the contralateral hemiscrotum such that both the testes are in one hemiscrotum, or we can leave it in the inguinal canal. Proceedingly, the aim of this study is to emphasize the need of ultrasonography in cases of inguinoscrotal swellings. Now, this is especially in pediatric age group, but could apply to adult as well if they present with inguinal hernia with udity, which is contralateral udity and inguinal hernia. To keep this, and also we should keep this entity in mind and its management while operating upon such cases. All the cases in the age group are in the age group of 3 months to 4 years, out of which 4 were diagnosed preoperatively by clinical examination and ultrasonography. 2 of these 4 cases presented with inguinoscrotal swellings and the contralateral undescended testis. And the other 2 presented with absence of testis in the scrotum. One is in the abscess cavity on exploration. This is a chart which shows details of the 5 cases which we observed in the last 5 years. So we have one case, which is a 3-year-old boy, which had cryptorchidism. The testes were in right inguinal canal in USG. We did a transeptal orchidopexy with herniatomy, and the follow-up was uneventful. Similarly, we had cases B, C, and D. In B, the patient had large inguinoscrotal hernia with left undescended testis. We did ultrasonography and found both the testes on the right side. We did transeptal orchidopexy with herniatomy, and follow-up was uneventful. D and C, out of which D was a 4-year-old boy with bilateral undescended testis, and the procedure was done transeptal orchidopexy with herniatomy, and the recovery was also uneventful. But contrastingly, in a boy who was 9 months old, he had a left hemiscrotal abscess, so we could not take the patient for USG or clinical examination because of the pain. and the patient was febrile. So we went in for exploration. On exploration, there was drainage of pus around 50 ml, followed by honiotomy and transeptal orchidopexy. Unfortunately, in a follow-up period, we had wound sepsis, but it was managed successfully with wound dressing. So these are a few pictures from the 5 cases which we observed. Figure 1 and figure 2 is the case of patient which is showing right inguinal hernia with left undescended testis. We can see that the scrotum is properly developed, and we can also see that on the right side there is inguinal hernia. On exploration in such patient in inguinal approach, we found that both the testes were lying on the right side in the right inguinal region, and a right inguinal hernia was also observed. So we did honiotomy. We did through the septum, we placed the left testis in the left hemiscrotum and the right one in the right. And fortunately, we didn't have to indulge into extensive dissection because adequate length was already present. Figure 3 is the patient who had the left-sided scrotal abscess. And in that case, as we explored, we found both the testes in the left side, and then we did transeptal orchidopexy. All the 5 cases were operated upon with honiotomy and transeptal orchidopexy and discharged successfully. All the patients were uneventful in the follow-up period, except one who presented with wound sepsis and was managed with dressings. We attempted to not indulge into extensive dissection and were able to achieve adequate length for transeptal orchidopexy. To conclude, I would say that transverse testicular ectopia is a rare anomaly, and its pathogenesis still remains unclear, which means an embryologically and anatomically correct management cannot be definitely defined. So any surgeon who's operating upon inguinal hernias and UDTs should be aware of this condition and its management. We suggest that all the cases of inguinal swellings and UDTs should at least be subjected to ultrasonography. Often, we do not find the testis to be in the inguinal region or palpable. In that case, we should first resort to MRI and subsequently to diagnostic laparoscopy, which can help us in locating the undescended testis, and also will help us to further manage the orchidopexy. We also observed that sufficient length can usually be achieved without extensive mobilization for a tension-free transeptal orchidopexy in most of the cases. Thank you.
Okay, Mahek,
yes,
in your series, did you find any difficulty in the post-operative follow-up in these patients in comparison to the normal patients who have unilateral undescended testes? Any particular?
Yes, sir. No, sir. In particular, we couldn't find, there wasn't any special difficulty or any problem to the patient, except for one patient who had abscess. Otherwise, the patient recovered as usual. They didn't have any such issues other than what a post-operative child has of pain, but not specifically anything.
So did you do MRI in any of your cases?
So actually, in our setup, as we first usually go for USG, so we went for USG and we were able to locate in all the cases except for one. We were able to locate the testis in inguinal region in the canal or in the scrotum, and hence we didn't have to go for MRI.
Other examiners, please, can ask questions.
Hello, Mahek.
Yes, sir.
Hello.
Good evening, sir.
Mahek. Good evening. How many long is the follow-up period for these patients?
So we try to follow up the patient for at least for a year, but as the patients come from rural environment, so there are a lot of defaulters. But yeah, we were able to follow up a few of the patients for 6 months, and the patients were quite well.
Well.
Yes, sir.
Okay. Thank you.
Thank you, sir. Yes, sir. Good evening, sir.
Okay, good evening.
Sir, I'm sorry, I'm not able to hear.
Hello.
Yes, sir. Yes, sir. Good evening, sir.
Good evening. In the scrotal abscess patient,
yes, sir.
How can you justify dent herniatomy along with orchidopexy done at the same time?
Sir, because we did a good irrigation and debridement, so that's why we attempted transeptal orchidopexy. But we could wait if if it was very contaminated. But then we were able to attempt it because the debridement was done enough.
Any major post-operative complication?
So, in particularly in in the patient which were observed. I'm sorry, sir. In the patient observed, in only in this patient we had sepsis, and that wasn't we didn't have frank pus. There was just a little bit of sepsis. There was wound gaping actually. So we managed it with dressing, and it recovered in around 10-15 days. So we didn't have that much of any major complications post-operatively. Otherwise, there could be if we do indulge with extensive dissection, there could be a trauma to the vessels, and there could be for atrophy and further damage to the testes, or there could be a constant pain in the scrotal region. But as such, we did not have any complications post-operative.
Okay, thank you.
Thank you, sir.
Next presentation, H2, Dr. Meenakshi.
Hello, am I audible?
Yes, please.
Good evening, everyone. Today, my topic is intratumor heterogeneity.
Slideshow.
Sorry, pardon, sir, pardon. Good evening, everyone. Today's topic is intratumor heterogeneity in carcinoma breast, a rare case report. Introduction. The breast carcinoma is a heterogeneous disease and differs greatly among different patients. That is intratumor heterogeneity, and even within each individual tumor, that is intratumor heterogeneity. Breast cancer is characterized by a remarkable degree of morphological and molecular heterogeneity, not only between tumors but also among the same tumor. Intratumor heterogeneity occurs at morphological, genomic, transcriptomic, and proteomic levels, creating diagnostic and therapeutic challenges. Intratumor heterogeneity denotes the coexistence of subpopulation of cancer cells that differ in their genetic, phenotypic, and behavioral characteristics within a given primary tumor, and between a given primary tumor and its metastasis. This diversity can be attributed to genetic and epigenetic factors and to non-hereditary mechanisms such as adaptive responses or fluctuation in signaling pathway. Receptor status such as ER, PR, and HER2/neu of breast tumor cells is an important and established measure used in therapeutic decision making, as the receptors are both targets for the treatment as well as prognostic indicators. My case was a 65-year-old female from Junjunu, Rajasthan, presented with a lump in left breast along with an ulcerative lesion past 4 to 5 months. Initially, the lump was small in size, which gradually increased in size over 3 months and was associated with ulcerative lesion in inframammary fold. Patient is menopausal and had given birth to 3 children, whom she had breastfed for 14 to 16 months each. She had no history of previous medical problems and no previous surgery. She had no family history of malignancy. She had not taken any oral contraceptives or hormone receptor therapy. On physical examination, there was 6 into 4 into 2 centimeter mass in upper inner quadrant of left breast, not fixed to skin or chest wall, with ulcerative lesion of around 3 into 2 centimeter in inframammary fold with margins rolled up. Lesion was bleeds on touch and has no palpable axillary or supraclavicular lymphadenopathy. The clinical stage was T4B, N0, and M0. There was no tethering of skin or pudgy or age, and contralateral breast and axilla were normal. Core-needle biopsy was suggestive of infiltrating ductal carcinoma. The patient had underwent left modified radical mastectomy with axillary lymph node dissection up to level 3. Histological findings were suggestive of infiltrating ductal carcinoma, not otherwise specified, with focal signet ring cell differentiation of approximately 20%. Histological grade was 2nd, and the Bloom-Richardson score was 7. 2 tumor focality were present in upper and inner quadrant, and a smaller one in axillary tail having a similar histological grade. Lymphomuscular invasion was present with tumor ulcerating overlying epidermis. All lymph nodes were free of metastatic deposits, 0 out of 10. Pathological histological classification was pathological stage T4B, N0, and MX. On performing IHC marker study, markers for larger tumor in upper inner quadrant were suggestive of ER negative, PR negative, and HER2 negative. The larger tumor was triple negative. The markers for smaller tumor in axillary tail were suggestive of ER positive, PR positive, and HER2 negative. Conclusion: all patients presented with molecular heterogeneity within a tumor cell, which is a rare presentation, and chemotherapy regimen has to be planned accordingly. Significant intratumor genetic heterogeneity is likely to limit the efficacy of target therapies even prior to the acquisition of drug resistance. There is a new challenge with the intratumor heterogeneity that makes a particular tumor an assembly of a variety of subpopulation of cells surrounded by an interacting microenvironment. All these factors complicate the diagnosis, therapy selection, and subsequent response. Therefore, it becomes crucial to understand all the basic facets of tumor biology, genetic mutation, and epigenetic changes considered together for a new approach to cancer therapies and for their role in treatment resistance. This heterogeneity is dynamic and evolves unpredictably during disease progression, creating significant challenges for modern chemotherapeutics. The extent of heterogeneity in breast cancer will likely necessitate a paradigm shift from standard pathological classification of breast carcinoma to a more personalized approach in which heterogeneity is thoroughly characterized prior to treatment. Advancements done in intratumor heterogeneity. Recently, intratumor heterogeneity has been recognized as one of the mechanisms of tumor resistance. Chemotherapy resistance represents the main drawback in response to effective therapy outcome. There are two types of resistance, intrinsic and acquired. The first is the natural ability of cancer cells to evade the therapy, and acquired resistance refers to tumor cells that initially are sensitive to a given drug, but after some time becomes desensitized. Novel intratumor sampling techniques such as analysis of circulating tumor cells or circulating tumor DNA may allow a more comprehensive analysis of the clonal composition of breast cancer, provided that cancer cells are shed into circulation proportional to their clonal frequency in the primary. Circulating tumor cells show a considerable intrapatient heterogeneity, which may reflect the temporal evolution of tumor cells, subclones, over time, or an expansion of treatment-resistant cells that escape the systemic therapy effects. It has been suggested that circulating tumor cells might provide a more biological and clinical description of heterogeneity of the entire tumor burden within a particular patient. As circulating tumor cells and circulating cell-free plasma DNA are likely to originate from tumor cells and thus correlate with disease burden and blood biomarkers, may serve as a surrogate for spatial heterogeneity and marker for temporal heterogeneity. The accurate detection and molecular profiling of CTC remains obstacle to using CTC as a surrogate for heterogeneity. In particular, most important circulating tumor cells capture method, cell search, relies on the detection of surface epithelial markers, EPCAM. Ideally, intratumor heterogeneity should be assessed by sequencing technologies and diagnosis for each patient, followed by monitoring of clonal dynamics during disease progression and treatment. This allows for the identification of genetic changes, driving resistance, as well as therapy adjustments. Potential strategy to overcome treatment resistance include targeting driver mutation and deleterious passenger mutation, modulating the tumor microenvironment, and immunotherapy. The ability to perform massively parallel sequencing on DNA and RNA material extracted from formalin-fixed paraffin-embedded tissue will greatly increase the availability of material amenable to characterization of tumor heterogeneity. Currently, targeted sequencing using capture panels for DNA required for formalin-fixed paraffin-embedded samples allows the detection of clonal and subclonal mutation, while the technology is improving such that routine whole genome sequencing will be soon possible. Thank you.
Hello.
Yeah, sir. Good evening, sir.
Good evening. Dr. Meenakshi, can a benign tumor be a heterogeneous?
Benign tumor can be heterogeneous, sir. Yeah. Fibroadenoma can present as an heterogeneous mass, or even phyllodes tumor can present in a heterogeneous mass.
What are the most aggressive form of breast cancers?
So inflammatory breast carcinoma is the most aggressive form, T4D.
Okay. Which type of breast cancers has the best prognosis?
So ductal carcinomas have good prognosis, and tubular carcinoma among them is have very good prognosis.
Okay.
Thank you, sir.
Next.
Dr. Meenakshi, sir,
Good evening, sir.
Dr. Meenakshi.
Yes, sir.
Your marker study, did you get your marker study only post-operatively after doing a MRM, or did you have that marker study pre-operatively?
Sir, no, we haven't done marker study pre-operatively. If we are
So what is the routine? If you have a breast lump, you think it to be a malignant one, you do a triplet biopsy. So what is the routine at your setup? Do you routinely do a pre-op marker study always, or you always do it post-operatively after major surgery?
Sir, if we are planning to give a neoadjuvant chemotherapy in a case of advanced malignancy, then we go for marker study. Otherwise, we just take a tissue sample for the malignancy to prove malignancy, and rest the marker study is done after the specimen has been taken out.
Okay, my last question.
Yes, sir.
When you do a HER2/neu, you have a patient who has 1+, the second plus is 2+, the third patient is 3+.
Yes, sir.
So what will be your further plan?
So 1+ will be considered as a negative. If 2+ is equivocal, then we will go for fish. We will go for fish. If fish comes out to be more than 22%, then it will be considered as positive. And if it is less than 22%, then it will be negative. It will be considered negative. And 3+ and 4+ are always considered as a positive marker, HER2 positive.
Okay.
So we will start with
okay. Or from my side. Or from my side.
Thank you, sir. Thank you.
Next participant.
Thank you, sir.
Next is H3, Dr. Milan Kumar Khatri.
Yes, sir.
Please share your
Am I
screen.
audible to?
Yes.
Yeah, yes.
So, my screen is visible to all of you?
Please, no.
No.
1 second, sir. Now, sir?
No.
No.
1 second, sir.
Sir, can I call next one, please?
Meanwhile, you can go for next one.
Sir, so now visible?
Yes, please.
Yes.
Okay. Good evening, everyone. I'm Dr. Milan Khatri from SMS Medical College. I'm going to present a case report on the youngest person to have. Am I audible?
Yeah, audible.
Okay. Okay. I'm going to present a case report on the youngest person who have undergone laparoscopic cystectomy and exploration. That is in Guinness Book of World Record now. And introduction, the gallstones in the infants under 1 year of age are very uncommon. And the majority of these infants stay asymptomatic and are diagnosed on the routine abdominal ultrasound. And eventually, most of them resolve spontaneously. The risk factor for gallstones in the infants are prematurity, previous bowel or cardiac surgery, hemolytic disorders, infections, total parental nutrition. However, some reported cases had no identifiable risk factors. And the clinical presentation for these patients are, patient may present as a jaundice, clay-colored stool, irritability and poor feeding. In addition, some cases may develop complications such as the cholecystitis and the cholangitis. And for the management, at present, there is no gold standard in the management of the cholelithiasis in the pediatric population. The treatment approach has become clearer in recent years. In centers where ERCP is offered, endoscopic approach for the relieving biliary tract obstruction is safe and effective and is often employed as the first option. Likewise, laparoscopic common bile duct exploration has also proven to be safe and effective. And inappropriate alternative, and especially in the location where pediatric ERCP is not available. As in adults, laparoscopic cholecystectomy for the biliary stone disease in children is well accepted as standard of care. So here we describe a case of the 7-month-old female infant treated with the laparoscopic polycystectomy and successful trial of the laparoscopic CVD exploration. So case report is a 7-month-old term female went to the emergency department of the SM hospital on September 12, 2019 with complaint of the abdominal pain, fever, vomiting, and she was also irritable and had in trouble crying and refused to take feed. So there was no history of jaundice in the neonatal period, any phototherapy, there was no history of any blood transfusion in the past. The birth history of the child was delivered vaginally at the term with weight of 2,600 grams. And she was the first child for the family. And she had normal weight to age, and the neonatal weight was normal. And the past history, there was no history of blood transfusion or surgeries in the past. And there was no family history of gallstone disease or any known hereditary disorder in the family. On the examination, the patient was irritable, febrile, and active. The patient was vitally stable. There was no pallor or icterus. On the per abdominal examination, abdomen was soft and mildly distended with localized tenderness and the gardening over the right hypochondrium region, with no other significant findings on the examination. Initial laboratory investigation shows the liver enzyme like alkaline phosphatase was 275, GG was 510, OTPT was 40 and 68, and the bilirubin was 2.0. The TLC was 22,000. On the radiological investigation, USG shows contracted GB with the IHRD and the CVD was prominent with size of the 4 mm. And on the MRC,
Hello. Hello.
Hello. Yes, sir.
What happened?
Presentation of.
Presentation of okay.
We have lost this connection with Dr. Milan. Somebody
Actually,
else is
he's presenting from mobile now. That's why.
Oh.
hello.
Yes, please.
So somebody,
yes.
so somebody else started presenting actually. My get off. Hello.
Yes, please continue.
So somebody else is presenting actually. That's why
Somebody else. It's not your screen.
Busy, what is problem?
Yes,
Dr. Milan, this is yours.
Yeah, now it's okay.
So if there
now
is
it's visible.
Dr. Milan, please.
Yes, sir.
You please share your screen.
1 second, sir.
keeping time in mind because we are already late.
So now is the
Still there is problem.
on the hello. Sir, on radiological investigation, USG shows the contracted GB with IHBRD and the CBD was prominent the size of the 4 mm. And on MR, there were filling defect distal CBD, likely due to small calculus. Proximal CBD measures to 6 mm and the distal portion of CBDs were not defined. The CBD measures 2.5 mm. IHBR was not dilated significantly in MRC. So she was to the general surgery with the diagnosis of the cholestasis. After thorough evaluation and the inter-department discussion, symptomatic polylysis with the cholestasis was diagnosed. Along the strong clinical suspicion of GB perforation as peri-GB collection noted on the MRCP. And she was started on IV fluids and antibiotics as we already counts for 20%. period, ERCP scope was not available in our institute. So we planned for the cholecystectomy with the CBD exploration. The operating details, laparoscopic cholecystectomy was started. The omentum was adherent slit over the gallbladder. The gallbladder was extended. Wall was equus. Endotoxin dye was injected preoperatively intravenously in the CBD and hepatobiliary system was visualized, and CBD perforated proximal to the CBD zone, and the clipping of the distal and duct, and the cholecystectomy was done to the region of the CBD near duct junction, and the stone was retrieved. The CBD checked for the clearing of sternum with CBD scope, and 5 French stent was placed in the CBD, and the cholecystectomy was closed, and the placed in the subhepatic space. So antibiotic were continued in the post-operative. Significant clinical improvement was noted in the 3 days after surgery. Patient regained her activity and the started tolerating breast. And the abdominal was removed on the post-op day 3. The US whole abdomen done on the post-op day 2 showed the normal caliber of the CBD, and there was no correction noted in the abdominal pelvis, and was in situ. And the CP done on the post-op day 3 showed the CBD of normal diameter, and the stent placed the low BD extending up to the duodenum. And there was no collection of the GB fossa. Her laboratory investigation were near normal by the 5th post-operative day, and then discharged on the post-operative 5 with regular follow-up. So this was the team operated this case under the even Kangesar. He was a child, and this was a gallbladder we retrieved after the surgery. So discussion, cholelithiasis is very common in the children. And the incidence of the cholelithiasis and cholelithiasis in infants is increased, but the guidelines are still controversial because of the lack of the systemic studies. There is evidence that the infantile cholelithiasis and the cholelithiasis can spontaneously resolve. Every case is unique, and depending on the resources available at the given institution, clinical scenario, there are multiple suitable treatment options. There are currently no convincing data to support one approach or another. So starting with management, spontaneous resolution what is fully of the symptomatic cases. If a patient is symptomatic or has symptoms, it is reasonable to initiate medical management with the period of watchful waiting, and the liver function test improves. Repeat USG should be done in 48 hours to 2 weeks, and it is likely that will be resolution of the bile stone disease. And the symptomatic patient, on the other hand, usually required medical or surgical intervention. In addition, studies suggested the only reverse risk factors spontaneous resolution. Those with the irreversible risk factors previous surgery usually require the intervention. Medical management using UDCA and antibiotics, no surgical intervention is also repeated successfully. If a patient is symptomatic or medical management failed, an attempt should be made to clear the biliary tract. In scenario, ERCP has been proven to be as safe as effective in the pediatric population as in adult. And if available, you should be considered first. ERCP is not available or not feasible, then a CBD exploration by system can be undertaken. This can be done with the laparoscope or the open approach depending on surgeon's preference. However, our patient was successfully with the laparoscopic cholecystectomy and CBD exploration with no complications. Other less invasive strategies that were suggested by the patient include the radiological washing of the stones using percutaneous tube and the balloon sphincteroplasty and the ERCP. Moreover, all of these reports showed similar success rate to our case. Conclusion is cholecystectomy in infants can present with the optic jaundice and the feature of localized peritonitis due to perforation. As for medical and minimal invasive procedure, this condition can be treated successfully with the laparoscopic cholecystectomy and the CBD exploration with similar success rate and no rate of morbidity. So this was all. Yes.
Dr. Miller?
Yes, sir.
You did such a good case. There is no intraoperative photograph or video we are missing. I don't know the reason.
Sir, we have video also, but there was limitation of the slide, number of slide. I have video also, sir.
Okay, how did you manage that CBD stent you placed post-operatively?
Sir, after post-operatively, we endoscopically removed that stent.
Okay, all from my side.
Yes.
Okay, okay, thank you.
Okay. Thank you, sir.
So next is Dr. Naruttam. And please, sir, look after the time, please, time limit.
Good evening, sir. Good evening, sir. And
my
Good
colleagues.
evening.
I'm Dr. Narottam Kumar Jingonia, JR3, work in Department of General Surgery, SMS Medical College. I'm case presenting of maiden breast deformity in a case of bilateral idiopathic retroperitoneal fibrosis. Introduction. Retroperitoneal fibrosis is characterized by presence of an inflammatory process encapsulated fibrotic tissue in retroperitoneum causing compression of retroperitoneal structure including the ureter and inferior vena cava. A maiden breast deformity is a name given to appearance when there is medial deviation of both ureters. My case report is a 45-year-old male present with history of pain in both flanks for 6 months. Patient have no history of fever, no calculous disease, and urinary symptoms like burning, micturition. On localization for USG for of whole abdomen, bilateral hydronephrosis seen up to mid part of ureter. On further evaluation on CT urogram, suggestive of medial deviation of bilateral ureter due to deposition of fibroid tissue in lumbosacral junction, which was suggestive of retroperitoneal fibrosis. After medical management failure, patient underwent laparoscopic bilateral ureterolysis with intraperitoneal omental wrapping and bilateral digestion. A and B image shows on CT urogram shows medial deviation of bilateral ureter due to deposition of fibrous tissue in lumbosacral junction, and C image shows maiden breast sign of ureter. Discussion. Retroperitoneal fiber is a rare condition. In 70% of cases, cause is idiopathic called hormone disease. It can be associated with autoimmune disease like membranous glomerulonephritis and alkaline spondylitis, and large vessels vasculitis. Drugs such as methylcerizide or other ergot alkaloids, beta blocker, traumatic retroperitoneal hemorrhage, or urine leak and malignancy. Generally, retroperitoneal mass center around distal aorta at the lumbosacral junction, wrap around the ureter, causing hydronephrosis and uremia via extensing compression and interference of ureter peristalsis. Retroperitoneal fibrosis should be suspect in case of bilateral mid-ureteric obstruction in which there is medial deviation of both ureter which cause maiden breast deformity. Ureter was placed in intraperitoneum when medical treatment failed. With steroid treatment is failed. Thank you. Hello. Hello.
Okay,
Sir,
okay, you are audible now, though.
Yeah, sir.
Any indication for surgical intervention in these patients? When you surgically intervene in these patients?
When if you give steroid therapy for 2 years, so if not respond, fibrosis mass is not decrease and not improvement in size of mass, not improvement in obstruction of ureter.
Okay, or from my side, sir. Other examiners, please can ask.
Okay, ठीक है.
So, Doctor, next is Dr. Parikshit, H5.
Yes, sir. Am I audible, sir?
Yes, please
Yes,
share your
audible.
screen.
Sir, my topic is case cost benefit analysis in closure versus non-closure of peritoneum in open appendectomy. Sir, it is conventional to suture all the layers that are cut during surgery. This is indeed that every surgeon is taught and every surgeon is practicing. The The fear of increased adhesion following non-closure of peritoneum has been disproved by many studies. Much of the experience and non-closure of peritoneum in the literature come from obstetric and gynecological surgeries. The effect of post-operative pain remains controversial issue. Our hypothesis is that peritoneum has rich nerve supply and poor blood supply. Closure of peritoneum result in more pain because of ischemia produced by suturing. To test our hypothesis, we took up this randomized control study to know the effect of non-closure of peritoneum at appendectomy on the post-operative pain and analgesic requirement. Aim and objective: to assess the cost-benefit ratio in non-closure of the peritoneum at open appendectomy as compared to suture peritonealization, to treat the patients with minimal pain and in the cheapest way. Material method: the study population comprises of 50 patients who underwent open appendectomy in Mahatma Gandhi, Jaipur, selected by purposive sampling method. And the discussion: pain on VAS for peritoneal non-closure and closure patients. The mean score was taken on day 0 on non-closure patients. Pain score was around 5. On day 1, around 3, and on day 2, it was around 2. The pain score on VAS for closure of the patient, closure of peritoneum was on days 8. On day 1 was 5, and on day 2 was 3. Discussion: the main aim of the study was to treat the patient with minimal pain and in cheapest way. Mean of VAS for closure was 8, 5, and 3 on day 0, 1, and 2 respectively, and that of non-closure was 5, 3, and 2 on day 0, 1, and 2 respectively. As shown in the table, duration of the procedure and non-closure was less than in closure. Also, length of hospital stay and analgesic requirement was less in non-closure patients. Pairwise comparison with Wilcoxon signed rank test for closure and non-closure showed highly significant p-value for duration of hospital stay, analgesic requirement, and pain in post-operative period. Conclusion: in the final analysis, non-closure of peritoneum was found to be superior to closure during the open appendectomy because of short duration of the procedure, less post-operative pain, less analgesic requirement, and less number of days of hospital stay. Also, the cost was less in non-closure overall. Hence, as the conclusion of this study, non-closure of peritoneum was better than the closure of peritoneum in open appendectomy. That's it, sir.
Hello.
Yes, sir.
Hello, Dr. Parikshit.
Yes, sir.
I would like to say that Dr. Ramkaran also said that somebody said that Kawasaki rule of presentation. I would like to ask you, you also read this rule of Kawasaki to presentation. And
okay, sir.
Next thing is, what does it mean by cost? Cost means economical cost or patient compliance cost?
Sir, economic cost also, sir.
Economic
as
cost.
suture material.
Suture material. Which type of suture material would you like to use?
Sir, we use.
What is the cost of this suture material? Vicryl. Vicryl also used in the sheath and muscle.
Yes, sir.
Single vicryl. When you use a single stitch, whole vicryl is lost.
Yes, sir.
एक स्टिच लगाओ या 10 स्टिच लगाओ, व्हीकल तो पूरा लॉस हो गया.
Yes, sir.
Is there any advantage except this cost material?
Sir, for pain management, also, sir, like
it's a theoretical. It may be theoretical.
Yes, sir.
Next.
Hello.
Hello. Yes, sir.
Hello.
Yes, sir.
Parikshit, what about the post-operative complication?
Sir, there was.
Hello.
Sir, there was minimal pain in open peritoneum procedure, sir.
A later complication
Sir,
like incisional hernia, just
no, sir. There was no complication like that, sir.
how much time you follow the case?
Sir, around 2 weeks, sir. 2 to 3 weeks, sir.
Okay, over, sir. Rupesh ji, you can unmute.
Next is last, Dr. Siddesh, please.
Sir, sir. Hello.
Yeah, Dr. Siddesh, please share.
Yes, sir. Sir, good evening, sir.
Good evening.
Hello. Can I start, sir?
Start.
Sir, my presentation is on the topic, sir, a prospective randomized comparative study on the use of lignocaine with zinc with hydrocortisone combination ointment versus lignocaine with sucralfate with metronidazole combination ointment in the treatment of acute fissure in the nose, sir. And is a cut between the epithelial lining of the anal canal distal to the dentate line. Passage of fast stool is considered as the main cause of anal fissure. Anal fissure is the most common cause of severe anal pain. The mainstay of treatment in acute anal fissure is with conservative therapies, sir, like warm water sitz baths, analgesics, stool softeners, dietary modification, and with the use of ointments for local application. The aims and objectives of our study is to determine the role of two ointments in a case of acute fissure in the with respect to pain relief, healing, safety, and patient satisfaction. We have studied total of 60 cases. We have taken 60 cases. They were divided into two groups, A and B, with 30 patients in each group. The inclusion and exclusion criteria are like this. The inclusion criteria are presence of acute fissure in the patients above 18 years of age, patients who are willing to participate in the study. The exclusion criteria are patients less than 18 years of age, patient with recurrent fissure, patient with more than 6 weeks of fissure with more than 6 weeks of duration, fissure with any signs of chronicity like skin tag, sentinel pile, and patient fissure in a pregnant woman, and patient with who are previously operated for any anorectal pathology in the past, or patient with concomitant inflammatory bowel disease, or patient with comorbidities like HIV, diabetes mellitus, immunosuppression, patient who are not willing to participate in the study. In the intervention in group A, we have given lignocaine 3% with zinc 5% with hydrocortisone 0.25% combination ointment. In group B, we have prescribed lignocaine 4% with sucralfate 7% with metronidazole 1% combination ointment. Along with the supportive therapy, we have given supportive therapy high fiber diet, lactose syrup, warm water, warm sitz bath. Warm sitz bath was advised 3 times a day before the application of the ointment. Patients were followed up weekly up to 6 weeks, every weekly. Pain score was assessed using 10 centimeter visual analog scale weekly, which is given at the right side. No pain is recorded as score 0, and distressing pain is recorded as score 5, and unbearable pain is recorded as score 10. Healing of fissure assessed weekly by local examination, and asked and checked for any side effects. At the end of 6 weeks, patient satisfaction with overall treatment recorded using patient satisfaction scale, which is given below. Extremely satisfied is taken as score 5, and extremely dissatisfied is taken as 1, and dissatisfied as 2, and neither dissatisfied or dissatisfied as 3, and satisfied as 4. During the follow-up, results are like this. In the pain score, our study shows less pain score in group B compared to group A, but there is no statistical significant difference because the p-value during the follow-up is more than 0.05. But in the graph, we can see there's less pain score in the group B compared to group A. During healing was follow-up healing. Healing was better in group B during 3rd, 4th, and 5th week as compared to group A. The difference was statistically significant. Healing was seen in all the patients in group B, but in group A, out of 35 patients, that is 16.66% patient did not show healing of fissure by the end of 6th week. When we come to satisfaction, we found there was more satisfaction in patients who were given with lignocaine with sucralfate with metronidazole combination ointment as modality of therapy with p-value 0.006. The no complication seen in any patient in both the groups. Our study shows both the ointment combinations are equally safe. The conclusion, the finding of study confirms that the lignocaine with sucralfate with metronidazole combination ointment is associated with better healing, better overall patient satisfaction, and with comparable pain relief and without any complication. In a case of acute fissure in when compared to conventionally used lignocaine with zinc with hydrocortisone combination ointment, the main limitation of our study is that study was done on a small sample size. These results should be confirmed by study on the last sample size, sir. Thank you, sir.
Sudesh?
Yes, sir.
Is it your definitive treatment or palliative treatment?
Sir, it's a definitive treatment, sir. I will choose the patient, acute fissure patient, I will choose, sir, and I will divide them into groups, sir. Then I will give the treatment, sir. Initially, we will follow the conservative therapy, sir.
Okay, sir.
Siddhesh, I have a question.
Yes. Yes,
how did you randomize your patients? आपने randomize कैसे किया patient?
Sir, by chit method, sir. Randomly, I have allocated the patient by chit method, sir. Group A, Group B.
Okay. And the last question: how did you calculate a sample size when you do a randomized control study? You said your sample size was lesser. You need more studies. So how you calculate a sample size that you have adequate sample size in a randomized control study? आपकी sample size तो ज़्यादा भी हो सकती है, कम भी हो सकती है. So how did you know the proper sample size? Okay, you have to read. Okay, over from my side.
Hello.
Yes, sir.
How many patients among the how many patients you take for operative procedures among them?
Sir, totally in 5 patients in Group A, they did not show healing by the end of 6 weeks, sir. We have advised them for surgery, sir, but they didn't give consent, sir.
In second group?
Sir, in second group, all the patients were showed the healing, sir, by the end of 6 weeks, sir. In lignocaine with sulfate with metronidazole combination ointment, sir, all the patients showed the healing, sir.
Okay.
Thanks.
Okay, thank you.
Sir, PL Yadav, sir.
Sir, good evening.
Good evening.
Sir, good evening.
बोल रहे हैं सर, बताओ कोई आदेश है? हो गए सेशन?
हाँ, thank you, sir, for making the session interactive and giving your valuable time, and also thanks to Dr. Ramkaran and Dr. Lunia for giving your valuable time for this paper session. And I request all of you also that tomorrow also hold time with us, tomorrow and day after tomorrow.
ओके बस ये जो मार्किंग से कल मॉर्निंग तक हम सबमिट करें तो चलेगा?
अब भी कर दो चाहे भाई, एज यू लाइक, दैट्स नॉट इश्यू.
ओके, कल मॉर्निंग में आपको भेज दो. ओके ओके
ओके ओके, थैंक यू.
ऑन द सेम ग्रुप.
ओके ओके ओके, गुड नाइट.
ओके, गुड नाइट. थैंक यू सर, थैंक यू रामकरण, थैंक यू डॉक्टर लूनिया जी.
ओके.
डॉक्टर बीएल मैं भी हूँ
सर. पहले बोला आपको तो आप मेरे सर हो, अभी इनकी यूं थोड़ी बोलूंगा आपको मैंने कहा थैंक यू सर, फिर कहा थैंक यू रामकरण और थैंक यू डॉक्टर लूनिया जी. सर आप तो मेरे टीचर हो, टीचर का तो रिगार्ड टीचर की तरह ही होगा. हम आपके बराबर भी आ जाए तो सर आप टीचर रहोगे.
ओके
बस सर, और तो ठीक है, आप बताएं सर. सर बीच में तो मेरे
tomorrow
बिल्कुल भेज देता हूँ मैं अभी.
हाँ, यस सर.
Tomorrow main conference will start at 10:30 a.m.
यस सर, कल अपन सेशन में भी हैं.
So I am.
हाँ याद नहीं, याद है मेरे को.
हाँ यस सर. ओके सर.
हाँ याद नहीं, याद है, बिल्कुल याद है.
थैंक यू सर.